Hey, good morning, everyone. Dear colleagues, dear expert, my colleague, friend from Taiwan, Asia Pacific region, dear Professor 谢宜璋 and Professor 卢澤民, the course director. On behalf of the cardiology of Taipei VGH General Hospital, I'm very pleased to welcome all experts to ROVUS Live. I'm Dr.林彥璋from Taipei, Taiwan. So welcome to all the meeting. So we know that the coronary PCI, coronary total PCI is very difficult and very challenging in the field of the coronary intervention. As we know, the technology of coronary intervention is developing rapidly. How to use the spatial technique, new device, and new image technique to facilitate procedure will be important. And this is the main purpose of the meeting. So we know that the Taipei VGH Cardiology is an international medical research center. We have the advanced medical standard, international research staff, and multiple teams to develop the coronary intervention. This time, we are honored to assemble the experts domestically from a local hospital and the international expert for the conference. So we are honored to have the local in-hospital staff, Dr. 黄少嵩, Tsai Yi-Lin, Dr.谢正一, Tsai Chuan-Tsai, and also the image specialist, Dr.吴承学, and also the Dr. Huang. Yes, and also external expert, the 马偕医院 Dr. 蔡政廷主任 and 长庚医院Dr.林佳濱、张启任 and Dr.郑正一 and Dr. 曹店平 from 振兴 Hospital and 王启宏 from 国泰 Hospital. So during the meeting, we also honor to invite the very honored Dr. Junko Honye from the Kikuna Memorial Hospital of Japan.
Good morning, everybody.
Hi. And we are also honored to have Dr. Lim Ho from Tuanmen Hospital, Hong Kong, to join the meeting. So we really appreciate the support from the cardiac team from Taipei VGH. It's a rare opportunity during the academic. So appreciate the support from Boston Scientific. So I'm here to learn from each other and like to share experience from you. Finally, I'd like to wish you all a great, smooth meeting, successful operation, and wish you the best. Thank you. So later, I'll give my chair to Professor 谢宜璋 for the later conference. Thank you.
Thank you very much for Professor Lin's introduction, and our distinguished guest, Professor Junko Honye, and my dear colleagues and ladies and gentlemen, good morning. This is Dr. Yi-Jiang here from Chang'an Memorial Hospital, Taiwan speaking. And first, I would like to welcome all the experts and our colleagues to join this virtual meeting regarding the 2022 Taiwan ROVUS lab demonstration will be performed in Taipei VGH. Actually, I would like to express my thanks to the Taipei VGH and Chief Lin and Professor Wu to invite me to moderate the first section of this lab demonstration course. And this morning section, we will have the two cases demonstration. And the first case will be the Dr. Shao-Sung Huang to perform a complex CTO PCI. And the second case, the Dr. Tsai Yi-Lin Tsai will perform the lemon bifurcation PCI. I think both the case will be very interesting and also very informative and educative. Of course, the first case, we will move to the classroom number 3. The Dr. Yi-Lin Tsai will perform the lemon bifurcation. So, hello, Yi-Lin.
Hello.
Can you hear me?
Good morning.
Yeah.
Can you hear me?
Yes.
Everybody hear me? Okay. Good morning, Dr. Xie, Dr. Zheng, Dr. Tsai, Dr. Lin, and Chief Lin, and Dr. Honye. I'm Tsai Yi-Lin, intervention cardiologist of Taipei Veteran General Hospital. Today it's my honor to participate in this ROVUS complex live demonstration. And beside me is the Dr. Lin Shu-Xin and Dr. Lin Luojie. And we both of three will finish today's case. And Dr. Lin Shu-Xin will introduce our patient.
Okay. So today we have a patient, 63 years old lady with chest tightness and dyspnea. And she has a past medical history of diabetes mellitus. And this time she has First, she initially has the chest tightness and dyspnea and seek medical attention at the Kingman Hospital. And coronary angiography shows there's a left main lesion and triple vessel disease. Because of the complexity of the lesions, the Kingman Hospital doctors initially consult the cardiac surgeon, and they have discussed the options of surgical interventions to the patients. But the patient refused to receive surgical intervention, and she preferred to receive percutaneous coronary interventions. So she was transferred to our hospital for the coronary interventions. So next slide. And this angiography, we can appreciate there's a right coronary artery angiography, and there's a stenotic lesions at the middle segment and the distal segment. And in this angiography, we can also appreciate there's a collateral circulations to the left anterior descending artery. Okay, next slide. And in this angiography, we can appreciate there's stenotic lesions at the proximal part and the distal part of the left circumflex artery. Next slide. And in this angiography, we can appreciate there's near total occlusions of left anterior descending artery. And we can also notice there's a very heavy calcifications in the middle part of the left anterior coronary artery. Okay, next slide. And when during engagement of the left coronary artery, we notice there's a pressure damping. So in this angiography, especially in the left panel, we can appreciate there's actually a stenotic lesion in the left main ostium. Okay, next slide. So after transfer to our hospital, we have arranged a stage PCI for these patients. So in August 29, we have performed stent deployment in the distal segment and the middle segment of the right coronary artery. Next slide. So this is the final, previous slide. Okay, this is the final angiography after the PCI for RCA. So we can appreciate that the collateral circulations to the left anterior artery has become more prominent after the PCI for right coronary artery. So next slide. So today our operator is Dr. Tsai, and our target lesions is the left main ostium and left anterior descending artery.
Okay, thank you, Dr. Lin. And today we have a left main osteostenosis case with calcified LAD. But why we say it will be a left main bifurcation, because his circ proximal had nearly 50% stenosis. So I think it's a case for today's ROVUS live demonstration. And we have some progress, and we can show the today's work so far.
Yi-Lin, before you present your work, may I have some discussion with our panelists? Because in this morning section, we have a special panelist, Professor Junko Honye from Japan, the Kikuna Memorial Hospital. And we also have the Tse-Min from Taipei VGH and Dr. Cheng-Ting from Mackay Memorial Hospital, and Dr. Chia-Pin Lin from Linkou Chang'an Memorial Hospital, and Dr.郑一正 from Kaohsiung Chang'an Memorial Hospital. So in summary, this case is left main plus triple vessel disease. Of course, you had fixed the RCA lesion already. And today the focus will be on the left main. And according to the previous angiography, we can see maybe some stenosis at the ostial left main. And actually from angiography, there are some heaviness at the middle shaft of the left main. Of course, the major problem will be around the proximal middle LD. Maybe just only a very small channel or with a very severe calcify of the lesions. And of course, for the regarding the circumflex, that a branch or maybe the distal circumflex lesions. So regarding this, a very interesting and educative case. Is there any comment or any strategy regarding this this case? So anyone will go first? Chia-Pin.
Good morning. This is Cheng-Hsueh Wu speaking from Chang'an Memorial Hospital. In this case, personally, I would like to clarify our strategy, including where is the significant lesion or not, such as how about the severity of the left main ostium, and how about the severity of circumflex opening, because it's quite crucial to decide our strategy to do the left main intervention or not. Sometimes we just have some non-coaxial non-coaxial engage of the guiding catheter, even with the lemon ostium is not so stenotic, but because you don't coaxial a lot, so we have damping pressure. So I think I definitely will use the IVUS to evaluate the lemon area to decide the lemon opening is severe or not. And of course, we have to decide the circumflex ostium and distal circumflex lesion we have to treat or not before we put a lemon stent. That's my thought.
So how about your opinion, Cheng-I?
So, good morning, Dr. Tsai. This is Yenn-Jiang from Kaohsiung Chang'e Memorial Hospital. So I think this case is very challenging. Regarding the lemon lesion, I also will endorse IVUS because sometimes a shape of a lemon is not circle. It probably ovoid, and the takeoff angle is not perpendicular to aorta wall. So if we only adopt angiogram, probably will misinterpret the severity of a lemon stenosis, especially the ostium and the distal portion. So I agree with Dr. Lin. We need to use IVUS to confirm the severity of lemon stenosis, and also for the proximal LAD. I think from the angiogram, we saw it's very calcified. So maybe deblocking strategy is necessary. And also for the mid portion of a circumflex, it's a borderline lesion. So we need to use a corner image to decide whether we should treat or not.
So how about Cheng-Ting? What's your opinion?
Okay, Yi-Lin, I'm Cheng-Ting from Marquette Memorial Hospital. I totally agree with Dr. Lin and Dr. Zeng's opinion. And but I also, because the patient is present with the angina pectoris, so I also concerned because from the angio, the coronary so calcified, heavy calcified. I also concerned his artery valves stenosis condition. Sometimes because the artery root heavy calcified extend to the coronary ostium. So how about his artery valve condition?
Artery valve is quite good. We have done the transthoracic echocardiogram. The artery valve is good. Yeah.
Okay, thank you.
Okay. So how about Tse-Min? What's your opinion regarding this very complex lesion case?
Okay, my good friend and dear colleague, and I'm Chia-Pin Lin. And Yi-Lin, would you show the angio you take today? The angiogram.
Please show the angiography. Today's angiography. Maybe left side.
Maybe we can see the cranial view and the caudal view.
And this is today's coronary artery angiogram, especially from left coronary, because he had a lemon ostial lesion, so we cannot engage with the 7 French small juggins guiding into the lemon. And even when we wired a Sion blue guide wire to LAD distal, we still cannot full engagement with have a good coronary angiogram.
Okay.
That's our previous work.
Okay. So I think from the angiogram, you can see that the distribution of the heavy calcification around the proximal and the middle part of the LAD. And I think, of course, I agree with the previous expert's opinion that IVUS is very necessary, but it is possible that IVUS cannot close the LAD middle. So I think the debugging, especially rotablation, may be inevitable. So I think maybe we can access the Honye's, Dr. Honye's opinion.
So Professor Honye, what's your opinion regarding this complex case?
Yes, thank you. Good morning, everybody. This is Junko Honye from Japan, and very complex case. And there are 3 points. The first point is how to evaluate left main, and second point, how to treat the very severely calcified LAD lesion, and third point, and how to do we have to fix the circumflex or not? And the first point, as the previous doctors already told you that the IVUS examination is very crucial because damping of the pressure is not always mean the very severe stenosis of ostial left main. Sometimes the left entry of left main is folded or angulated. Or if there is a very severe tight stenosis. And so we have to clarify which is that's true in this patient. The second point, the LAD severely calcified lesion, and the lesion is pretty long, so we need to some degree of ablation anyway. And it is a point that where to where we have to ablate. And the third point is the complexity or severity of circumflex lesion. And especially in the ostium circumflex, we always avoid complex stenting. Try to finish with one stent strategy from left main to crossover to LAD stenting. And sometimes we dilate with squirting balloon at the ostial circumflex and finished with drug-coated balloon. And that is option. Thank you.
Okay, thank you very much for your very important comments. So after the discussion of the panelists, so Yi-Lin, in summary, in this case, you have to face the three problems. The first one is the layman. So we need to treat this layman. Of course, the IVUS is very important. The IVUS study is very important. And especially we need to study the LAD and as well as the circumflex. If we need to treat the circumflex, especially we need to know, should we treat the bifurcation lesion or not? And the second one is severe calcified LAD, and as the panelist mentioned that before you advance the IVUS catheter, maybe you need to ablate the very calcified lesion. So this is in summary of this panelist comment and opinions. So what's your therapeutic strategy, Yi-Lin, regarding this case?
Dr. Xie, may I ask a small question?
Yes, of course, you can. Not just only one. You can ask many questions. No problem.
Yeah, for this patient, he had a right corneal artery stenosis and a layman to LAD calcified plaque with ostial lesion. So the revascularization strategy, because I think she is the candidate for live demonstration, and for safety, I will try to fix the RCA first, because RCA had a collateral channel donor to the LAD. So if we do the rota, it will be much safe and stable hemodynamics. But actually, the ischemic burden is located at the layman and the LAD territory. So if we don't have to do the live demonstration, and it's just usual case at daily life, where we just treat the layman to LAD straightly or not, just like me, just do the RCA first.
Okay, this is a very good question. But before the answer from our panelists, in this case, I have one question for you. Did this patient receive a sine scan stress test for this patient?
She came to Kinmen Hospital for non-STEMI. So he didn't do the non-invasive like Salium or Chemio test.
Okay, I see. So Yi-Lin's question is, if we forget the lab demonstration course, will you just treat the left side only, or you will treat just like him, treat the RCA first, then go back to treat the layman and the LD lesions, circumflex lesions? So any comment from our panelists? Cheng-Ting.
I agree for the patient's safety. Fix the RCA lesion first is okay, because sometimes from this angle you can see after guiding engage and the wiring past the lesion, the LAD flow is nearly it's not so clear because flow has obstruction. So sometimes we were concerned before abrasion, rota abrasion, the patient is need for mechanical support. So I just concern this. So in this reason, I agree with fixed RCA first for safety. Yes.
So, Professor Honye, what's your opinion regarding this question?
Yes, very important but difficult question. And if we try to fix RCA first, but if there is some slow flow, then this patient, hemodynamic would be getting worse. So we, if we treat RCA first, then I prepare to use intra-aortic balloon pump for just in case. But if you, so this is very complex case. So if your treatment of RCA is very successfully, then it is quite safe to treat left circumflex system. So I think that is a good choice to treat RCA first.
Yes.
Thank you.
Thank you. So from today's angiography, you can see there are some collateral from RCA to middle LAD or even to the distal LAD. So after you revascularization RCA, currently today, it's more safe to do the left side PCI. So this is our answer. So how about other panelists? Any other comment?
I think this is a very interesting question, but since there is no clear evidence to support which first strategy, and sometimes it should be individualized. But regarding to this case, that I think that RCA is not very dominant because it's, at least is bidominant of the RCA and the circumflex. So if the RCA lesion is very simple and very easy, we can treat it very quickly. I think the treat RCA first may be a good choice. But if the RCA has sometimes very long lesion, the diffuse lesion, heavy calcified lesion, very difficult, complex lesion, maybe we have to treat the lemon first, because if we do the RCA first and we have some problem like the slow flow that Dr. Honye says, there will be very catastrophe. So sometimes it should be individualized. But in this case, maybe I will try to treat the lemon and the LAD directly, because I think that the RCA is not so big.
Okay. Yeah. So Yi-Lin, based on your very good skill, so you revasculated the RCA already. So today, when you perform the lemon or even the LAD PCI, I think it's more safe today. So what's your therapeutic strategy for this case now? For the
Okay, so indeed, we have a good collateral from the RCA, so we go to the lemon and LAD treatment. Now, we have tried to push the IVUS image catheter to the lesion side, but it cannot pass the lemon osteo. It just match to the lemon bifurcation side. So we can see the image at that time, and to see whether there is a lemon stenotic osteo lesion, and that's the image. And we can invite Dr. Zhang to interpret our first IVUS image from this view, from this lemon LAD proximal.
So Yi-Lin, today you perform from the femoral artery.
Yeah, femoral artery.
Yes, and the 7 phalange 0-4 guiding.
Yeah.
Okay. So
Dr. Zhang from Taipei VGH. Could you see the IVUS?
Yes. So I would like to introduce today's IVUS commentator is Dr. Yenn-Jiang from Taipei VGH.
Okay. Thank you, Dr. Xue and all the panels. So we perform the first IVUS, and the IVUS cast cannot close the proximal calcified lesion. So we just do the IVUS pullback from the proximal LED.
镜头看学长，他们调一下。
The IVUS image
yeah.
can
Yeah,
not.
okay. I just showing
Okay.
you now.
Okay.
And this is the IVUS pullback from the proximal LED, and this is the bifurcation, and this is in the left main. As you could see, there's a calcified plaque at around 10 to 12 o'clock. I will show you again, because we the catheter cannot close the lesion, so we just do a pullback in the from the most distal side that IVUS can reach. So as you can see, there's a calcified plaque from 12 to 6 o'clock, and this is the bifurcation side. Second flex come from the 7 o'clock. And this is in the left main shaft, and this is in the left main ostium. Okay, sorry, I will show you. This is roughly around the left main ostium, and it's an oval shape indeed. And just like previous panel mentioned, and we did the measurement, and the lumen area of the left main ostium is around 7.4 millimeter square. And of course, we all know the cut value of 6 millimeter for defer the left main intervention. But I would like to show you the LD ostium is around here. So it's quite tight stenosis, and the calcify is around 180 degree. And so I think if we do the intervention, we must be close the LD ostium to the left main. So, but whether we should cover the left main ostium is another issue. Maybe we could have a discussion about here. And regarding the wire bias, I think the IVUS catheter just touched the calcified plaque from the proximality to the ostium. So I think if we do the debugging, I think the wire bias is quite nice at this segment. So this is my comment.
Okay, so from the from the preliminary IVUS finding, any comment from Professor Honye? We know you are an expert for the IVUS interpretation.
Yeah, the IVUS interpretation is very excellent, I think, and wire bias is of course good. And another point is that the ostial circumflex, at least the pullback imaging from LAD to left main, the ostial circumflex looks like quite nicely open. So that means, so at least looking at these IVUS images, we don't have to touch ostial circ during the procedure. Thank you.
Thank you for your comment. So if we want to make sure the severity of the ostial of the circumflex, maybe we can run another IVUS study from the circumflex later, okay? So after the IVUS interpretation, of course, we cannot advise the IVUS catheter to the ideal location. So as we mentioned in the discussion before, we needed to rotablate this very calcified LAD lesion. So Yi-Lin, what's your next step?
So we directly do the rotational atherectomy to do the plaque modification, because it's a very, very critical lesion. And we choose the 1.5 quarter, 1.25 ver, and to try to modify the LAD proximal plaque. And we pass the lesion at the third round. This is the
What's the rota wire?
Rota floppy.
Okay.
Rota floppy.
And how about the speed?
The speed is 160,000. 160,000. Yeah.
Regarding
and
the size of the bird, I think I would like to access the panel's opinion. Would you choose 1.25 or 1.5 bird?
Well, in my opinion, of course, I will just use 1.25 first, because you can appreciate that the LAD flow is almost close even after your workhorse wire passed lesion. So it means that it should be a very critical lesion. And also from the LAD pullback IVUS, you can appreciate that even we have a very good wire bias that the IVUS catheter almost touch the calcium arc, but also the IVUS catheter also touch the normal wall in the opposite side from 6 to 12 o'clock, which means that in the proximal LAD, if we use a larger burr, you have the chance to injure the normal tissue. So I will use the 1.25 burr first, and then we will see what's happened. And of course, I have to mention that we always educate our young fellow that we have to use the auto pullback during the IVUS pullback. But in this case, in the very beginning, if we just suspect there is a critical lesion at the lemon ostium, I will recommend in this specific case to use the manual pullback first, because you don't know that is there any critical lesion at the lemon ostium or not. If there is a critical lesion and you do the IVUS automatic pullback, maybe you may encounter some hemodynamic compromise. So you can use the very quick manual pullback to check, is it a critical lesion at lemon ostium or not? If not, of course, you can use your automatic pullback. If yes, you should rapid evaluate the lemon and pull out your IVUS catheter in order to prevent the hemodynamic compromise.
So how about your choice, 1.5 or 1.25 initially?
Based on patient economic, if patient can tolerate the 2 burr, I will choose the small burr first. I have another question about the guiding selection, because from the IVUS, the prick is located AD lateral wall. So Yi-Lin, you choose the jacking left or short tip?
Yeah, short tip jacking left.
Yeah, okay, short tip, okay. So I just a question to the panelists. Do you think a different type guiding will a different wire bias for this patient?
Yeah, I think that's very difficult because we have to keep the balance between because you think of the ostial lemon lesion, so you don't want to engage the catheter too deep. But another side, you want to have a good and a better support. You have to maybe use the catheter will de-engage. So it depends on the safety and efficacy. But fortunately, in this case, and I see Yi-Lin can advance the rotor operator very easy. The support actually so far is good, but I'm not so sure. Maybe when we deploy or advance the stent, maybe we have some problem. But after the good prepare before the stent implantation, I think it's okay. So how about the opinion from Tse-Min or Zheng-Yi?
So if the patient can only offer 1 burr, so I would like to choose 1.5. Otherwise, I probably will use maybe 1.5 balloon for pre-dilation and try to pass the IVUS to the proximal LAD lesion to look at the lesion morphology at that point. And I think if I choose 1.5 burr, I probably will lift the guiding catheter a little bit to try to change the wire bias to avoid the differential ablation at the ostium LAD. I think they could avoid the complication. So.
Yeah, I think that the question of the guiding catheter, I think is very important. Sometimes we have to have some compromise between the support and the cohesis. But I think in this case, because maybe we have to treat the lemon ostium and there is some heavy calcified plaque in the lemon, and so maybe I think cohesion is more important than the back support, because if we choose the extra support guiding, maybe we will have some unnecessary wire bias. But I think that the different wire bias may be different. The guiding catheter will have certainly have the different wire bias And I would like to raise another question that after we check up the IVUS, would you leave the lemon Austin alone, did not treat it because the area is adequate, or just still stand the lemon Austin?
Yeah, this is another good question. But before I answer this question, I want to ask the opinion from Dr. Honye. Two questions. The first question, what size of bird size will you choose firstly? And second question, what kind of guiding catheter will you prefer? Thank you.
Okay, very good questions. And usually in this case, I start with 1.5 bar. However, in this very particular case, this patient has very critical stenosis, as Dr. Lin mentioned, and there are a lot of collaterals from right coronary artery. And in addition to that, the first IVUS catheter could not be advanced through the LAD stenosis. And it's safer point of view, I start with 1.25 bar in this particular case. And the second question, the guiding catheter. And at first, we didn't know how the stenosis of the left main Austin is critical or not. And sometimes if we use a backup type guiding catheter, we may traumatize the osteo left main. And of course, in addition, you can find some severe calcium at the ceiling of left main. So in order not to traumatize osteo left main, it is a very good selection to start with short tip JL guiding catheter.
Okay, so thank you very much. Thank you very much for your comment. And before answer the Tse-Min's question, maybe we need another complete IVUS study because now we rotablate the calcified LAD lesion, so we can have another complete IVUS study. And after the IVUS finding, we can discuss this very good question. Okay, good. So Yi-Lin, I see that you perform another IVUS study from the maybe more distally of the LAD, right?
Yes, and thank you, Dr. Honye and my mentor, Professor Lu. And because of the worry, considering about the lemon osteo lesion, so I choose the small jogging guiding to avoid traumatizing the lemon osteo lesion. And I decided two-bird strategy at the beginning without considering economic issue, because fortunately today we have a live demonstration and the patient's economic concern is not a critical issue. So I choose two-bird strategy and use the 1.25 bird to create a small channel to let our IVUS image catheter can advance to the LAD distal. Now, and as you see, we already put the IVUS image beyond the critical calcified plaque. And our next question will be, should we use another rotablator, another bird to plaque debugging? And is there any need for lemon osteo lesion to treatment? And so we have to ask about Dr. Zhang image.
I'm going to show you the IVUS putback after the 1.25 rotabration. So this is the IVUS putback from the middle LAD, and you could see some mixed plaque, and there are also some calcified plaque over here. And this is a relative normal size, and the vessel size is roughly around 30 millimeter. And this is a diffuse lesion, and you can see this is the most critical site. There are some circumferential calcified lesion around here. But there is also some reverberation here. And this is the IVUS is enter the proximal LAD. There's still some calcified lesion, and this is LAD Austin and into the left main. Okay, so so after the first rotation, we still have some calcified lesion around this segment. And regarding the length of the calcified segment, is roughly around is more than 10 millimeter in the length. So I think because there's still circumferential calcified lesion and the length is more than 5 millimeters, so it will be a potential under expansion of the stent. So maybe I agree the two burr strategy. We can upsize the burr to do the roll operation again to get a more outcome and a more better lesion preparation.
Yeah, judging from this round of IVUS study, we cannot see the osteolamina very clearly. So can you restudy the osteolamina or even lemon shaft by manual, just
Yeah,
like
sure.
佳濱 suggestion?
Okay, so maybe we can do the IVUS. Yeah.
And so now IVUS catheter is in the vessel, not yet, or has been removed?
So
Yeah, we can just advance the IVUS now.
Yeah. And we will also, because currently we have a guidewire in the circumference. So we can also examination the circ lesion.
Okay, so you can pull back from the circumference and to the lemon. But it's very important to make sure the severity of lemon osteo lesion again.
And currently I'm in the circ middle to distal, the stenotic plate. And can we show the IVUS image?
Yeah, okay, we can see the IVUS image.
Okay, then we can start pull back.
Okay, so now we do the IVUS from the middle circumference. We still use the auto repair. But as you can see, there's still some lesion in the proximal circumference, but it's quite short, and some superficial calcified lesion. And this is a relatively normal site of the proximal circumference. And there's still some superficial calcified lesion here. And this is a bifurcation. So this is circumference osteon looks quite enough. And this is the left main. Okay. Yeah, maybe we can do the manual pullback again to
Yes.
show the left main.
Okay.
Osteon.
Okay, and here is the aorta and the lemon osteum, and here might be the calcified plaque of lemon proximal and the junction of aorta.
Dr. Tsai, could you just flash the caster a little bit? It seems to me that the image quality is not good enough. It's too dark.
Okay, we can flash, right?
Okay.
Okay, it's better.
And this is the junction, and this is near os.
Yeah, I think it's just like the first IVUS run is the oval shape of the lemon osteon.
Yeah, and this is more proximal site of lemon, and this is the osteum.
So can you measure the area again at this point?
Okay, we can record and do the measurement. Okay, we can. Oh, okay, yeah.
In this case, it seems to me that the LAD osteum is quite critical. So definitely we will treat the LAD ostium, and I think it will be more adequate to stand all the way back to Lemon. And even the Lemon ostium is already big enough, over 6. But since we have to stand back to Lemon, personally, I would just stand all the way back to the ostium. And definitely the circumflex lesion have to be treated because it's quite a stenotic area by the IVUS pullback. Even we don't do the FFR pullback, according to the FLAIR trial just published in New England Journal of Medicine this month, the lesion, the minimal lumen area is less than 3. So even without FFR, and I will treat the circumflex. If I were the operator, I will maybe just treat the one stand for the middle to proximal LAD first, then turn to treat the circumflex, and then back to one stand crossover from proximal LAD back to Lemon ostium.
So from the IVUS study, what's the area of the ostium circumflex? Do you have that data?
I mean, not the ostium, just the distal circumflex lesion.
Okay.
And I just simply one stand crossover from LAD to Lemon ostium. The circumflex opening is okay, but the distal circumflex is quite stenotic. So I will treat the circumflex first, then cross over from LAD to Lemon ostium.
Okay, Yi-Lin.
Yeah, and
so what's the area of the ostium Lemon? 6.6, right?
Yeah, around 6.6, 6.5. So I'm agree with Dr. Lin that we have to stand in all back to the Lemon ostium, and also the circumflex middle lesion might be treated as well in the same time. But the next step is what is our second burr size? 1.75 or 2.0?
Yeah, I think this is a very important question because the second round of the IVUS, I think, is very informative. And at first, I see that the distal LAD actually the vessel size around 2.5, but there is very heavy calcification around in the middle to distal part of LAD. Also, you can see from the angiogram, there are very circumferential calcification, but because the distal is 2.5, if you choose to 2.0 burr, sometimes there's some potential risk. So maybe we may have around a run of the OCT can see the thickness of the calcium. Then you will be more comfortable to use the 2.5, 2.0 burr or 1.75. 1.75, yeah.
Yeah, but unfortunately today we don't have the OCT image catheter because it's already run out of the image catheter in Taiwan. They don't have the image catheter, so we only can judge the burr size from the IVUS image.
So any comment from Professor Honye regarding the IVUS study?
Yes. We still have a very circumferential calcium with very tight stenosis from proximal to mid part of LAD. So we need the second rod ablation. And I would like to use 1.75 burr for this kind of lesion. And because the first bar is 1.25, and it is safer to use the larger, less than 0.5 millimeter would be safer. And so I would use the 1.75 burr. And in terms of thickness of calcium, of course, a IVUS cannot tell you the thickness of calcium. However, even after the rod ablation with 1.25 burr, looking at the angiography, I think it's my view is through the PC monitor, but I think that still you can see the pretty heavy calcium at the bottom part of mid-LAD. So I think we need another rod ablation. Thank you.
Okay, now this is from the angiography view from the expert. So we need another bigger. So Professor Honye suggests 1.75 millimeter burr to rotablate the very calcified lesions. Okay, so So Yi-Lin, please go ahead your work. We have to move to the classroom number 1, the Dr. Shao-Sung Huang. Okay, Shao-Sung.
Okay.
We will come back later.
Can you hear
me? This is Dr. Yi-Zhang speaking.
Yeah, I can hear you. Can you hear me?
Yes, very clear.
Okay. Before we show our case, I will introduce my team member, Dr. Li Haowei and Dr. Wu Jiting. Dr. Li will show the baseline characteristic of this case.
Okay, so can you hear me?
Yes.
Okay, so this case is a 49-year-old gentleman, and he presented with dyspnea and come to our hospital last year. And he has the underlying disease of heart failure, hypertension, diabetes, and dyslipidemia, and also the chronic kidney disease. Okay, next slide, please. So during the last time PCI, on December last year, his RCA showed a diffuse lesion from the proximal to middle, and also diffuse lesion from the PDA, along the PDA and the PL. Okay, next slide, please. And as for the left side, you can see there's also diffuse lesion from the circumflex along the distal and the OM. And you can see that the LAD is total occlusion. Okay, next slide, please. And from this angle, you can see there's no prominent auto collateral. And when you're tracing back to the right side, you can also see no prominent collateral from the right side also. And next slide, please. Okay, so this is the other angle. And next slide, please. So during the last PCI, they first deal with the RCA and deploy a BMS stent at the RCA middle. Okay, next slide, please. Okay, so this time our target is the LAD chronic total occlusion, and with the CTO score 3 points.
Okay.
So Shao-Sung, before the discussion, I would like to introduce our panelists, including Professor Honye from Japan, and also Dr. Chia-Pin Lin from Chang'an Memorial Hospital, and Dr. Cheng-Ting from McKay Memorial Hospital, and of course Tse-Min, Professor Tse-Min, and also Dr. Yi-Lin from Kaohsiung Chang'an Memorial Hospital. Okay, so in summary, this is a triple vessel coronary disease. Of course, you first fix the RCA first, and today's target will be the LAD Austin CTO region. So, according to the measurement, the JCTO score will be 3 points. So, is there any comment or thought regarding this CTO region? Cheng-Yi, you can go first.
Well, I think this is truly very difficult case. So, judging from the left side cone angel, I can appreciate some stump at the LAD ostium. So, if the visual gray collateral is not so well, I probably would try just take a few minutes to try anti-gray approach. So if I not succeed, I will try to maybe try to septal some septal collateral and from PDA. So super selective injection probably needed to evaluate the whole course, because from the right cone angiogram, it's not very clear to demonstrate the entry site and the whole course of the collateral.
Okay, so this is today's angiography. You can see some collateral from RCA to LAD. So regarding this case, Professor Honye, what's your opinion?
Yes, very difficult case, I think. So looking at the right coronary angiography, the septal channel, there are several small septal channels. However, from my view, I cannot find a very good promising collateral channel. So anyway, I start from antegrade approach. And when you put the IVUS catheter to the circumflex and find the accurate the entry of CTO, and I recommend to use IVUS first.
Okay, thank you. Any other comment from Chia-Pin and Cheng-Ting?
Okay, thank you. Could you have the left side angel? Here is the right side angel. Okay. Maybe I think from this projection you can maybe from the previous one. Could I? Yeah. As Honye Sensei just mentioned,
yeah,
that we can have the IVUS pull back to evaluate the entry point. But from my point of view, I would wonder that because it's a big angle between the lemon and circumflex, and if you pull back from the circumflex, it's maybe quite difficult during the pullback to identify the LAD entry site. So maybe we can just try just integrate to target a little bit dimple lesion with some calcified. So maybe that will be my first attack point for the anti-grade approach. And of course, we have always to prepare for the retrograde approach. So if we go for the retrograde, maybe we can have to fix the middle RCA lesion first, then go for the retrograde approach.
And Chia-Pin, if we advise a consider maybe truly that's maybe a Ramus or first OM. I don't know.
Yes, yes,
sure.
Of course. If we have the Ramus branch, it's better to pull back from the less angle Ramus to evaluate the LAD entry site instead of circumflex. But from this projection, I would wonder that it should be the OM branch, and it will just end up back to the circumflex OSTIP. And I don't think it will help a lot instead of pull back from circumflex.
Thank you. And Cheng-Ting.
But we can try. I was pulled back from the high lateral OM branch. Maybe we can puncture from the circumflex upside direction. Yeah, maybe you can see some image from the Ramus OM pullback. You can try.
Okay. So IVUS guided, I think, is necessary. Tse-Min, what's your opinion?
Yeah, yes, I think IVUS will be very helpful. But as the Dr. Chia-Pin says, there is a dimper of the lemon to LAD Austin. So maybe it is a proximal site for the proximal LAD CTO cap. But I think this case, because there is some calcification, and I think the CTO segment is maybe very long. So I think bidirectional approach is necessary. So retrograde sometimes I think is inevitable. So we have to choose so maybe we have to treat the RCA middle lesion first and then do the retrograde. And I think bidirectional is necessary.
Okay, so Shao-Sung, after the very complete discussion with our panelists, so in summary, we will suggest we can try antegrade approach to try to reopen this vessel. And of course, retrograde approach should be back up. So this is our strategy. And how about your strategy?
Thank you for your valuable comment. For this case, I think as you say, the CTO segment is long, and you can see calcified plaque in the CTO segment, and the stump, maybe a little stump or stump is in LAD Austin. So I think maybe only antegrade approach, the success rate is low. So I think maybe bilateral approach is need for this case. However, the collateral secretion is not very well in this case. So initially we want to try, maybe we can serve in some distal collateral from PDA to distal LAD, try to retrograde approach, maybe can increase the possibility of success. However, we can see restenosis in the RCA middle stent because he put the bare metal stent initially. But the lumen may be enough for the microcaster, so I don't treat the instant restenosis first. I put the microcaster, the hemodynamic did not change, so I don't treat the instant restenosis first. We can see the next slide. Initially, I used the Caravelle microcaster tip injection. However, this collateral did not go to the distal AD, so we distal injection to find maybe some collateral here, very faint collateral from PDA to LAD, distal LAD. So next, so luckily I use the Sion blue wire. The wire can go. Goes mostly to distal AD, luckily. So, but however, the microcaster cannot went to the collateral circulation. So we use the conus branch for increasing the support. Next slide. However, the microcaster also cannot go to distal LAD. So we changed another microcaster. We try to use the APT 1.7 French APT microcaster to try to push the microcaster to distal LAD. Luckily, the APT microcaster can push into the distal LAD. Next slide. We can see the microcaster can see here. So next, I try to use IVUS to find the LAD ostium, maybe a little stump in the angiography. So I use a Sion blue wire to circumflex and pull back the IVUS from proximal circumflex to left main. Dr. Zhang, can you show the IVUS image to our panelists?
Hey, Dr. Shao-Sung.
Yes.
Hey, do you have the angiogram of the distal LAD?
Angiogram.
Angiogram inject the contrast from the 1 APT microcaster.
No.
So we can, if you have the angiogram, we can evaluate the distal cap of the CTO.
Oh yeah. Oh, yes. So, sorry, I don't have the angiogram from the microcaster, but we can see the IVUS imagery from circumflex to left main.
Okay, this is the IVUS pullback from the proximal circumflex to left main, and there's some plaque in the proximal circumflex, and you could see there's one branch, and the second branch enter the circumflex, and this is the left main, and then we in the guiding. Okay, I could show you again. The two branch enter the main vessel. So I think because this quite large lemon and right angle, so to be honest, I don't think we could really clearly show the entry point of the LED.
Do you think the 6 o'clock, this is the LED?
because that's quite short, then the IVUS jump into the guiding. So I'm not so sure whether I think in the 6 o'clock, I would say it's not, it's
Chia-Pin,
difficult to say.
What's your opinion?
From my perspective, it's always not promising to guess which direction is the LAD Ostium. Maybe you can just keep a wire at the LAD dimple and then just make guess for your better guess where is the entry. But from this pullback, as I just mentioned, that is acute angle between the circumflex to the lemon, and the IVUS caster always jump suddenly from circumflex back to lemon, and you always cannot clearly identify the entry point of this kind of big angle or LAD opening. So it's not a good idea. Just guess which point is your entry and just blindly puncture the point. In this case, maybe I will shift back to the angel guide puncture first instead of always stick on the IVUS guide to identify the entry point.
So Professor Honye? Yes, regarding this IVUS study, comment from your expert?
Yeah, it is very, because the size of the vessel, it is pretty difficult to identify the entry of CTO. Maybe 6 o'clock or so would be maybe at the entry. However, if you place IVUS catheter at the left main, then stays for a while and move the IVUS imaging core back and forth, try to find the entry. But because the size of the vessel is quite large, so it may be difficult to identify the entry. Thank you.
Okay, thank you very much for your comment. So Shao-Sung, actually, IVUS cannot give us a lot of information. So maybe you can try from angiography guided.
Yes. So next.
Yeah, maybe I have a question for Dr. Zhang.
Yeah.
From the IVUS image, what's the vessel? The 4 o'clock vessel that we can see in the.
他好像想问俊清学，找俊清。
Oh, that's another AM branch, right?
Yeah. So there are two
branch.
branch.
Okay,
yes.
okay.
Yes.
Yeah,
So we can see 2 orifices or a branch.
So probably we can pull back from the high OM. Maybe we may have some new finding. Yeah.
I think maybe the 6 o'clock is the LDOs, so I put the IVUS in this position and make an angiography to maybe the little stump is the LDOs. I think so. I use a double lumen caster, Sasuke caster for LDO stem puncture. So initially I use a Gaia second wire from this dimple to penetrate the proximal cap. However, the wire deviation to the outside maybe subminimal space. So I think maybe I need put another wire from retrograde to make sure the length the pathway from LAD to proximal to LAD. So I use next slide, 5 cross from this LAD, try to penetrate from distal cap. However, the wire can only a little advance from distal distal cap. So I use another UB3 caster from the distal cap and and another use a Conquest Pro wire from proximal to maybe try to kissing wire technique. Next. However, maybe calcify or maybe in the wire in the subintimal space, so the wire cannot kissing in this area. So I tried several times. However, the wire can only a little close, but not can kissing. So I use a second from distal and try to reverse cut technique. Next.
Shao-Sung, what's the retrograde wire?
This is the UV3. Next.
Oh, is the UV3. Okay.
This is the next.
Retrograde UV3, antegrade Gaia second, right?
Antegrade Conquest Pro. This is Conquest Pro, sir. Conquest Pro 12, and now this is the Gaia Conquest Pro in antegrade and the Gaia second in the retrograde. So maybe I think maybe we can use reverse cut here because the wire cannot advance more. So I think maybe close, so close, maybe reverse cut can success in this area. How about the panelist opinion or comment?
So Shao-Sung, when you advance antegradally, you use the Conquest Pro 12, right?
Yes, yes.
You can
because initially I use Gaia second. However, the wire cannot go advance to the distal LED, so I changed to Conquest Pro 12.
Okay, I see. So at this moment, any comment for this very complex CTO region? So Shao-Sung's strategy is he will perform the reverse cut at the plasma LED, and we can see the another view, the lateral view, right?
Lateral view. Okay.
So can we see the lateral view? How about the relationship between these two wires? Okay. Okay. Yeah, retrograde wire is promising.
Okay, so I'm Cheng-Ting.
Yes. Okay.
What's the antegrade microcaster?
Antegrade mass is the APT 2.6 French APT microcaster.
2.6. So the 2.6 French microcaster can advance.
Can advance to plasma LED. Can advance.
Can advance.
Yes.
Okay.
Yeah, I think thanks to Shao-Sung's very good technique, and of course, at first I will take the picture of the distal LED beyond the CTO segment, and may have a pre-image that we can evaluate the distal CTO cap the situation, and then I think at first I see that you use maybe soft wire, maybe the Sion or filter that can go very high from the retrograde. So of course, at first I will try the kissing wire because the wire position looks like very close, very close to each other, and but I think maybe you have some deviation in the middle part of the LED and deviate to the intimal space. But now I think in this situation, the plasma in the at least part of some part of the Y is very close, and so of course in this situation, maybe you can try the reverse cut. But I think if the microcaster can integrate microcaster can advance into the plasma LED, maybe we can still stick to the kissing Y technique because I think the plasma it was very promising.
Before try the reverse cut, maybe you can change back to the Sasuke double lumen caster and the parallel wire integrate try. Maybe you can cross.
Okay, thank you for your comment.
Tse-Min suggests to use a soft wire retrograde.
Retrograde, okay.
Now retrograde is Gaia second wire.
Well, in previous imaging, I noted that maybe the operator use the soft wire. Then the wire can go very high to the middle part.
I see. Okay.
And then later the so now is
gas second.
Retrograde.
Yeah.
And is it possible to push the IVUS caster into the LAD? Is it possible?
I see, maybe possible, but maybe little.
But I think the anti-grade wire is not long enough to minimize the IVUS catheter. So in this situation, any comment from Professor Honye?
Okay, so from my view, the entry point of LAD is located a little bit proximal to that wire. And the second point is that if you try to use reverse cart, and you should change the wire from Gaia second to Sion or Sion black, very slippery wire. That's my recommendation.
Okay.
Thank you.
Thank you.
So Shao-Sung, in summary, we suggest, the panelists suggest you can stick to do the kissing wire technique before you perform a reverse cut technique. Okay?
Okay.
Okay.
Thank you.
I think the Chia-Pin would like to check the proximal retrograde anti-grade wire position to make sure that the wire actually in the proximal LAD. Of course, now the anti-grade wire may have the microcaster, so maybe we have to change the microcaster to change to the IVUS. But I think this is more carefully. But the wire position look very promising. I think that is maybe in the proximal, in the vessel.
From the angiography, the retrograde wire is very promising, right? The course is quite smoothly. Okay, so Shao-Sung, please go ahead your work. We will be back later. Now we have to move to the classroom number 3.
Okay, thank you.
Yi-Lin's classroom, okay?
Okay, thank you.
Okay, so please move to the number 3 classroom.
Okay.
Yi-Lin, we are back.
Yeah,
we are back. So can you explain to us what's your progress of the PCF in this case?
Currently, we finished the second bird rotational atherectomy, and though Dr. Honye, Professor Honye suggests we use 1.75 for safety, but after consideration about optimal plaque modification debugging, so we choose 2.0. We choose 2.0 Rotalink to do the plaque debugging, and this dig around. And this is the first round of the 2.0 rotabird, and there is much resistance from the Lehman distal and the LAD ostium. Then the first round we can pass the lesion to the LAD proximal to middle, the most calcified plaque. And we also use the 160,000 RPM to do the rotational atherectomy. And after 3 rounds, we can pass the lesion smoothly. And one more polish round. This is the polish round, and this is the polish round. And during the rotational atherectomy, patient have the bradycardia, long pulse, and somehow ST elevation. So I think it's many distal embolization because we polish so much plaque. And so we use a 2.0 balloon to pull bar the lesion, and this is the angiogram after pull bar. And we can see the IVUS image. Yeah. IVUS image after 2.0 rotabird and 2.0 emerge balloon dilatation. This is the image.
I was prepared from the middle to distal LAD after the 2.0 rotabration and the 2.0 predilatation. And there are some eccentric plaque around 12 to 6 o'clock eccentric plaque. And this is relative, not so, you still can see some calcified plaque, but after the 2.0 rotabration, we get a quite large lumen here. And this is around the LD and diagonal bifurcation site. And then this is the LD ostium and the circumflex into the left main. And this is in the left main shaft. And this is the left main ostium. So I think after the 2O root ablation and the predilatation, we get a quite large lumen. But of course, maybe we induce some slow flow, something like that. But I think we did a good atherectomy and the vessel preparation after the two-birth strategy. And this is the IVUS finding.
Okay, so after the no referral phenomenon, what's your treatment for this case, and how about the current condition of this patient?
He thought it was caused by the distal embolization. So we give him some ISO kit and also peripheral use the IV push level fed to elevate his blood pressure. And now there is no more ST elevation and the patient was calm. Also for his chest pain, we gave him morphine 3 milli to relieve his chest pain, relieve her chest pain.
Yeah. Okay, thank you. So Cheng-Ting, any comment?
Yi-Lin, what's the rotation speed?
160,000.
Of course, because you use a bigger burr size of the 2.0 millimeter burr. So now the IVUS finding is better than the previous one. So at this moment, any comment from our panelists?
Well, I would like to have the comment from my mentor, Honye sensei, from the IVUS pullback after the 2-0 bird.
Yes. Yeah, very aggressive and challenging strategy with 2 millimeter burr. And because during this is a quite long lesion, and during the pullback of from distal to proximal LAD, the guide wire bias it's not so good. There are some segments which guide wire bias is not so good. So, but fortunately, you didn't create large vessel injury with rotablator 2-point bar. So the result is quite nice. And we can see some discontinuation of calcium, like 4 o'clock or 5 o'clock around here. So I think it's a good ablation. If I were the operator, I would use the 1.75 burr following by cutting balloon Wolverine 2.5 or so. Then sometimes the crack of calcium can be effectively created. But very good challenging strategy.
Okay.
Thank you.
Thank you, Honye sensei.
Yeah, I think the Dr. Tsai is a young interventionist, but he's very, very brave. But because I think distal vessel is maybe 2.5, and use the 2.0 burr, you should not advance your burr beyond the heavy calcified part. But I note that the burr go to the very, very far, very distal to the LD. I think may create some risk of the injury in the perforation. But I think after the rota and the other track show that just Honye said the wire bias is not so favorable now, so maybe we can choose a cutting balloon. But I know there is some crack already in the calcified plaque. But there are also area there is some circumferential, not crack. So maybe we can choose 2.5, 2.75. Wolverine to treat the most calcified part of the LAD.
So Yi-Lin, what's your next strategy?
Yeah,
Just like
because
Professor Lu say, use cutting balloon.
yeah, because we have another 3O NC emerge to probe the lesion, and the new image round showed still there is not well preparation of the lesion. So probably indeed we have to use a Wolverine cutting balloon over the calcified site. So 2.75 Wolverine.
Okay, so Yi-Lin, please go ahead your job, and we have to move to the next a special lecture from Professor Junko Honye. Professor Honye, are you ready to give us a very special lecture?
Yes, thank you very much. Okay.
So before the lecture, it's my honor to introduce our distinguished guest, Professor Junko Honye from Japan. And currently, he is the Director of Cardiovascular Center of Kikuno Memorial Hospital of the Kanagawa, Japan. Kanagawa in Chinese means Hsin-I Chuan. Okay. So, yeah. So, and she get the PhD from the Nihon University Graduate School, Tokyo in 1987. And currently she is also the visiting assistant professor of medicine of the Department of Cardiovascular Medicine of University of Tokyo. And as we know, and Professor Honye is the expert of IVUS, not just on IVUS, also is the image study of the PCI complex for a complex region, and she also involved a lot of the Japanese expert consensus document in the writing group, including the CVIT of the primary PCI for acute myocardial infarction, update 2022, and also the clinical expert consensus document on the standard for measurement and assessment of IVUS of the Japanese Association of Cardiovascular Intervention and Therapeutics. And she also involved a lot of the FFR study. And today is our great honor to invite her to give us a special lecture. The title is a Master IVUS for Complex PCI. So let's give a warm welcome to Professor Honye. Professor Honye, thank you, please.
Thank you very much for your kind introduction. And good morning, ladies and gentlemen. It's always to meet all of you in doctors in Taiwan. So today my talk is a case with a rotablator, including left main bifurcation, especially for osteocircumflex. So the practical usage of IVUS for calcified lesion in complex anatomy, including left main bifurcation or osteo lesions. So so today I would like to share my knowledge, my case with you, how to treat safer and more effectively use of rotablator involving left main bifurcation. Of course, today's case, you mentioned that guide wire bias, and so we have to understand guide wire bias completely before starting rotablation. As you already know, that the similar guide wire bias and position of the IVUS catheter inside of the lumen can be predicted. So this can be applied to predict guide wire bias during rotational atherectomy. So in this particular case, the IVUS catheter is facing to the superficial calcium, so that the nice ablation can be expected in this particular case. So in terms of left main bifurcation, let me review the plaque distribution. Let me review the one paper saying that plaque distribution on IVUS in left main bifurcation. And according to this paper, they found that the angiographic angiographic classification of left main bifurcation lesions is very accurate. So we usually use angiographic classification, Medina classification 111 or so. But this classification is not always accurate. However, and what they found that the continuous involvement from the distal left main into the proximal LAD artery is present in almost 90% of the cases like this. However, the carina of the bifurcation is always spared. So that means that in the case with rotablator, do not ablate the carina. So you have to change guide wire bias intentionally before starting rotablation by, for example, manipulating the guiding catheter. So this case was done more than 6-7 years ago. So we, at that time, we did not think the guide wire bias actually. And operator so in this case, there, as you know, that there is a very tight stenosis in mid-LAD, and the IVUS catheter did not cross the lesion. So we observed the IVUS only at the proximal part of the lesion. And this IVUS shows almost the carina of the lesion, carina. And you can see that circumflex is coming from 9 o'clock. And of course, you can see some calcium. However, the IVUS catheter is quite far from this heavy calcium, rather and facing to the carina, which is very healthy. And the operator started ablation from left main, all the way from left main to mid-LAD, and finally past the lesion. And after the ablation, the IVUS catheter was able to cross the lesion, so we observed the carina area. And in this case, we found that the vessel injury was created from after rotablation, like here. Fortunately, in this case, we could not see the extravasation following rotablation, so we finished this case with scrolling balloon. So try not to ablate healthy segment to avoid vessel injury. So what we should do in this case, so advance a burr with Dynaglide mode beyond carina to around here, and start ablation only in the very tight stenosis here, and do not push a burr too strongly to avoid jumping into the distal segment. So we have to ablate only calcified segment here. So I'm going to present very interesting case with rotablator in ostial circumflex. And please note that check guide wire bias on IVUS, of course, and manipulation of a guiding catheter to change guide wire bias, and to use larger size of a burr, comparison between angiography and IVUS, of course. And if you feel that there is no rotational speed drop in rotation during rotablation, then we may have to change guide wire from floppy wire to support wire. So this is a very 50 male. He has a history of diabetes, hypertension, and chronic renal failure on hemodialysis. And actually, this case was transmitted on some live demonstration in Japan, and operator was Dr. Hamazaki. And previously, stents were implanted in mid-LAD and mid-right coronary artery, but both of them had instant restenosis. So this patient had second PCIs for both instant restenosis. And you can find that very tight stenosis at ostial circumflex with some calcium inside of the circumflex, right here. Again here. So looking at the IVUS catheter to check guide wire bias, we start imaging from mid circumflex and coming back proximally to the lesion. And you can see a very tight and superficial stenosis, calcium here from almost circumferential, right at the osteal circumflex here. And you can see the LED is coming from 5 to 6 o'clock. And now the IVUS catheter is coming to left main. So the assessment of IVUS findings are as follows. IVUS catheter is facing to calcium, so and safe ablation can be expected because of circumferential calcium right at the osteal circumflex. So initially, starting with 1.5 millimeter burr, then we evaluated IVUS again following 1.5 burr ablation. So the operator started ablation with 1.5 millimeter burr with very, very gentle ablation. And he selected floppy wire. The rotational speed was 2,000 to 20,000 RPM, and maximum pressure rotational drop was 8,000 RPM. So please note that the tip of the guiding catheter, direction of the tip of the guiding catheter. This is the control angiography, and the tip of the guiding catheter is a little bit facing to the osteal LAD. However, during the ablation to the osteal circumflex, the operator pulled back a guiding catheter a little bit, so that the tip of the guiding catheter is facing to the circumflex to obtain good guide wire bias. Following rotational atherectomy 1.5 millimeter burr, some nice lumen was created here. However, some slit can be found here. So we suspect that there is a deep cut here. So we checked IVUS again and coming back to the ablated site here. So you can find that a very nice ablation was obtained here. And there are some small flap. I'm going to show you again. So you can see some flap here. So that this angiographic findings looks like this. So, but excellent ablation was obtained. And so your eyes, to look at the angiography, is consider the which direction your eyes are looking from looking on IVUS image. So IVUS image, your eyes are looking from 8 o'clock, so that some you may recognize some flap around here. So some septum, but this is not the septum here. So calcium was nicely ablated without the deep cut. So we decided to use a larger size of a burr, 2.5 to 2 millimeters. The wider was floppy, and rotational speed was the same, and maximum speed drop was 6,000 RPM, which is very elegant procedure. After the root ablation, a pretty nice results was obtained even on angiography. So after the 2 millimeter burr, so IVUS showed the additional very, very good ablative effect here with larger size, inner lumen size. So usually we finish this case in our routine practice. However, this is very special case because this patient has repeated instant restenosis and LAD and right coronary artery. So in this particular situation, we wanted to finish without stent implantation. So this is very, very unusual to use 3 burrs, but we decided to use the third burr, 2.25 burr, with 20,000 RPM. However, in this situation, no speed drop, but burr crossed the lesion. What happened in this situation? So we checked IVUS again. Again, the very good guide wire bias was obtained, and calcium was nicely ablated following 2.0 burr. But as a result of the ablation, larger lumen was obtained. So we decided to change so with using floppy guide wire, the burr was moving inside of the lumen, detached from the calcium. So we decided to use extra support wire to obtain stable guide wire bias. So again, the 2.25 burr ablation, and this time we had a very good effect with speed drop, 3,000 RPM. And this is the angiography following 2.25 burr. Very good ablation was obtained on angiography. And looking at the IVUS, as you can see here, very, very nice ablation with quite a sizable lumen was obtained. So we finished this case with scoring balloon and drug-coated balloon. So in summary, the position of an IVUS catheter before PCI was able to predict very good guide wire bias. Guide wire bias can be intentionally controlled in proximal lesions by manipulating a guiding catheter. Check IVUS again after every single ablation to evaluate efficacy of ablation that will lead to use larger size of a burr. When a burr passed the lesion without a speed drop, then it is time to change guide wire from floppy to extra support if you make sure that the guide wire bias is excellent. But after reviewing this case later, we may have able to change guide wire from floppy to extra support wire at the time of ablation with 2.0 burr because of excellent guide wire bias. So how to control guide wire bias? Of course, can be controlled in some degree. However, manipulating a guiding catheter for a proximal lesion, and usually deeper engagement, the tip of the guiding catheter is facing to outer side. To pull back the guiding catheter a little bit, then you can control to inner side. The other point is motion speed bias. The faster or quicker motion speed, then the burr is going to tend to go to outer curvature. In contrast, slower or very gentle motion speed, the burr tend to go to inner curvature. So intentional ablation with slower motion speed for lesions which is located at inner side. So rotor wire floppy or extra support, which wire to use? So use extra support guide wire when good guide wire bias was assessed before ablation. So this is my last slide. There are lots of tips and tricks to interpret IVUS images. Every image of IVUS gives you lots of information to obtain maximum effects with less complication. That means PCI with very high quality. Thank you for your kind attention.
Thank you very much for Professor Hongye's very excellent speech and a very nice case presentation. So regarding this speech, any comment or any question from our panelists? Chia-Pin.
Honye Sensei, instead of pull out the guiding catheter to ablate the outer curvature of circumflex ostium, would you recommend to use the extra support wire in the very beginning instead of pull out the guiding catheter?
Okay, if you find to use because the wire assessment before PCI, we usually use a softer wire like Sion blue or so. And that if you assess that guide wire bias is very, very excellent before procedure. So so we may choose extra support guide wire from the beginning. But please note that this is a very special case. Usually, I recommend to start with floppy wire.
Thanks, Professor Hongye's very excellent, informative speech. I have one question. Would you recommend to download your rota speed to create more abrasion effect? I know that you always use 200,000 round, but sometimes some experts, especially in Taiwan, will recommend to use lower speed after the burr close the lesion, maybe down to the 120,000 round. What's your opinion?
Okay, so of course the slower speed may decrease the particle which is migrated into the distal vessel. However, if the calcium is very thick and tight, then it takes a long time to pass the lesion with slower speed. So in that situation, a very hard and tight and thick calcium, then we tend to start with higher speed, like more than 18,000 RPM. And then finally, we were able to pass the lesion with burr. Then we down the rotational speed to 15,000 or 14,000 to ablate again.
So any comment or question?
So Dr. Honye, thank you very much for your very excellent and informative talk. So I have one question regarding the burr size. So usually some experts suggest the burr to vessel size is around 0.5 to 0.6. So I know from your slide that you do a very aggressive ablation. You using very large burr size. So does there any evidence suggest the clinical benefit, or we just use a small size and then cutting balloon angioplasty that will result equal result?
Okay, a very good question. So the situation is different if you put a stent anyway, or you try to finish that case without stent implantation. If you if you plan to put a stent anyway, then maybe maximum rotor burr size is 2 millimeters. Then cutting balloon and stent implantation would be a choice. However, in this very special case, we try to finish with stentless technique. So in that case, we usually use a larger size of a burr, 2.15, or very special case. In this particular case, we used 2.25. It is very unusual. But if you want to finish with stentless, without stent implantation, we sometimes use larger size of a burr, 2.15.
Okay, so Professor Honye, you means that if we do not want to put a stent, we can maximize the burr size, right? Okay.
Right.
Okay, good. Okay. Because the time is limited, thanks again for
Okay,
Professor
thank you very much.
excellent speech. Thank you.
Thank you very much.
Yeah. So now we will move to the classroom number 1, the Dr. Shao-Sung Huang's classroom. Shao-Sung, we are back.
Yes. So I use the reverse card because the anti-gray wire, kissing wire, the anti-gray wire cannot be advanced more distally. So I choose the reverse card. I use initially I want to use like Dr. Honye's suggestion, use a Sion black or Sion wire for retrograde wire advance to left main to proximal LED. However, the Sion black cannot go close to the anti-gray wire, so I use a new Gaia second wire. We can see the wire.
So, can you shift the angiography image to the main screen? Yes.
Yes, so the wire can go more close to the anti-gray wire. So I because the wire I think not going very smoothly. So I'm afraid maybe in the subminimal space. So I use the reverse card here. Next slide. This is the 2.0 balloon.
So some retrograde wire still the Gaia second?
Gaia second, yes, because the soft wire cannot go advanced. So this is the Gaia second wire. So after the balloon dilatation in plasma LED, the wire can go to the.
So you perform the reverse cut technique.
Yeah, reverse cut. Yes. Yeah. This is why it can go to the left main. Next slide. So after manipulation, the wire can go into the guiding caster.
Yes.
Yes, this is go into the guiding caster. So I do the IVUS to check the wire in left main is in the true lumen. Next slide. We can see the IVUS image. Dr. Zhang, can you show the IVUS image to the panelist?
Okay, this is the IVUS pullback from the proximal LED.
Second phase.
Oh, sorry, this is from the second phase. Oh, and you can see the wire enter into the left main from LED. Okay, maybe we can see it again.
So we can make sure at the Austin site, the wire is in the true lumen.
Yes.
Very important. Okay, so after the IVUS study, what's your next step?
I will use I will anchor the wire in the guiding caster and push the microcaster to guiding. Maybe externalization, I can put the stand in already. So the next step, I will choose the externalization technique.
So the retrograde microcaster is still the ATP?
Yes.
Yeah. Can we see the angiography? So
I don't. I just here. So this is the angiography. So I will anchor the wire. So I will use a 2.5 balloon to anchor the wire and push
your current status. You just anchor the retrograde wire and want to advise a retrograde microcatheter. Okay.
Yes.
I think after the penetration of the CTO region, I think the next step will be very routinely standardized. Yeah.
I hope the microcast can advance to the guiding cast.
So any comment from our panelists or Professor Honye? At this moment, any comment?
Actually, no, as the operator, as Dr. Operator said, the externalization, it's time to externalize.
Anchor.
Yeah.
Well, since we don't have the clear information of the alignments, I'm just wondering what's the standing strategy? Is just stand exactly to the LAD ostium or back to somehow disease alignment? Because from the very beginning, we just have the IVUS fallback from the distal alignment to circumflex, and we don't have a clear information in the alignment trunk and lemon ostium, so we cannot decide, do we have to stand back to lemon or just exactly at the ostium?
Yeah, maybe we have to do the IVUS check for the whole LAD segment from the middle to the proximal, and then we can decide how to stand the lesion. Because I think this is a standard demonstration of the CTO technique by directional approach. And now is in the step of the externalization. But I just wondering that there is a very long CTO segment and there is some calcification, but I think the Y position is very good, and probably it looks like that the antegrade and the retrograde Y did not have some difficulty to crossing the lesion. Because sometimes in case of the very heavy calcified, sometimes the Y very easy go to the intima space. But I think that because maybe it's a good technique of the operator, that the Y can cross and look like very not so difficult and go close to each other. I think it's a very quick demonstration.
I have one just quick question. I noticed there's a severe stenosis at the mid portion of circumflex, and I also found that there's some faint collateral from OM to diagonal. So I'm wondering if any of our panel will try to fix the circumflex before we attack LAD CTO.
I will not, actually. I think the major region is LAD, so I will fix the LAD already. Even you fix the LAD, you still can fix the circumflex, I think so. Later.
I mean, we do stage, we in the first stage, we fix RCA and circumflex, and maybe we wait for maybe 2 or 3 months. The collateral will be better, so we can have better chance to do the retrograde approach.
Yeah, maybe this is another choice, but as you say, the collateral from OM is to the diagonal, not to the LAD. Yeah. So maybe this is another problem. Yeah. So because the major collateral is from the RCA to the LAD.
I think this patient may have the financial concern. Yeah, he used just only BMS for the RCA. I think the circumflex is very diffuse. Maybe need many stents. So I think there are some financial concern.
Because the patient is previously non-STEMI, maybe that sense the
不是红的是
another
小的
choice. Treat RCA first and stage to treat LAD.
Okay, very good discussion regarding this very important question. So Shao-Sung, please go ahead your work. We will move to the classroom number 3.
Thank you.
We will be back very soon. Okay.
Okay.
So.
balloon.
Yi-Lin, we are back.
Yi-Lin,
can you hear me?
Yeah, I can hear you. And now we are already finished the first LAD standing.
Okay.
And I will report just what we do just now. And cutting balloon.
You go
There's a
back
cutting
to
balloon.
the.
It's coming. Yeah. After Professor Lu's suggestion, we use a 2.75 cutting balloon, Wolverine cutting balloon, to treat the most calcified lesion. We can see the dense of the plaque, the calcium. And the balloon was inflated up to 10 atm. I'm afraid of, because beside this plaque, there was no 360-degree plaque. So I'm a little concerned about if we inflated the cutting balloon too much, and the healthy side of vessel will be traumatized, because we already done the 2.0 rota burr. So I just treat this calcified plaque with 2.75 cutting balloon up to 10 bar. After then, I use a 3.0 NC balloon and inflate it to 20 bar. This is the 20 bar, and since it was well expanded, so I try to. I think we have to already can put a drug-eluting stent over his left anterior descending artery. But we have another issue, is that his high diagonal, the osteo of high diagonal is have short, small angle and heavy plaque over the diagonal ostium. So I am now trying to preservation this LAD and diagonal carina. And currently, we are going to deploy a second stent, but we cannot advance
Before you perform the first stent, did you check the IVUS again to see how about the effect of the cutting balloon and the NC balloon dilatation?
Yeah, we checked 2 times, after the Wolverine and also after the NC balloon dilatation, and we can.
So can you show us the IVUS finding? Can we see any crack of the calcify?
Sure. And this is after the cutting balloon, image after cutting balloon.
Chia-Pin, can you give us some interpretation regarding this IVUS study?
Well, even of course we have some calcium crack by the IVUS pullback image, but I am not sure the crack is the consequence of cutting balloon or the initial NC balloon, because I don't see a lot of crack during this pullback. Definitely we have some crack already.
That's we want to have the crack of the calcified region. Okay, so seems good after the interventional procedure. Okay, Yi-Lin, please go ahead to do your work. So what's the size of the first stent?
Okay, the first stent, and we choose 2.5 30 millimeter stent, and this is the angiogram before we
please
stent.
put the angiograph to the main screen, okay?
Yeah, and previous actually we use another 2.5 38.
英九放到主荧幕上面好吗，导播 ？Okay, good.
Okay, actually this is the first drug-eluting stent, and at first I chose 2.5 38 millimeter, but it is a little bit too long, because the proximal edge of the stem will be just near the carina of LAD and diagonal. And I'm afraid if I have 2 stent junction just beside this carina, and I cannot save the diagonal after if it total occluded. So I change the length of the stent. It's 2.5 32. Yeah. 2.5 32, and then next. And it looks the stent was well expanded.
next.
So can you advance the 38 stent more distally?
But
If you don't want to change the stent size.
yeah, but from the previous angio and the IVUS image, we can see that after this small diagonal, there were diffuse plaque over the left anterior descending artery, more distally. There were diffuse plaque. So if I push the 38 lens stent more distal, then we will landing on a plaque. So after this concern, so I change my first drug eluting stent.
Yeah, so your strategy, you will put two stents, one stent in the from the proximal or middle LD to distal LD, and another one will cover the whole lemon, right?
Yeah.
Okay. Yeah. So because you perform IVUS study, so next time you can, from the IVUS study, you can measure the length if you want from the after the first diagonal branch and to the ideal landing zone, and you can see more detailed, more accurate length of the stent. Yeah.
Yeah. Thank you, Dr. Xie, because I think I make a mistake, like I underestimate the severity of the diagonal ostium. And after I realized it was very critical. And yeah, indeed, we have to evaluate the IVUS image more clearly. And right now, I'm going to deploy the second drug eluting stent, but the second drug eluting stent cannot pass the lemon to diagonal, lemon to LAD bifurcation, because I think somehow it's guide is twisting together.
So,
Okay.
Dr. Tsai, are you not going to intervene the circumflex?
It's a good question. At first, I think if it was so smooth, then I can do the circumflex lesion and in the same time. But right now, I'm worried about after I fix the lemon to LAD, and I will lose the lat diagonal, and lat diagonal, the territory is quite large, and the angle is a little bit difficult to rescue. So currently I want to focus on the lemon to LAD stenting.
Yeah, I agree with Yi-Lin's strategy totally, because we are concerned about the ostial region of the diagonal branch. So we avoid to have overlapping of two stents at this location. Yeah, so that's very important.
Yeah, we always try to make our stent the overlap area distal to the diagonal orifice. I think this is a responsibility of the Dr. Jiang. His as a commentator should measure the length of the lesion and recommend the stent length to you.
No. I think I didn't have well discussion with, yeah.
They are a group. So the team is a group. That's a very good job. So how about so what's the current status? You can advance the second.
Yeah, because I cannot advance my drug eluting stent to more distal side because of the guide probably twisting together. So I think I have to predilate the LAD ostium much better, than hopefully my stent can deliver to a proper site.
So what's the size of second stent?
30 and 28.
I think if you cannot just pass your even by your balloon into the previous stent, maybe you can just pull out the LAD stent and then do the LAD wiring again to untwist the diagonal wire, or you can try the third wire to LAD. Maybe it's a twist. Okay, now you pass.
Yeah, thank you. 20.
The size of the second stent 30 may be smaller than the diameter of the lemon. So any comment for the second stent size? Will you use a bigger stent, 3.5? 13.
Yes, I would choose 3.5. And deploy initially low pressure and just the pressure after implant.
Yes. So how about Tse-Min?
I think the Cheng-Ting is the expert of the stent structure, and this because we will use the synergy stent, and the synergy stent is two size design.
Yeah. So because the synergy chart XD for 4.5, maybe and 3.0 and 3.5 is the same same shot. So maybe
use a bigger balloon to dilate the stent more bigger. Okay. Regarding the synergy stent, were you concerned this as an osteal lesion?
Yeah, since this is the modification of the new synergy stent, and there's the
Normal
risk
concern about the longitudinal
the risk of
compression.
the LSD is no more, very much less in the Austin, in the proximal part of the stem, but there is also occur in the middle part of the stem. So we have to careful to avoid the LSD in the middle synergy, but the proximal, I think is okay, because the radial force of synergy is very good.
Okay.
I think that the diagonal branch looks like not more clear. So maybe should we need to dilate the diagonal branch?
Yeah, I have done the 2.0 balloon the diagonal ostium just now before I delivering my second drug-eluting stent.
It looks like there's some twisting of your wire. So would you use the third wire, just as the Chia-Pin's recommendation, the third wire to go into the diagonal branch again?
Oh, just the wiring into the diagonal?
Yeah, new wire.
A new wire. Okay. 让出发票，我们看还有一支。
Of course, we know the new generation of the synergy stent, they strengthen the end of the stent side and design. So you will avoid the previous longitudinal stent compressions and complication now.
So currently,
limit to LED angulation. So could you show us the spider view? To see
spider view, OK。我们一开始照相。And this is the spider view of the lemon bifurcation.
No. Spider.
This is
photo view.
This is IO code. The Dr. Tsai want to the spider.
The lateral view
of
the
spider view.
Can we show the lateral angiogram?
Yeah, lateral angiogram.
This is true lateral. 上一组。
Yeah, LAO view. LAO.
Not true.
Next.
True spider.
Next. Do you have the next?
Okay, next.
哦，这边没有换到。
LAO code.
No this view.
We have error code 75 and code 12.
Okay.
From the true lateral view, maybe you can see the limit to LED angulation is very sharp, vertical,
yes.
nearly 90 degrees.
Yeah.
So maybe the stent is difficult to advance to cross the angle.
The first stent is quite easy.
Yeah. Person profile.
Yi-Lin, what's this guy? Why?
And this is round through floppy. And I use a large curve and trying to re-engage into the diagonal. But the ostium have some dissection because of we already done the 2O balloon POBA.
Okay.
So, yeah, so it's not
maybe more difficult to advance another one.
Yeah.
How about just push this wire into LAD?
You mean into LAD so we can have better support?
Yeah, and also you can untwist.
Yeah. So you change the LD wire to untwist, as Chia-Pin said.
Yes, just use this wire to LAD, and I think this new wire is not twisted with the diagonal wire. And you keep the diagonal wire, and then deliver your stem from this third wire.
Okay, and I think this will be.
You don't need to remove the diagonal wire.
Yeah.
Sometimes the second stem advance because the angulation, the tip will insert or touch the first stem proximal strut. Yes, so maybe you should change the wire and the stem relationship position. Yeah, sometimes we will use the some method, a kind of method. We hold the wire and the balloon stem caster simultaneously push wire and the stem caster. You can change the, yeah, you can close this sometimes.
But in this case, I think the stem was stuck far beyond the bifurcations. So maybe it's not the stem proximal strut to avoid the advancing of the second stems. Maybe it should be the twisting. So we will see.
Yeah, I'm still fighting. Yeah, and I will remove the cyan blue first because still my drug eluting stem cannot come out of the guided. And hope. Oh yeah, it's really. Godzilla. But how about using the guiding extension catheter? Is that helpful?
Will you try just push the guiding catheter and clockwise to rotate to make the guiding catheter to a power position?
Okay.
Because it's a short tip, right?
Yeah, yeah.
Yeah, I just use in this condition. I just use the spider view. You can see the angulation and adjust the coaxial guiding coaxial position. Yeah.
I think the Xiong guide wire probably I really need to rewire a guide wire into the diagonal or just pull out the diagonal wire because from the angel we can see that it's even the new round through guide wire, it was twisted with the Xiong in which was in the diagonal. They were twisted and it impeded my drug eluting stent delivery. So I have to rewire a new guide wire into the diagonal and remove the old Xiong guide wire.
But you mentioned that you can use the extension guiding catheter. You can use that before you remove, before you advance the another wire to the diagonal branch.
Yeah, and so I think probably it's.
And another very key point that Cheng-Ting mentioned that you can shift to the spider view because spider view you can see how about the co-axis or the guiding catheter with the lemon because sometimes you just advance the guiding catheter but the axis is not co-axis. That's very important.
Yeah. And
another, you can advise the LAD wire maybe more distally to have a better support. So do you want to shift to the spider view?
Yeah, I will shift to spider view, but
yes,
they didn't project it onto the screen. Yeah. Yeah, we already used the spider view. And I think the coaxial of the guiding is acceptable.
I think the support of the guiding is a problem, but probably the stem was broken by some calcified crack. So it's not broken by twisting of the wire, probably. So I think the guiding the extension catheter Godzilla may be helpful. You can, because your balloon can go into the distal LAD, right?
Yeah, and my balloon 3.0 non-compressed balloon can pass the bifurcation. I think it's little bit
this is a problem.
resistance. Yeah.
So maybe get
support, but I think the guidewire.
You should keep the guidewire of the diagonal branch. So I think you can use the Godzilla 6 French Godzilla, and try to advance the Godzilla to the middle LAD. You can under the help of the new balloon.
And from the frontal view, actually the stem is twisted with the diagonal guidewire. Yeah, and
make patient take a deep breath.
Okay.哎，阿姨，你深呼吸一口气哦，深呼吸一口气。
No.
Yep. 正常呼吸。So. 好啊，打字下来。
I think there's a curve over there, an angle over there, so not so easy, especially calcified region, not so easy to pass and also not so short. It's a long stem. Yeah.
So can we put the Sion guidewire outside the Godzilla, 6 French Godzilla?
I think we can put the wire together in the Godzilla.
Together, both in.
Yeah. So you can, if you can advance your Godzilla to the middle, I think the stem may be very easy cross the region. Yeah.
For me, I would suggest to outside the wire. Yes, actually for me.
60 French, maybe there's some
60 and 7 French, right? Guiding 7 French. 6 French. What's the guiding catheter size?
7 French.
7 French.
7 French. Or you can use a 5.5
eyeliner, and it will be okay.
So both wire in the Godzilla.
Yeah, both wire in the Godzilla, and now we are trying to deliver the stent. Hope this time we can succeed.
I think no problem.
Oh, thank you. Yeah, and I think the position is better. Okay. 没关系，先不用，把它拉回来。不用，先不用，先把它拉回来，轻轻 test 一下。来，再轻轻 test 一下。So we will focus on the lemon ostium, and should we use the LL cranial? 框起来，框起来 focus 对。OK， 我们还要再回来。我知道，我在拉它。这样。哦，类似这样。要再出来一点，我怕漏。And is this the right position?
Maybe you can out a little bit because this is austere region. Yeah.
Oh, okay. Pull out a little bit.
Yes. I will
Okay.
suggest pull back a little bit.
Okay.
How about AP cranial?
Okay, then frontal.
Actually, I think
Of course, we can check from both LL cranial
yeah.
and AP cranial.
Actually, this view I think is very, very good. You just see the marker just exactly at the orifice, but we know there's a gap between the marker and the stent. So I would suggest pull back a little bit.
And is this the proper position? I think one more, pull back a little.
Yeah, pull back a little. Yeah, it looks good.
Here.
Yeah.
Yeah.
Can we see the AP cranial?
AP cranial.
Yeah.
Here.
Everybody agree?
Yeah,
the position.
Yeah.
So
I always final check rotation the angiogram from share IO to LL. You can make sure. Yeah, just rotate.
Oh yeah, it means frontal. Frontal 先打 IO cranial， IO cranial， 然后等下正 AP cranial 到 LL cranial，frontal cranial 少一点，因为来自 IO 啊 ，OK， 这边先不管它 ，here， 然后对 AP cranial， 然后再 LL cranial，yep， OK。Oh, but it's impinged by guided LL cranial。若且再给我一点 contrast。好。刚刚 device 叠在一起。So is this that's 上一张。So is here okay? 我觉得刚好又比较好。双头看不到，双头哪一个cranial看不到，但是要哪一个？我们看侧边，专心看侧边就好。
Even because the stent will be moving during the heartbeat, so sometimes will move in. So we panelists suggest maybe you can
pull out
for the safety, yeah, pull out a little bit.
Okay.
Okay. 这边 guiding should be pulled back a little bit. Yeah. Agree?
Here.
So can we see a cranial view?
感觉好像有所 Maybe you need to pull back a little bit. Yi-Lin.
Okay.
Because the stent is moving forward and the backward.
It is good here.
I think it's acceptable.
Yeah, I think it's okay.
A little bit up.
Is this okay?
I think it's okay. Anyone?
I think it would be out of the ostium.
Out of the ostium, yeah, a little bit. Maybe moving a little bit.
Move in a little? Okay.
Little, very little.
I will try.
Actually, I think it's okay.
So how about here?
Yeah, it's good. Looks good.
Okay.
Nowadays, I think the design of stem, since the stem will become elongated after inflation, so I don't worry about it too much. So if you want the stem move a little bit out, so maybe you inflate the stem at a low pressure and then keep a little bit tension backward.
Okay. So here we will deploy the stem.
Okay.
I think the ground floor of left main ostium was totally covered. Okay, standing.
Yeah.
6. 10. 12. Okay, one more time. 12. I think the stent is expanded. No, 3.5.
So this stent is 3.5 or 3.0?
No, 3.0.
3.0. Okay.
Yeah. So we will use the 3.5 non-compressed balloon to pop the stent.
Okay.
And 3 by 28, right?
Yeah, 3.0 by 28.
So you, in this situation, one stent strategy, would you routinely do the kissing wire, open the straw, or just close by the proximal pattern?
What's your strategy?
So for one stent, I will routinely do the kissing. Yeah, it depends the ostial side branch.
What kind of the region or scenario you will do the kissing balloon technique?
So if I found a pinch of the side branch ostium,
yes,
and or slow flow, so I probably will do the kissing. Or the ostium or side branch always have existing severe disease, I will do the kissing.
学长 ，Lemon 4.0可以吗？4.0 12的 NC emerge 哦。
应该可以吧？那 IVUS 还蛮大的。
In this particular case, I will do the kiss to open the circumflex cell because we still have a lesion in circumflex. Sometimes if you have to treat the circumflex one day, it will be more easy to do the intervention through the open the cell.
Yeah. So after part, and I will consider, and if make sure the diagonal is okay, I will do the kissing, open the stent rod and kissing balloon technique. If the diagonal is still there.
Okay. Yi-Lin, thank you very much for your effort to this case. We will move to the classroom number 1. We will be back very soon. Thank you. Please go ahead with your work. Shao-Sung, we are back.
Okay. We have some problem during the extradation because the APD microcaster cannot be advanced to the guiding caster. So the RG3 cannot be we cannot change the RG3 caster.
Yes.
So we use another choice PT 300 centimeter wire for extradation. So this is the extradation, the angiography during extradation.
So you think a choice PT because there's a siding guide wide, so it's more easier to close the heel region than the microcatheter. Okay.
Yeah.
So you also advance the choice PT smoothly into the antegrade guiding catheter?
Yes.
Okay, good.
Okay. So this is our stop here. So we will, after extradation, we'll use the balloon dilatation from left main to LAD.
Okay.
No, we rarely use the choice PT 300, field FC 300. In this situation, when your wife go into the antegrade guiding, but the microcaster cannot advance, most of the time we will change our microcaster to another kind of the maybe Cosell or the Caravelle.
Okay.
So now you have set up the externalization system, right?
Yes.
The choice PT, the distal end has been out the guiding catheter already?
Yes.
Okay.
那灯可以照。
调一下灯。
Retrograde microcaster maybe stuck by some natural plaque. But if you use the 300 centimeter field FC or choice PT, because the shaft of the 300 centimeter wide is a little bit steep, very steep compared to the RG3. So sometimes during the externalization, this may cause some strain of the heart, and sometimes will cause will cause the BP drop or even acceleration of the septal. So must be very careful, and the microcaster should be along the whole course of the collateral.
Okay.
Shao-Sung, Cheng-Ting also mentioned that before you advance the choice PT, you remove the retrograde gas second wire, right? And at this moment, maybe you can try antegrade wire tip into the retrograde microcatheter. Did you try that? Did you try this technique?
No.
No, okay. Okay.
So currently, you try to do the balloon dilatation from the antegrade wire, right?
Yes, but
Yeah, the choice PT is different from the RG3 because the tip is more soft and the body is more stiff. Yeah.
Yeah.
So sometimes you want to advance balloon catheter from the tip, it's too soft and not so easy.
The camera can focus on the operator hands.
直接进去吗？出来，在这里。
Okay, Shao-Sung, we will be back later. We will move to the classroom number 3.
Okay.
Yes, to see how the Yi-Lin, he almost finished his case already. Yi-Lin, we are back.
We just finished the lemon osteo standing and part with 4O balloon.
Okay,
and, then we pull back the image. This is the flow, and I think the diagonal flow is acceptable.
Okay, good.
Yeah. So we check the IVUS image, and the IVUS image is
Actually, the LD is quite diffuse disease vessel.
Yeah. And this is the IVUS image.
Okay, good. So Cheng-Ting will be well interpreted this IVUS finding.
听不到俊清的声音。
Yeah, Cheng-Ting.
Yeah. Can you hear me?
Yes, now we can.
Okay. Yeah. So this is the distal stent edge, and as you could see, the stent was well expanded, and landing in I think that you're landing in a relative plaque-free zone. Of course, the more distal side within the 5 millimeter, there's still some discrete lesion, but there's some discrepancy of the vessel size. And this is the distal stent edge. There are no dissection here. And as you could see, the stent is quite well expanded after the aggressive preparation. So I think this is the most calcified part, and the stent was still well expanded. And this is the circumflex into the left main, and you can see the stent was well expanded in the left main, and we a little bit protruding into the aorta, maybe just 1 or 2 frames. So we entirely cover the left main ostium. Yeah.
So any comment from this IVUS finding? Professor Honye, any comment? Shall we do more aggressive stent dilatation?
Yes. You obtained a very nice result in terms of the minimum stent area, and stent after the dilatation with Yi-Lin, we observed a hematoma or dissection, but stent completely covered that vessel injury. And in terms of ostial circumflex, in my eye, the cell is quite nicely open, and we don't see lots of struts over the ostial circumflex. So in that case, I would not touch the ostial circumflex and finish the procedure. Will you check the ostial circumflex with a cross-sectional view as well as longitudinal view, and check how stent struts exist at the ostial circumflex.
So Professor Honye, will you perform the kissing balloon technique in this scenario?
If there is lots of stent struts over the ostial circumflex, then I would dilate with kissing balloon. However, in this case, I think the cell is quite nicely open over the ostial circumflex, at least to my eye. So I would like you to check check it in a cath lab.
So you mean you will put back the IVUS catheter from the circumflex?
No.
No need.
Okay.
阿姨怎么了？再忍耐一下哈。
好，Yi-Lin。
是，yeah. Yes.
Yeah, and all the panelists appreciate your work and your effort to do this very calcified lesion and the main lesion and a very complex lesion. So I think the result is quite good. So thank you very much for your demonstration, very good demonstration for this case. Thank you again. Thank you.
Okay, thank you.
Congratulations for your very successful lab demonstration.
Thank you very much. Thank you for the nice advising.
Yeah. So we will move to the classroom number 1. Yes, Shao-Sung, we are back.
So we use IVUS again to check the wire is in the already Austin is in the true lumen. Yeah.
So you have do the balloon dilatation for the proximal already CTO region already?
Not because the two-point balloon cannot be advanced into the LAD. So
okay, I see.
So yeah, so I use IVUS.
Cannot cross the region.
Yes. So okay. I use IVUS
2.0.
Yeah.
Okay. So would you try the smaller balloon size?
Your microcatheter should put back.
Yeah, but however, the wire length was not enough. I can't pull back because not too long. I don't know why. So the microcatheter cannot be pulled back more. Yeah.
But this choice pity is 300, right? 300 centimeter. So what's the length of the retrograde microcatheter? You use the
150 centimeter.
IVUS is in the circ.
Yeah, because the IVUS cannot be advanced.
Oh, there's some perhaps. So you cannot advance your balloon from the anti-gravity,
Yes.
right?
Yes.
Because the lens.
Yes.
But now, can you advance your microcaster back to the lemon, or you still stuck?
I cannot advance. Yeah.
Cannot advance.
Yes.
So can you advise another new anti-glare microcatheter?
Another new anti-gray microcaster. Oh, okay.
To kiss the retrograde
Okay.
Maybe we can
microcatheter.
try
Yeah.
just Dr. Tsai suggested to
Okay,
do the
okay.
begin, put back the choice PT or field FC,
Okay.
and use another anti-grade wire to try to tip in the microcaster, right? Yeah.
No, you can use the 2.6 French APT microcaster because it can rotation advance and rotation dilatation. Maybe it's a chance.
And you can support it by the anti-glare a new microcatheter, right?
Oh,
Yeah, and advance the anti-glare micro as far as possible.
yes.
Yeah, to keep the high success rate of the tip in. Yeah, tip in 这个。So, or you try a smaller balloon anti-gravity.
Okay. Okay. 可以给我个1.2，有没有1.2或1.5的保论啊？
你要1.2是什么？一般的还是？
一般的，一般的。
一般的1.26吗？
好。奇怪了，为什么会这样子？
So, what's your strategy now?
So now I will use a small balloon to open the radio stand. Yeah.
Okay. Okay. So you use a 2.0 millimeter balloon.
Yes.
But cannot advance the balloon catheter into the pass through the CTO region.
Yes.
Okay. Okay, you can try the smaller balloon. But we also discussed that maybe if the smallest balloon cannot cross this region, and maybe you can advance the another microcatheter anti-gravity and to distal as far as possible.
Okay.
Of course, the best is to touch the retrograde microcatheter, and you can change the another wire from the anti-gray to the distal LED tip in.
So can you put back your microcaster? Yeah.
Yeah, retrograde microcatheter.
The microcatheter, yeah, less not adequate.
But because this is more rare system, right? So you can put back your wire a little bit and put back the microcaster and try to advance the balloon.
我也帮我抓的后头，我稍微拉。
So can you advance the balloon?
Yeah, okay.
Yeah, it is close.
Okay, good. Good, very good.
这一大圈。
好，1.2的不论哦 ，Maximal，超个吧。
14。
14。
好
What's the size of this balloon?
1.2. 1.2.
1.2. Okay.
好，这样。
再次14。
OK， different。
好，5秒。
So now I think you can fully dilate the LAD Austin and then try to pull back and try to advance your microcaster. Yeah, try to go into the antegrade guiding and re-sterilization again using the RG3.
OK， 好，这个打上。
再次14。
OK，
5秒。
对。
好，14个吧。
可以。对。
好，5秒，不能当。
这对车。
好，14。
好，different。
5秒。
那个2.0的保论。
So make sure the retrograde microcatheter can pass through the CTO region. So you will try to direct use a 2.0 balloon.
Yes, yes.
Okay. A bigger balloon.
Yeah.
I think this is a very interesting case, and we have done a lot of technique. Yes. So the next step, just like the Tse-Min said, that we will dilate the CTO region and advance the retrograde microcatheter into the antegrade guiding catheter, and we change the choice PT to RG.
的2.0好不好？
And to do another installation and just like the standard procedure, antegrade approach. Yeah.
I think after the 1.2 balloon dilatation, maybe the microcaster can advance to the antegrade. Yeah, so we can use just use another balloon anchoring the wire and advance the microcaster. Maybe likely that even pass the region. Yeah.
完全不用，先不用了。
出来没有？
出来，放出来。
And Professor Honye, any comment at this moment?
Okay.
好，2.0的不论哦。Maximal。
6个吧。
6。
No, as you said that dilate with the larger size of the balloon and continue your procedure. Thank you.
6个吧。
等一下，带点要掉。好 ，deflect。
10秒。
Okay, Shao-Sung, please go ahead your work. I think you will be very successful already.
Thank you.
And because the time is limited, I have to close this section. And thanks again for Professor Honye doing this lab demonstration course from Japan and gave us a lot of information and comment. I think that's very useful. And I also thank the Chia-Pin and the Cheng-Ting, Tse-Min, and Zheng-Yi for your very precious comment for this lab demonstration course. And I think this morning the case are very successful, has been done. And I hope anyone can stay here and stay in this lab demonstration course. We have another 2 cases of in this afternoon. Thanks again for all your contribution to this demonstration course. Thanks again. Thank you. And I hope to see you very soon in the future. Professor Honye, thanks again. Thank you.
Goodbye, everybody.
Bye-bye.
Bye, friends in Taiwan. Goodbye.
Bye-bye.
这个 ROVUS 的第2个 section 哈。那首先我代表台北荣总欢迎各位来参加今天下午的这个 ROVUS 的一个 demonstration。那在我右手边是吴承学吴医师哈，然后这是我们医院的PCI 的专家。那这个在右手边第2位是那个张其任张主任，是台北长庚医院的主任哈，心脏科主任。那在我左手边是曹典允曹主任哈，他这个是台北振兴医院的心脏科主任。好，最右边最左手边的是这黄启宏黄主任，他是那个国泰医院。哦，那这个也是我们现在目前介入学会的秘书长。那今天我们也很高兴有从香港有邀请到这个 Dr.Lam 来做我们的一个 guest 的一个 panelist。Dr.Lam 你可以听到吗？
可以听到，非常清楚，谢谢。
谢谢你的参加。今天我想我们今天大家就用中文来做沟通。那我们今天我们今天下午本来有安排2个 CTO 的一个 CTO case 跟一个钙化的 lesion。那我早上也坐在这里那看早上2个 case 非常的精彩就是一个 CTO 这个黄少松黄医师做了一个 CTO case， 非常复杂的一个困难的一个 case。那另外一个蔡医师做的一个 Rota， 那个 case 应该已经结束了。那我们现在应该早上的这个黄医师成功的这个 retrograde 跟 antegrade， 那现在是应该已经完成 sterilization。那少松你可以听得到我们讲话吗？少松，有听到吗？那
有听到。
我们又回来了。跟我们讲一下你的进度。
让我现在卡在我那个 microcast 完全没有办法进到该顶里面了，我没有办法前进，被咬住啊。
那这 case 我跟大家简报一下就是它是一个 Lemon Austin 的这个 Lemon Austin 的这个 CTO。那 CTO 长度这个近端 LAD 的地方就有个 dimper。那 retrograde 其实 RCA 中间有个 lesion， 之前放过一支 BMS。那这次 retrograde 其实路不是非常清楚，不过少松很成功的用 Y suffering 就走向找到一条很不错的 retrograde。那用 microcast 是这个 APT。那之后2个 Y 很顺利的接近 kissing 不过后来少松还是做这个reverse cut。reverse cut 之后 Y 可以顺利的走回那个 guiding caster 里面 antegrade guiding。然后但是他遇到的困难就是 antegrade 的即使 anchoring 之后 microcaster 还是回不来 antegrade 的guiding。所以后来他就做 sterilization。那 sterilization 他就用一个应该是 choice PT 300的一个 microcast 的 Y 做完成 sterilization。那刚也 sterilization 之后也曾经用 1.2 跟 2.0 的 balloon 做一个CTO lesion 的一个 dilatation 了。但是目前的卡在这里，就 microcaster 还是没有办法的 advance 回来。那现在应该是目前的 situation。那少松好像 balloon 打完之后，你的 microcaster 还是送不回来，是不是？
都送不回来，对。然后它尾端又不够长，我 microcaster 又没办法往后退这样子。
那 microcaster 跟 Y 咬住了吗？
就是卡在这边，对，我现在想办法看能不能把 microcaster 再退一点这样。
所以遇到这种状况，我不知道各位 panel 对于这个情形有什么其他的想法操作。APT 1.5 French， 对。他现在没搞退回啊。操作。像 sterilization 它是用 choice PT sterilization， 但是长度好像比 RT3 稍微短一点点。所以300而已，所以它比较不好用这个 antegrade 的 device。可以啊，它可以。
好像好一点。
可以松开了，
退不回来，进不去，刚开始是进不去。
对吧？这里有。好，1.2的 balloon 哦。8个bar。14。
好
，5秒。
再一次哦。
再一次14个bar。5秒。
所以14。
好，14。
好，14。
14。好，14个棒。
对，那我们刚刚有一些建议啦，刚刚包括谢理事长跟那个蔡 P 有一些建议就是说看能不能做 tip in 的 technique， 就是说 microcast 我尽量 advance， 那即使还是过不来的话，那就把 QSPT 拉掉之后，用 anti-grade 的 Y 看能不能应该有机会走进 LED 里面，然后走进那个这个distal 的 microcast 的 APT 里面，但是到后来把动可以打过之后，我们本来预期 microcast 可以拉回来，可以穿过那个 CTO segment， 不过好像还是有一些没有那么容易啊，所以刚好在这个位置，不知道大家有没有什么建议？
所以现在主要是说外已经 externalization， 但是呢，那个我看它 1.2 的把动已经有下来，在做扩张了啦。那可能扩一扩，不 ，IVUS 看一下，看威尔的位置怎么样，看一下是不是应该能够出去，应该是在里面呢，可以 IVUS 看一下，了解一下。那或者是用把动再扩一扩，看看。
再一次14。
好，比分。
RCA 那个要消掉。
消掉
就说你现在 anti-grade 的把动已经过了嘛？
对。
已经到对有点远端。那你像 retrograde 的那个 microcast 还是没办法送回去吗？
它就会卡在那个，不知道是我旁边我再试看看可不可以送，但是我想2.0的打完之后再看看。
有没有可能送一条那个 double lumen caster？
对啊，你用 crusade
我用 crusade 可以，对，
你把弄出来，然后弄个 crusade 或者 Sasuke 下去，
对。
企图是，所以抱歉，有点没有进入状况。现在企图是希望把 RG3 换出来，目标是这样吗？sorry， 是希望把 QSPT 换出来，
或者是要有一条 anti-grade 的 Y 能够过去。
OK， 不过现在应该蛮有 chance 啊，如果 balloon 都下得来，那 double lumen caster 下换。
有时候 APT 比较软呐，稍微有点折到，为什么会跟 Y 咬在一起？他做也时间有点久了，所以我跟你讲。
应该不是你举的问题，应该是下面那抽规的牵到去咬到。
不过它因为 LED 的那个开口的钙化有点厉害，所以这个可能 anti-grade 就是东西不容易过去。不过看起来应该胜利在望。那 Dr. 你对在这种 situation 你有没有什么建议？就说 retrograde 的 microcast 一直过不来。
我不是太清楚这个病例，给不了什么好的建议。这个情况我如果就这样看的话，我觉得这个 double lumen catheter Sasuke 下去，然后用个 workhorse 或者 hydrophilic 的 F-field FC 或 C-on bed。
对，
找个出入门，然后就转成这个 anti-grade system 去做这个 ADCTO， 可能最安全。刚才看的时候，这个 ECG 呢 ST depression 很厉害，我不知道别人血压情况稳不稳定。如果在这种情况，这个
2.0 的 balloon 哦 ，distal
跟这个 wire 是不是 fusion 咬住
？6个吧。
如果咬住的话就很麻烦，可能试一试这个可不可以松出来，如果不能松出来，可能要搞定这一个再做稳定的病人，搞定这个 Y 跟这个 myocardial fusion 这个问题，然后再做其他的考量。
是，
对。
所以少松你retrograde 的 microcaster 是不是咬住了，没办法拉回来？
可以，他现在应该是主要他远端的那个头，我觉得好像 Y 也不够长，所以我没有办法一直把它退出来，就只能先退到这里这样子。
好，5秒。
我建议你不要再退了，因为那个这
刚不是
个刚在concern的就是说这个 QSPT 的 shaft 其实蛮硬的。
对，我不敢再退了。
对，这一段在 septal 里面其实有点危险，会 laceration， 一定要有 microcase 来保护啦。所以你马上打一打之后，我觉得就像刚刚曹主任建议的，
对，我觉得可能用少数可以下去用。
过去换成 integrate Y， 那就把 retrograde 整个撤出来了。
好。
那因为我们这个是全部是新的一组人上来看，可不可以看一下 initial 的片子一下就好了？可不可以 initial 让我们看一下？
好。
你做了一个程度以后
，14。
integrate Y 换完之后，再让我们其他的 panel 看一下，嘿。
好，那个少数可以了。
这是一开始的 RCA 的影像，嘿 ，retrograde 看起来有一些 faint corridor， 那 integrate 的话是这个样子，嘿，那有一些钙化，嘿，钙化蛮厉害的，对，不过还好，就是 integrate 跟 retrograde Y 前进的时候，好像都还蛮smooth的，没有说遇到钙化很难走这样子，倒是还好，两条其实位置看起来是蛮不错，就叠的不错，所以 retrograde。integrate 做 reverse cut 一下子 ，Y 用 Gaia second 就过来了，对，这 Gaia second 进到 guiding caster 也很顺啊，但进去之后它的 trapping
可以长怎么样
？APT 怎么样推？我们都进不来，就卡在开口的地方，可能是一个钙化。
应该这个。
在没有 RG3 之前，其实做 retrograde 我也用的就是这个。QSPT 啊，那当然那个感觉真的很不舒服，那个对整个心脏 traction 的力量，不管尤其是最后要回拉的时候，那个感觉是好像每一次都在跟心脏拔河的感觉一样，所以可能真的是会需要小心一点。所以当时是因为没办法microcaster 没办法推得更远，所以
microcaster 进不到该顶里面，只能到接近 LED Austin 那边，然后用RG3走好像走不进去该顶，所以只好用那个 QSPT 让它直接走进该顶里面这样。
那 Cheng-Ting 我自己有一些经验啊，那因为那时候尤其是台湾很多这个 microcast 健保没有给付啊，我们用就是比较勉强，不是比如说不是用 Corsair， 那甚至于是后来用比如说用 Corsair， 那 Cheng-Ting 如果像这样是钙化一定程度厉害的话，我觉得我自己不太有成功的经验哦，因为那个你如果是 tip in， 那这个 wire 整个 support 其实不是真的这么好，那我觉得那个卡住这个要 tracking 这个 wire 的这个力量不是太好，所以其实我基本上印象里面真正过去的我都觉得机会不太大。
那看起来很顺。对，的确就像刚刚张主任讲的，我们经验也是，你retrograde过不来 ，integrate 场也过不去了。
那个
即使 Y 过去了，然后 support 还是不好，还是过不了。不过这 case 因为 integrate 把已经打过了，他可能retrograde那个他 microcaster 回来的时候刚好遇到一个钙化，每次都卡在那里。不过现在看起来，那个少数可以过去的话，应该很容易。这个
很恭喜啊，对啊，
应该成功在望。
搞不好这个可能要 Rota， 你看那个 IVUS 看起来，应该是360度，还不是很短呢。现在
IVUS 刚刚有做过是？我们还没看过这个 IVUS。
IVUS 还没有。
哦，所以那个不是，那是
左下角
那个是蔡依林那边的。
等我们外流下去再。
所以这条是 Sion，
这条是那个 Sion Black
啊。
这个是diagonal 嘛？
或者你 double room 再换个位置看看。
对啊，你进 diagonal 之后把小数可以拉回来，然后再拉外，应该很容易就进主干了。
对，我也是这么想。如果你的希望 bed 进了这个这么好的 diagonal，你就换一个Sasuke 去这个希望 bed，或者就 IVUS 看一下，用这个希望 bed 做 wire，然后 IVUS 看一下，然后就用这个 wire AD 了。
头在哪里？灯可以看一下。那这。
好，恭喜到有点远端了，嘿，这个没问题了，嘿。
好，那我就把，那我现在把
退出来
退出来嘛。
可能要小心，可能要 check 一下看有没有 perforation。
好，
我不知道病人的 hemodynamic 现在还好。
还可以，对。
好。
所以话说，如果当时看到这个 CTO 这一段或者整个 LED 是相当程度钙化，选择这个 retrograde microcaster 会不会有不一样的选项？
其实我本来是用 Caravelle， 可是我们现在好像没办法用 Corsair Pro 了。那 Caravelle 它一开始就上不来，那个 microcaster 在 collateral 那边上不来，那所以后来才换 APT 1.7 French 的，好像它慢慢就rotate一下，可以慢慢前进就上来这样子。但它就被好像咬在这个钙化的地方，好像就被它咬住，我就很难前进，就一直没办法前进进到该顶里面这样子。那帮我打出回 system 出来。
哦，对，我想对。
也许那个 Corsair 可能可以了。Corsair 如果可以用的话，其实在这种situation可能还是可以试看看，因为它至少可以旋转了。
如果在这种情况，其实你一回做 PCI 都用 integrate system， 那 retrograde 的 system 可以拿走这个试一下，可不可以拿走这个 PT choice， 然后换另外一根导丝 wire 进去，然后看这个 microcatheter check 有没有 perforation， 然后看这个 microcatheter 可不可以拿走。所以这个我很怕，我也试过这个 wire 跟这个 microcatheter fuse 在一起，可以很麻烦的。
是。所以我觉得这是很好的建议了，就是说先从把 choice PT 拉出来之后，再换一个试用进去，然后再把那个 microcatheter 往回退，然后这时候 check 看看有没有 septal 的 perforation，因为这样子如果说有的话，还可以处理，全部拉出来，如果破了就很麻烦。
是。
对，少松，你现在拉现在拉 choice PT。OK， 好。
那这个应该每一个 beating 都会有感的，
很有感，
拉一下，
非常有感。
对，那时候血压会掉。
那我要先 integrate 先做完再。
不，你觉得还是要送一条外进去啊？你要送一条
外到，那就我们还有什么？
就上一条线就可以了，
那有实用吗？可以给我条实用。我们有实用吗？好像
所以这个 case 还是蛮复杂，还有很多事情要处理哦。所以 LED 弄完以后，你那个 left main bifurcation 那边还是要也是钙化，然后一个 left main bifurcation 要怎么处理，那个也是另外一个 issue 了。对，
大家会建议就 single stent crossover 就好，还是
可能要看 image 吧，哎，
看 image 好。
其实如果现在的话，应该尽量搞定这个 retrograde system，make sure 它没有什么 complication， 没有 perforation， 然后整个 retrograde 就撤出去，然后就专心做这个 antegrade 的 system， 因为你 antegrade 也很复杂，看这个 IVUS 应该要 motivation 啊，做一大堆东西，所以如果 retrograde system 可以完全稳定，这后方稳定，然后再集中火力做这前方，可能会好一点，安全一点。
这是很好的建议哦。我们 check 看看这个 retrograde system 有没有什么问题？对。
可以看那个 code AIO 吗？
好啊，那这时候把那个 microcluster 好像可以往回退，然后从RCA打个药看一下。不过少松，我注意到他那个这个 radiation 的 dose 好像有点高了哦，可能要。
这个嘛，没错。
对，就这样。
好像还可以。
你要退多一点啊，要退多一点。
再退多一点。
哎，对啊，退到 PDA 啊，你要退到 PDA。
你们一般会不会先做完这个 RC 一个 lesion， 然后再做这个 AD 呢？或者是留个 wire 在 RC， 然后就做 AD？
觉得RCA 的 lesion 可能也是要处理啊，那是一个上次放 BMS 的一个 ISR。
那我们就
好，那就专心做 integrate 就好了，因为我觉得 radiation dose 真的太高了。
OK， 好。
或者还有那个你的 projection 可以调整一下，
调整一下角度哈。
不要固定个 projection， 那这样可以避免一些 radiation injury。另外呢，如果现在已经确定了，我另外一个做法就是，当然就是可以把，当然这个那个 Hsin-I 的那个 rate 可以减少一点了哈，从15到7.5。那另外一个就是把那个什么那个 I 调小，从那个调小那个。就我觉得调小是所有的 radiation 的 progression 是最有效的 I 调小，从20调成25。不过当然你的眼力要变得很好，但这可以避免到 radiation 一直累积上去。
对，就调25啦，哎，看到那么大，这样对 radiation 降低会最有效。然后可能换个位置，哎。张主任，你们那边做都是几个 friend？ 很常规。
我过去其实常没有真的这么 pay attention 这个部分的。不过现在大概包括我们年轻人，大概就是一部分的 procedure 会。
开一个 new 的2.5把论好不好？我吹屏一下。
Dr. 林好，你们那边的那个 radiation 都是用大概会怎么样 take care？ 就是还是说用降低这个 frame rate， 还是说用像刚曹主任用比较大的 field 做？
我觉得你们非常之好，就看这 radiation 看得很谨慎。我们的从2012年开始，我们基本全都用7.5，不用15了。还有我发觉这个 radiation 来源呢，很多是来自这个负偶的，然后我就把它以前那个型号我就其实可以叫的，我搞它0.8。就是 low 的再小20%，这样这个 radiation 会小一些。其实这个负偶的调教也可以的，但是要跟这个Philip 的工程师说，他们可以帮你调小的。但是我发觉了，如果你这样你搞定7.5以后了，你的负偶了，一般呢我们都会用15的，如果负偶搞7.5的话，看起来就很不舒服了。另外就是我们有一个记录本，比如说如果你超过3个 G 的话，就会记住，然后护士会记住，然后如果你很多超的话，就跟你谈谈话啊，这样或者看看那个 case 是不是需要这个什么可以改善啊，这样有一个机制。这样做法，
对，你可以看到现在那个 flow 哈，它每秒就增加1，所以还有个方法，像我 routine 都是采，因为 Philips 的话，它是有所谓的 low flow、normal 还有 high flow， 对，那一般都default 都设在 normal 嘛，那我们那个按钮直接按到 low， 所以我的习惯就是 low flow， 然后诊断我都用15的，那诊断看清楚，再做 PCI 我全部改成7.5。对，大概 protocol 大概这样子。那如果是那更久一点，就会变成25。那这样可以这个，还有一个机型也是一个问题，就是说，Philips 的老的机型，它的 flow 跑得很快。那现在那个机型像那个Azurian， 那个就是很好，那个就很慢，所以跟机型也有关系。所以有钱就换机器吧。
对。这就是我说的，曹主任说的很清楚，就是它可以 low 跟 normal 什么的，我们呢是 default 就用 low 的，其实 low 呢还可以再 low 的，我们因为它这个 design 是 for 这个Caucasian Western for Europe 的，他们一般比较体型大，在亚洲人不用这么大，我们就把这个 low 在0.8这样。而且平常都研究什么个体位会最好用 radiation 最小，比如说这个 RC 的话，就用一个 10-10， 就是 LAO 10度 cranial 10度，这个角度做 RC， 一般你可以看完你要看的东西，而且这个 radiation 是最小的 10-10。
对，我完全同意。
就是 LAO cranial 就最好了。
每次带着那个 fellow 在做，那 fellow 都是为了他们都反正大家习惯，RCA 一定是 LAO， 那 cranial 就调到很厉害，那个下面那个射源都打到我们的脚了。我说不要这么大，你这样就射到自己嘛，那个 radiation 太大了。对，所以就是小的 cranial 其实就看得很清楚了。
对，还有这个 radiation 出来就 stem boost 会用很多的，就尽量RC 就10就10度这样就是比较好。还有其实除了这样剪之后，我们还会再加一个环板在这个 lateral tube 那边的，这里再加一个板，这样很难说。就是另外再加一下透明的防 radiation 的板。
还有就尽量用 store flow 就好了，就说我们不用每个 image 都照相，反正你已经那个就 store flow 啊，这样也可以减少一些 radiation。
对，在这哦。
其实最好的就像曹主任说的，换一个台微星，对，真的，我们换了新的 Philip 之后，这个
6个半。
这个
8个吧。
我们导管室里面有在 take care 这个 radiation dose 之后，我觉得这10年来好像都没有再发生 radiation 的 dermatitis。过往真的发生的机会比较高。不过这 case 真的稍微高一点，12G 有点高，可能之后要很小心。
这里再测14。
可能等一下都用成一套 IVUS 来 just。
那这个病例其实非常困难，我觉得黄医师非常厉害，这个可以做到，已经是一个很好的结果。有时候微滴层真的没办法，这个有。
其实大概已经做了，应该5个钟头了。
IVUS。
像这个 CTO 的 case， 那个如果你们都是怎么去 monitor 它的那个 ACT， 每小时还是每30分钟？像这么长的 procedure，
我们现在大概常规就是因为它这个应该是一边手一边脚吧，然后我们那手进去之后，当然我们会就先打5000U， 那之后要做 PCI 的时候，他会打5000U， 之后那个时候我们大部分的 procedure 会测一个 baseline 的 ACT。那之后就看补了5000U 之后，大概1个钟头以内就会测第一次。那之后就是每半小时测，看那一次测的状况，可能会再加药，加heparin。
可以了。这个是哪里？
这个是从社可拉回来的 IVUS， 在一开始从社可那时候要看 LED 的 Austin 的时候，
这边呢？是 LED 进来了，对，好
middle 到
来看到，好
middle 地方好像有个 critical lesion， 对。
IVUS 人到这边阻力就很大，我先从这边拉回来好了。
所以呢，你这个很可能其实这样一定要 Modification， 但是你 RC 有一个比较 critical 的 lesion， 可能要处理了 RC， 然后再去做这个 Modification 比较好。
整个在外面了，
好像在外面呢。
是。不行。
这个做 Modification 也很危险哦。
对，他好像看到有一大段就是在外面，可能
做。
找 live 看一下。
一般这种情况，我不知道，大家会不会这样处理？我会先做完这个 RC， 然后 AD 就算了，就放一个支架 2.0 什么的打一下，因为它这样呢有 calcium nodule 有这些东西，你根本不可能打太大压力的球囊，就等它 stand 匀了 stable 来了，然后半年1年之后回来再慢慢搞这个 AD、CTO， 因为它本来就 CTO。
就类似像那 investment procedure， 就是把那个。
对，因为你现在放了支架，你放了支架之后，你肯定打的开的不好的，而且你如果用大球囊一扩，它就会破的这种。
他没有跟我讲，应该就不用讲。
看起来有一大段都是在血管的外面哦，这个可能 那目前也不太适合 stent 了。
对，
对，我觉得如果不想 stent 的也可以，
是现在
那就 investment。
所以问题是他现在有没有 perforation 啊？你因为2.0你都打过了嘛，你可以轻轻从
对啊
integrate test 看看。
看起来 distal very distal LAD 是在出入门嘛，那
very
外耳
distal 应该
过了
是嘿有一
所以
段
所以
这个
只好把它整个
是怕对，我也怕它会不会
连在一起
会不会 perforation 啊？哇，这里
哦，这个一定会 perforation 的，对啊。
对，那这种情况的话，stent 2.0 stent 有时候可以把这个 perforation 开掉的，但是如果这个位置你用 cover stent 也是麻烦。
所以如果目前没有 perforation， 是不是就哦？
你可以把 angel 调过来嘛 ，angel 看一下。
Angel 可以把它移到那个主画面吗？
哎，我们今天下午的那个一导馆的 IVUS commentator 是黄伟杰黄医师啊，黄医师在吗？
是，
你还是跟我们解释一下 IVUS 的 finding 好了。
哦，好，是各位早上。那因为前面是那个张俊清学长看的哈，那我们来看一下他其实之前在
IVUS 帮我们调过来好吗？哎，调到 main screen。IVUS，哎，导播麻烦，哎 ，OK， 好。
好，那各位老师好，那我们现在看一下，就是一开始一早上的时候，其实是从 circ lesion 来 pull back 到 layman 去看 identify 那个就是 LAD 的 entry point 哈。那我们可以看一下一开始的时候，它在 middle part 的时候，其实这边有一个 calcified lesion， 到比较接近circ Austin 的时候，倒是 disease free 没有到这么严重哈。那接下来就直接到我们今天下午的 LAD 的这个 lesion 哈，看一下哦。那我们可以看到这个其实是从 LAD distal pull back 到 layman 的一个影像。那似乎在比较LAD 比较 distal part 有一点点出入门之后，好像都是进到像这边都是进到 force lumen 这样。
这不是 force，这已经在外面了。
对，在外面，
有人嗓的外面了，
已经在外面了这样。所以可是又比较铺背到 LAD 比较 proximal 的地方，可能这边可能也这不是哈。
这个都还在外面，在钙化的外面。这个叫小阴体嘛。
对。
然后这个再进来。
对，这个再进来这样。那就像刚刚就是各位老师所建议的，是否这边前面先架支架，还是说再接下来处理，先把 RCA 先处理完就好了这样。
我想要不要 try 在 proximal 的地方用 balloon inflate 一下，看看有没有办法 stop。我觉得这个地方放 stent 大概变数非常的多，你也不知道是不是可以收拾，那而且就 lost 了所有未来可以 approach 的机会。所以如果 stop bleeding，stop the procedure， 当然这个现在因为 distal 也有 connection， 所以会需要非常小心确认是不是 stop bleeding。但是我想这是一个 chance。
或者看看现在 echo 看看有没有 Calcification， 如果都没有的话，我是觉得就直接停了。对啊。
可以看一下 echo 吗 ？echo 可以看一下有没有 Calcification。
这个停要很小心哦，因为这种呢 pseudo aneurysm 呢，它会 progress 的。如果它出了 CCU 3-4个小时就破，可能很麻烦。可能好像之前的一位老师说的，放个球篮在 proximal AD 就2.0什么的，摔住这个 antegrade 的血流，这个最重要，因为 retrograde 的 pressure 其实很低的，低的就像 wing 一样，静脉一样，就等它一回，然后就1-2个小时以后回来再看，肯定没事才出去，因为出了去之后，万一有事的话很难搞，这个再挖呀或者怎么做，而且它 RC 是有一个 critical lesion 的，有时候有事的时候就变化很快，
另外一个如果真的不行了，就是 surgery 啊，就是 cabbage 呀，所以就最安全的，可能比较安全。
contrast 的 watch 的很快啊，所以
I 先退可以。
echo 做了吗？
正在推哦，我们推 I。
OK， 好。血压目前 hemodynamic 还好。
现在血压还可以。
哈瑞也都还好哦。
其实现在如果没有特别不怕的，就在 Osteo AD、Post AD 就放个短的2.0球囊摔住，避免它有进一步的问题。
好。
那个。那 face 在。这怎么动？
它 IVUS Post AAD 这一段好像是没什么问题的，这出入门的。
这病人的 LV function 好吗？
不好，大概40，一大概40。
是，我想需要。
你再低一点，因为这个球囊可能会影响这个血流，放低一点会比较好，就会是。
这个 angel 看起来是真的要小心，有点水的样子，外面那一圈。
对，是压力不用太大，就2、4已经足够的，因为只需要减慢这个血流或者减低这个血压，去这个移植有破损的地方就行，就。
echo 看起来怎样
？echo 机器在开，还没有定，等一下。
我觉得你的 balloon 可能要拉回来一点哦，你这样可能
拉回来一点。
subintima 的 space 可能要塞到 Austin 就好了，因为你很快，等于说你从 Austin 一下去，很快就到 subintima 了。
感觉他很靠近对 left main 才进出的。
IVUS 从 apical view 看起来其实是没有什么precardial fusion，然后
这好消息。那 subcostal
也没有，几乎没有，对，几乎没有。那其实我觉得他的 wall motion， 刚刚邵总讲说40几，可是这个看起来应该有超过50呢。
有超过50，那就好。
apical 动比较不好，可是整体的那个 wall motion 应该是超过50这样。好 ，OK， 谢谢。
好，谢谢。比较麻烦，就 antegrade、retrograde 可能都会渗啊，所以这个病人还是有很高的 risk 会 delay tamponade。
我觉得他 antegrade 摔在这里就一般都安全 ，retrograde 去到哪里的 pressure 已经很低了，就等时间，然后喝杯咖啡看着，然后半个小时回来没有 effusion 没有什么，然后就离开。
暂时可能就先停在这里，如果能够止住是最好，就将来还有机会再试看看。
也许还是要 consult 一下那个了 cardio surgeon 看看，有一个 backup 嘛，对，如果紧急的话还是可以。
另外，我想叫大家在这种时间 reverse 不 reverse heparin， 其实每次这是一个蛮讨厌的 issue 哈。我们reverse 就很怕这个 thrombosis， 那我基本上是会先试试看这个 stop， 用 balloon tamponade 看看能不能 stop bleeding。这个 reverse heparin。
在一个 new 的2.0，它那个保论包怎么打不起来的呢？对啊，它那保论包是破，它这个打论啊 ，ACT 好对。
好，
在一个
那邵总，
2.0
我想
的法论。
先处理一下哈。那我想
好
这3导管好像也暂时还在准备。那是不是Dr.Linko， 我不知道你的 slide 好像准备好了吗？
哦，准备好可以。
OK， 那我想我们就先请 Linko， Dr.Lim 先给我们一个 special lecture 哈。那 Linko 其实我们应该是常常在网络上见面，而且 Linko 常常来，都很荣幸能够邀请他来参加我们台湾很多的这个线上的会议哦。那他是非常这个很有热情，而且非常有经验的一个PCI 哦。那他目前是这个香港大学的一个 Associate Professor 哦，那还在屯门医院哦。那我看他是其实得到非常多的 award 哈，也做了也在各个大会里面有参加，当做这个 panelist 的 commentator 哦，那是非常有经验的一个 interventionist。那今天他要跟我们一个 special 是主要是在讲这个 calcium 的处理哈 ，calcium 的 modification。目前我们 PCI 的一个 tool， 我知道在香港哦，各种这个治疗钙化的利菌的工具哦，比我们齐全很多哦，包括这个 IVUS 或者是 Orbital 哈，在香港的医生都比我们有经验很多哈。那今天我们很高兴能够请到 Linko 来分享他的经验。好，那我们就来热烈掌声欢迎 Linko。
谢谢卢主任。其实我也很喜欢来台湾，因为台湾的技术其实实在是太好，每次来都学到很多东西。今天我就分享一下，最重要是说这 calcium management 的工具。这个情况其实我们也不是有很多的工具，比如说 laser 我们就没有了，我们只有这3个东西 water pole short wave 跟 orbital atherectomy 就是 CSI diamond bed， 你看你喜欢什么名字了，就这3种。这个 water pole 呢就比这个以前的 water 呢进步了很多，用了很多，以前用手用脚，现在就不用了，只用手就可以了。而且它的 monitor 你可以看到这个触度很清楚，而且如果有剪出的话，它会出一个3角形。这个其实都不用多说，因为我问过台湾的朋友，其实你们都有 water pole， 而且如果我看过，比如说黄医师的 Modification case， 还有很多台湾医师的 Modification， 其实是世界第一流的，很多地方都没有你们做到这么好的水平。其实我也跟你们学了很多东西，怎么用这 Water。其实这个只是换了一个更深的 Advanced 这样的东西，没有什么太大的分别，但是确实是好用了很多很多。其他的东西都是一模一样的，所以这个呢，在其他地方我会多说，但在台湾我觉得没必要多说了。第2个工具呢，就是 short wave balloon。short wave balloon 呢，这个比如说用一个病例来说，这个是个 end-stage renal failure 的 case， 它很钙化。我们看OCT 这个会看得比较清楚一点。那你一路看来，这里呢有很多钙化很严重，360度，而且这个钙化很厚的。而且呢，它的钙化呢，这血管很大。如果你要做这个 Modification， 你要2.0的磨头，360度才可以把它磨掉。这个病例呢，我们用这个 short wave 就把它 short 然后这个 short wave 呢，如果用了上去呢，会怎么呢？你可以看到有很多 dissection， 一般用完 short wave 之后没问题的。你说 balloon 然后 short wave 然后这个血管爆破 rupture， 这个是没有见过的，但是这个 dissection 就基本 100% 有。所以呢，如果做 bifurcation 的时候，如果腮帮很重要，一定要给一个 wire 做 protection， 要不然 dissection 会 close 这个腮帮。我试过这个 short wave 这个 left main 之后 close 这个 circumflex。那你看这个，它可以碎了这个很多这个 calcium 360度的全都碎了。它因为是 concentric 的 calcium 呢，它就很有效。你看它这个厚度的 calcium， 它可以完全碎裂。就算这么厚，它也可以碎。 如果你用其他的方法 atherectomy 的话，你要把这个搞定 ，CSI 搞不定这个。如果 VOTA 的话，你最少要2.0的磨头，这个磨头的话可能危险会多一点，但是这样呢 ，shortwave 就可以把它搞定。然后这是 post PCI 的 angiogram， 这就是 shortwave 的好处。另外一个好处呢，比如说这个LC CTO 啦，这个 LC CTO 啦，我做的时候呢，这个 subintimal 了，这个我当时呢，我以为我是不能下班、不能放工的了。这个如果要做 retrograde， 这个很麻烦。但是也有一次 redirect 的时候，不知为什么就出了门，然后我就很开心，就小球囊开，然后就放支架，发觉开不了，我就 NC 打到28也开不了。那这个就是这种情况。这种情况呢，如果用 Modification 呢，其实很麻烦。但是呢，这种情况呢 ，short wave 啦就容易处理。那但是呢，这个 short wave 的 deliverability 呢就不好，不像 VOTA 你可以走进去，比如说这个 proximal RC 在这里用 AL guiding， 我还要加 guide extension 才可以把这个 short wave 送进去。但是很快呢，他就把这个 short 一个 cycle 这样就把它打开了，然后就完成了。如果这个情况深加这个 stent， 我要搞定它，再用 Modification 的话就很麻烦。这就是 short wave 的好处。这个 CSI 另外一个 tools 就是 orbital atherectomy 啦。那我特别选这个病例来说一下，就是你看这个病例它的 EF 都是很低的，就是20左右的，很差，开化很严重。然后你见到我要放 impeller support 去做这个是为什么呢？这个 CSI 呢，它的磨头呢是在中间的，不是在前面的。它的用法用起来呢，当你用的时候呢，它你很慢，不像 Modification 你可以很快去做，你可能是1秒1 mm 每一个秒钟1 mm 这样去，那你可以想象一下，这个是有体位的，有 size 的。你把它摔进这个血管，它 EF 很低，它就会 ischemia， 它这边顶不顺的。而且呢，你要小心它这个CSI 还会不断碰这个水，然后再摔住。它的不像 Modification 这个水就是 lubricant 这样出来的水了，是很小的，它是很多的。然后有时候我觉得会做成 ischemia， 而且听新加坡的朋友说，这个 no refill 的情况出现会比较多一点。万日这个 low EF 的出现 no refill 的话就很麻烦。但是在这么多问题底下呢，我这个病例为什么我还会选这个 orbital atherectomy 呢？就是这里，我盯着这个让大家看，就是因为让你看这个 calcium， 其实 calcium 可以在 inner 也可以在 outer， 在一个曲面的情况下，在 inner 的情况呢，你可以想象一下，如果你推这个 Modification 推过去，通常就会好像跑车一样，就拐弯会做这个 Modification atherectomy 在 outer 的 surface。inner 呢是做不了的，理论上是这样，实质上我发觉不一定，但是理论上是这样。如果你做CSI 呢，它因为它磨头其实是在中间的，那有什么好处呢？就是你可以 push 也可以 pull， 就是我推下去的时候我会磨一些 calcium， 我拉回来的时候也可以磨这个 calcium。当你拉回来的时候呢，理论上就会磨更多这个 inner curve 的 calcium， 这就比如说 RC 这个 AD 这个位置，有时候这个 calcium 你用 stent boost 用什么一看到这个 calcium 比较在耐弯的话，可能这个 CSI 就比较好。 这是它基本上唯一最好的优点。另外这个跟这个 Modification 有一点不同的地方就是，你用这个 CSI 过完这个血管呢，它不像 Volta 一样，Volta 会走这个 polish 就抛光打磨一样，就很滑，很容易推送东西。但是 CSI 完之后，有时候不一定，有时候会更难 deliver 东西，有时候会deliver 到，但是有时候呢也是 deliver 不到的。比如说这个在这里 essential calcium 这个 software 是没有什么用的 ，Volta 我怕它就只做 Volta 做不了 inner， 所以就用了这个 CSI， 因为这么多缺点也选这一个。那这就是这个分别 ，Volta 这个头在前方，CSI 的头呢就在中间，所以你说 causability 的话 ，Volta 会比这个 CSI 更好。CSI 呢，它的好处，另外一个好处就是它跟 Volta 不同 ，Volta 你剪这个粗度的话，你就可以做更大的血管，做磨去更多的东西。但是这个 CSI 是你增加这个粗度，你才可以磨更多的东西。血管限制也比较多，比如说你小个 2.0 的，你做这个 CSI 就很危险了。但是 2.0 的做 Modification 也可以。如果你生发完支架这个有支架在的情况，做 Volta 是 relative contraindication， 但是也可以做，每个人都做过，我们都做过很多都没问题。但 CSI 呢，就是他们厂家就很保留这个是一个，因为它的 mechanism 是在中央这样装，这个有支架的情况用就很麻烦，有危险。但是这个是不是完全不可以呢？有 case report 说可以，但是这个就不是主流可以接受的意见，因为如果真的出事，你可能很难防卫自己啊。那这个做完之后的效果啊，理论上可以，实质上做完也真的打开了，这就是 CSI 的总结吧。所以呢，我说工具还是工具，最重要还是怎么去用这个工具。我个人的经验呢，就是最主要你知己知彼就百战不殆嘛，就是对症下药，你一定要看清楚你的敌人 calcium 是什么情况。我最主要是看2个情况，一个是 location， 一个是这个它的特性，就看这个是不是在 ostium， 是 ostium 的 lesion 啊，在 inner 或者是 outer 啦，这个 calcium 的位置 ，ADLC shed 啦，这个 tortuosity 的情况是怎么？还有这个移动的 movement， 它有时候有一些 lesion， 比如说 LC 它 move 的很厉害的，我一般会用小一点的磨头去磨，避免这个 perforation， 因为磨的它动得很厉害，如果在 tortuous 再跟 eccentric。基本上你用带磨头的话，一般都会穿的。另外就是看这个 nature，eccentric、concentric， 这个很重要，因为 eccentric 的话，其实我们用了大概香港15到20% 的 short wave， 我们 center， 我们发觉 eccentric 的话用头不是这么大，而且不要太迷信这个 short wave 的效果，它是有的，但大概等于一个很安全的40ATM 的 OPM balloon 扎下去，但是它很安全，一般不会做成这个 vessel water， 但是你说它很有效去这个 eccentric， 我看你的彩数不一定的，因为 calcium 其实也有不同的 calcium， 有不同的硬度 ，concentric 的话，这个所谓就很有效。Volta 也很有效，CSI 也很有效 ，concentric 就全都有效。但是 eccentric 的话，CSI 也没，就是 orbital 也是没有什么太大的用处，而且也有危险。Volta 还是首选，这个 eccentric。这个 instead 呢就是Volta 或者 short wave。 一般来说，如果imaging 看这个 eye cell 啊什么的是这个calcified eye cell 的话，一般都要先 Rotational 然后再 short wave， 因为你 Rotational 跟这个 short wave 的分别就是你可以把 calcium 磨走 ，short wave 它只是把它碎裂。你好像我刚才收这个 OCT 这个 short wave， 你看就很清楚明白了，它很厚的 calcium 都可以把它碎了，但是碎的这个 calcium 还是在这里，它这个 calcium 只是裂了，它没有磨走，没有减小的。另外就是 calcium nodule， 我相信所有人，你问有经验的，每个都说 calcium nodule 就是 Rotational， 这还要用比较大的 Rota 去做short wave CSI 都不是首选这个，所以现在看清楚以后呢，然后再选择。我们在选择上是怎么的呢？现在我们的做法一般都是 Rotational first， 就一般除非有特别的情况，一定是 Rotational 先做，因为为什么会这样呢？你看第一个原因，你看如果我用 short wave 先有很多的 dissection， 然后我再做 Rotational 的时候呢，就很增加这个风险。有 dissection 可以做 Rotational， 但是风险就会增加。第二就是这个short wave 其实很难 deliver 的，有 guide extension 已经很好，但是有时候是 deliver 不到的。当然我也试过 Rotational fail， 卢主任看过 Rotational fail 过不去，然后我用 short wave 过去，然后搞定，也有这个情况。但是大部分的情况用了 Rotational 以后呢，再做这个 short wave 呢就简单容易很多 ，deliver 东西都会好很多。CSI 跟这个 short wave 也有一个特性，就是你可以搞定这个 calcium， 但是它不会有这个打磨的这个效果，就是让你过东西很容易。有时候 short wave 原 calcium 是打开了，但是过东西也是很麻烦的。但在什么情况我们不会做 Rotational first 呢？就是在这个 ostium， 这个 ostium 好像这个 LC 还有 ostium 的话呢 ，CSI 是我觉得比较好一点，因为你不一定要 push， 你pull 也可以磨定这个 calcium， 所以如果你做 CSI 做这个 ostium 的话，这个会比较容易控制，而且做的会比较好一点。因为它可以 bidirectional 嘛。另外，如果 concentric 的话，它这种呢比较大的血管 concentric 的话，这个 short wave 会有很好的效果，就好像我刚才说的病例一样。比如说那个血管 3.0， 这个 calcium 很厚的，就算用 2.0 的磨头，其实你也磨不了什么东西的。这种情况的话呢，就用short wave 会比较好一点。我们之前也试过有一个朋友的病例，就是3.0 的 concentric 的360度的 calcium， 他做了 Rotational， 然后就放时间，然后也是打不开，然后最后还是要 short wave 这样。所以一般的情况我们做法是 Rotational first， 然后在特殊的情况才会考虑用其他的工具，就比如说 osteo lesion 或者是些很大的 concentric lesion， 那就会选择这个 short wave。现在我有一个概念，就是 Rotational 只是 Rotational 是绝对不足够的。我觉得你 Rotational 完之后，一定要再做一点东西。做 NC balloon 最简单的就高压打多几下 cutting scoring balloon 或者是 short wave。short wave 呢，我们如果没有金钱的考量呢，我们就可能我听着 short wave， 但是一般来说我们不会这样做，我们先用 NC 测量一下，如果 NC 可以打开很好很顺还是什么的，我们就 NC 就算了，或者就 scoring balloon 就算了。因为 short wave 太贵，这个如果呢这个 NC 打不开或者这情况不是太好的话，我们就会加一个 short wave。这就是我们一般这样的做法，这是概念上的转变。我觉得只是 Rotational 是不够的。另外想说的话，其实我这两个是朋友来的 ，Rota 跟这个 short wave。 一般我们不会routinely这样 water shot 这样，但是如果没有 money 没有精致的考量的话，这个是一个绝配。比如说我举个病例说，就大家清楚，比如这个是一个 RC 的 lesion 啊，这个很弯曲的，这个我们过了，但是呢，球囊打不开啊，它很弯曲，这个而且是 eccentric 的，你看它在那一次，而且它动得很厉害啊，这个 RC 这个动得很厉害，所以我只敢用这个 1.25 的拨完了以后呢好一点，但是还是打不开。以前呢在做什么呢？就只能用这个 open balloon 就打40，然后加一个 cutting wire， 然后这个我发觉是如果没有 short wave 以前呢，这个是最厉害的方法了，就把它打开。但是这个有危险的，因为这个打到40，有时候加一个 cutting wire 它会破的。会 rupture 的这个血管，但是现在的做法呢，我就 1.25 或者 1.5 拨完之后，就可以送这个 short wave 之后是很容易送了，就再用球囊测试一下，开的好不好，如果好就算了，如果不好的话就用这个 short wave，除非特别的情况，你可以用大一点的波，但是这个大一点的波就有些情况就比较危险。为什么这样说呢？这个加起来一起用有什么好处呢？比如说这个病例，它一个很开发的 RC，AD 也是 disease 很开发的 ，left main 也有 disease。我要先做这个 RC 才敢做这个左边的，它还有 severe AS。那如果我要做这个，你要 1.75 或者 2.0 的波的话呢，这个病例的话，它一定会 bradycardia， 然后血压会掉，然后 AS 的病人他就很容易起不来了，就一直掉下去就会死了。所以我只敢用 1.5 的波完之后，是效果不好 ，stand 了这里还是开不好，然后我再用这个 short wave， 一个 short wave 不行，它没有精致的巧量，我就再放一个 short wave， 连续用2次这个 short wave 就把这个打开了，但整个 procedure 它就很安全，因为这个没有血压低啊，大家都有经验，如果 1.5 的波这个 RC 一般都没有事，但是你用2.0 的话，它一定会掉血压 bad 的。1.5 的话就60到70% 它会低的。如果普通的病人没问题，但是这个 severe AS 的就很麻烦了。那这样呢就很简单，很容易就把这个搞定了。然后其他的update 呢，就是这个 hemodynamic support 啦，现在support 可以做得很好啦。就这个 mechanical 的 support 做得很好，另外重要的 concept 我以前都不相信，但是现在慢慢就相信这个 halfway burr 了，其实很好用。我发觉了这个新的 water pull 之后，你可以看这个减出可以看得很清楚你就可以很好的控制你的力度，而且你做的越来越多之后，你就知道这个 water patient maximum 的力度可以去到哪里，再多的力它就会穿什么的，有了这个概念其实你过不了，到了 maximum 的力度过不了就过不了，其实你换一个球囊换一个 short wave 换一个 NC 如果在日本医生出的 paper 是 90% 会成功的。另外这个 differential speed motivation 呢也有一点用处。hemodynamic support 现在就以前就只能 inotrope IBP， 现在就 ECMO IBP， impeller 和 impeller 去做，你就其实完全 support 你，整个故事都已经完全不同了。比如说这个病例。真的病例就67岁 ACS APO 就 intubate 的，他 severe MLEF 才15%，最重要是这个 pulmonary hypertension RVSB 79的，他这个 RC 这样我们做打不开了，那就要做 Vibifurcation 了。在这种情况呢，也可以做到 Vibifurcation，以前这是不可能的，因为需要移掉这个 bony pressure 这么高，它就会立志死的了。但这个可以做。你这里看这个 left side 也是很开化的。那我们用这个 water 模头，在用完这个 RC 之后，我们在这个做完了，那你看 left side 是很开化的。我们呢可以一次过再做完这个CTO 啦 AD 这个 Vibifurcation 啦，那我就省钱了很多。如果我用 short wave， 我 short wave 去搞这个 RC 不一定搞得定，因为它不是很 concentric， 而且这个球囊我可能是 2.5， 那到我这个 AD 里，我又要再换另外2个 short wave 加起来就很贵了，而且它每次只能用8个 cycle， 这个好像比较长啊，这个 lesion。那我要用多少个 short wave 呢？还有这个费用。那如果我一个 Vibifurcation 就可以把完全2边做完了，那本身这个病例它用这个很多支架啊 mechanical support 已经很贵了，这个也要强调好。如果我再多几个 short wave 的话，这个就天价了做这个，所以这也是它的用处的好处。在这种情况的话，你可以窝完之后，然后看到哪里不好，开的不好 ，imaging 看的不好，然后再用这个 short wave， 因为大家都有这个经验，知道你 Vibifurcation 就算它很开化，有时候你用 1.5 啊 1.25 啊，只是窝完之后磨平了一点这个 calcium， 很多时候球囊都可以把它打得开，打得好的，好像这个病例一样。那就省钱很多了，所以呢，就是这个我们可以看到这个工具转变之后呢，你的临床的 skill 啊，还有这个想法啊，什么都经常改变。但是无论怎么变，我可以说，还是会有failure的，就是有所有的工具。最近我还是有的病人做不了，真的，Calcification 呢，就是还是我们最大的敌人啊！谢谢各位，这是我的分享啊。
谢谢 Lemho 哈，非常精彩哦！我们实在是很羡慕香港有这么多的这个 tour， 那个不过 tour 越多选择也是很麻烦的，我们就有一种这个 rota， 我不知道其他的这个专家对于这个 Dr. Lemho 的那个 lecture 有没有什么想要请问他的？我上次在听那个日本的专家，我在讲说这个 orbital 好像在 tortuous vessel 转弯很大的时候用 orbital 好像是蛮合适的。我不知道Dr. 对这一点有没有什么特别的 comment？
没有特别的 comment。我觉得不论是 Volta 或者 orbital 在转弯很多的地方的话，都会很危险的。最主要是看这个 wire， 如果 CSI 它的 wire 比较强 support 的，它会把这个弯的拉急，然后你的会很容易碰到这个血管壁的，这个力会容易破损的，不是绝对安全的，就算 Vibifurcation 也是。
林教授，谢谢你的演讲哦。像那个 shock wave 哈，对于那个我们under expanded 的那个 stent 那个钙化的很厉害 ，stent under expansion 这种效果好不好？特别是很 heavy 的 calcification， 那撑了以后扩张不是太好，那这个使用上效果怎么样？
大概5成到6成的情况都可以，不是100%。我们做的很多这种，他们 concern 就是你放了 stent 然后稍微会打烂这个 polymer 会不会有问题啊？或 stent 有什么问题？我们做了很多个，可以告诉你到现在没有一个回来，所以应该是可以的。效果的话不是一定成功，就是5、6成的病例都可以成功。好像刚才 给你看的话，28打不开的放去一个 cycle 它就打开了。我们是个 water based 人员，还是球囊打不开的，然后放这个 shockwave 就打开。另外一点呢，我们勇敢的试过一个球囊，好像我刚才给的那个病例，你看我一个 shockwave 8个 cycle 在同一点打不开，我再放一个 shockwave 进去，2个 shockwave 在同一点，再用8个 cycle 去打它，它开了。试过2、3次这种情况都会开。这个技巧用的技巧就是，你第一个 shockwave 不行之后呢，打不开就再用这个 NC 球囊去再打压一下，把这个 calcium 再压实一点啊，现在压实一点，然后再放第2个 shockwave。第2个 shockwave 通常我都会大胆一些，放大一点的 shockwave 球囊，然后这样增加这个效果。这个是理论上我们是个可以的，但是没有 paper， 也是只是我个人一点点的观点。其他都没有什么。还有一点就是 shockwave 会爆破的，这个很容易破。现在是第2代好了一点，以前的话基本上50% 会爆破的，这个要小心。但是没有出过什么问题，但是爆破容易有 dissection。
Dr. 我是林口长庚张旭恩，我2个问题跟你请教哈。第一个就是，其实刚刚看这个所谓 calcify 那 undilatable 的 stent， 其实我看到一些就是一些 case series， 好像在那个过程里面有一定比例的病人其实会出现 slow flow、no reflow， 发生 MI， 我不太能想象，因为在上面也没有特别 mention 这种 mechanism。你觉得有没有什么合理的解释这样的 lesion？比较容易发生 slow flow。那另外一点就是eccentric， 其实我在早先这个 shockwave 开始的时候是说这个其实 eccentric 的 calcify 并不是一个shockwave 很好的 indication。不过后来越来越多的这个我们看到一些 webinar 西方的那个好像也都说这个也可以 work 的。那我不晓得，比如说大概 eccentric 什么程度，你觉得在你的经验上还是可以 work？
谢谢，很好的问题，两个问题，第一个问题呢，这个 no reflow 的，我觉得发生的情况是这个 shockwave 破了，因为 shockwave 呢，你就算 negative 什么，很多时候呢，在球囊里有 air， 它如果破了有 air 流下去了，才会有这个 no reflow。你说这个球囊胀，然后做成 no reflow 这个我们大概用了300个 shockwave， 你说 shockwave 杜治这个 no reflow 的话是没有的，300个也没有一个。另外一些 paper 说这个 shockwave short， 然后这个有些 arrhythmia 这样的，这个也是没有的。它只有一个 report 的病例，他说的时候好像有一些 mechanical pacing 这样的，但是这个也是一个 misconception， 就是不会有事的。第二个问题不好意思，忘我怕我 eccentric 对 eccentric 这个呢，我说我个人的意见呢，好吧，有时候会所以我刚才就是说看你的彩数，真的看你的运数，有些病人可以，有些病人是不可以的，不是看这个 calcium 的什么 degree 180度230度或者怎么情况口度怎么，是看这个 calcium 的硬度，这个硬度 imaging 是看不起来的。我见过稍微搞这个 calcium load，也可以，在澳门有个朋友有一个case，他用这个稍微可以搞定，但是呢。为什么可以？为什么一些不可以呢？我个人的意见是觉得这个 calcium 的硬度，因为我们 OCT 看IVUS 看这个 calcium， 其实你有经验，你看的很多，你也有我这个感觉，有一些 calcium 是特别硬的，有一些 calcium 的 lesion 呢，它其实不硬的，虽然它很厚，但是它不硬。这种不硬的话呢，还是可以，但是一个很硬的怎么的，这个稍微就没有什么效果。如果是新的 paper， 西方那些他说很多，其实有机会你们用的时候，你就会 知道其实对不对，因为有时候他们做的病其实没有台湾做的这么复杂的，所以你们自己是这个感觉啊，就是最正常，不要期望太多，它的效果不是你想象的这么好。还有这个新的理论，就是他们说，就是 short 了之后，就算你现在没有看到裂啊什么的，有一些 micro fracture 啊，这样，这个他有 CT 给我看过是有发生的，但是效果就是看彩数，可以行可以不行，你估计不了，就是你估得到估不得到，就是你看这个 imaging 看这个估这个 calcium 是有多硬。你看你估不估得准？对，所以一般我都eccentric 的都，如果没有精致考虑的话，那就试一试吧。如果对，
好，谢谢任侯，和大家，
我有个问题，然后如果什么时候像 Austin Legion 什么时候会选择用 Rota 加 Shockwave？ 如果是因为前面太，那我必须要用 Rota 先去 Rota 以后才能放 Shockwave 的话，那我的 Rota burst 是一定要 adequate 的人，还是只要让 Shockwave 的靶论可以通过就好了，就可以执行这个针对 Austin Legion？
谢谢黄医师的问题。对，为什么我不会选 Volta 呢？就是，我说的 Osteo lesion 是 aortal Osteo lesion，就是好像 Osteo LC 啊、Osteo left main 这种就 CSI 比较好，或者稍微比较好。你可以想象一下，这个 Osteo LC、Osteo left main 基本都是4.0以上的血管。如果你要做 Modification， 你要2.0的磨头，但很开化，你2.0的磨头磨过去很难的，所以有时候要1.5，然后再2.0这样。所以呢，一般可以的话都 CSI， 因为难做。至于这个 shortwave 跟这个 Volta 这样，如果你先做 shortwave， 你把它 dissect 了。那也打不开，但是有 dissection 了，那你就没有选择了。在 osteo 里，如果再加 dissection， 你做 CSI 或者做 Modification 都很危险。shortwave 完之后在 CSI 是很危险的一件东西，因为 dissection 了，你个 CSI 再转的话就会出问题。所以的话，一般都是 CSI 或者 Modification first， 除非你很有信心这个 shortwave 一定可以把它开了。有时候你 IVUS imaging 你看到觉得这个 calcium 很分手，但是不是很厚，concentric 的，那 shortwave 打了开了就算了。我不知道我这样说可不可以
？OK， 好，谢谢 Professor Lemho 的一个分享啊，我想大家都对于这个 IVUS 非常的，台湾这边大家医生都觉得都非常好奇啦，很希望能赶快有那个 IVUS 来，希望我们未来也是会有一些经验累积之后呢，跟我们互相交流。谢谢。
希望不会太失望啊，不是你想象这么好的。
是，好，谢谢。好，谢谢 Professor Lemho。那接下来我想我们就进到那个三导管哦。三导管，我们今天下午是请到振兴医院的邓新一邓医师帮我们做一个应该是 complex 的一个 CTO case。新一有听得到吗？
有。
好，那我们今天下午这个下午的 section 那你就麻烦你帮我们做一个 CTO case。那在我们的这些 panel 就是吴承学吴医师那张其恩张主任那黄启宏黄主任跟那个曹天明曹主任那我们这上面来看你表演。那你是不是帮我们介绍一下你的 team 跟你的 case？
好的，好，那谢谢大家那今天我们是一个 ADCTO case 那我这边是庄医师跟张医师那等下请明奴帮我们讲一下这个 case。
有 slide 吗？好，那这个病人，各位前辈大家好。那我们今天这 case 林先生，他是一个71岁男性这是来自因为胸闷喘。那 underline 是之前有一个 CAD double vessel disease，2020年的时候 RCA 有做过 PCI， 然后还有一个 hypertension 跟 RI 的 past history。好，那下一张。好，那这是2021年的时候右边的，可以看到前段就有一点 plaque， 那可以看到后段 PDA 的部分，可以甚至看得到 collateral 灌回这个 LED 这样。
它 IVUS 没有动重来。
下一张。好，那这是左边的冠状动脉的造影，那可以看到 在 LED 的近端就是一个 CTO， 然后合并一些钙化这样子。然后也可以看到 Circ 自己就有 collateral 灌回到 LED 的远端。好，下一张。好，这是另外一个角度。那我们就可以看到 Circ 就 collateral 灌到 LED 的远端，那 LED 的近端就 CTO。好，下一张。
哦 ，slide 上面右边的那个应该是错误的，那个是早上的 case。懂了。
好，那这个是就是可以看到 cranial 的造影，可以看到这个 PDA 就有 collateral 到这个 LED 的远端。好，下一张。好，这是2021年10月的时候有试过这个 LED 的 CTO 的 PCI， 不过那时候就 fail 这样。好，下一张。然后那时候就在 RCA 近端有做个 POBA 这样子。好，下一张。好，那我们今天的 target 就是这个 LED CTO， 那这 CTO score 有 lens， 然后 calcification 跟 retry， 然后3分这样子。然后我们今天的 operator 是邓新义医师这样子。好，谢谢大家。
好的，我想这个 case 应该是也是蛮有趣的，那个还蛮明显的一个 collateral 哈，从 RCA 还有从 Circ 这个地方过来的 collateral 其实蛮少见的。那retry fail record case， 我不知道各位 panel 对于这 case 的 strategy 有没有什么想法？是不是请张主任先
？OK， 给我们再看一下这个left side 的 angel，
看一下今天的 angel， 看一下今天的 angel。
播一下。麦，你先第一张啊，刚刚那个啊 ，OK。
cranial view 还是
有加2张。再下一张。
张主任讲的这一张。
我想大概这个 case 可能是不是 anti-gray 有机会，可能一个大概还是 IVUS， 不过IVUS pullback 从 diagonal 或者是 septal， 那 septal 大概不太有机会，然后那 diagonal 是不是我们有机会看到真正看到的那个一丝 anti-gray flow 到底是不是真的 entry？ 那我想如果是的话，我想还是anti-gray 这个 approach 是合理。那如果那个不是，那就这 case 如果 retrograde 的选项的话，大概因为看起来这几个RV branch 是一定程度的 tortuous， 然后当然我想以现在的 wire 是 workable。那当然第一个RV branch 大概因为太接近那个CTO， 所以可能这个angle of attack 可能相对大一点。不过当然这个可能真正影像照相的时候看distal exit 或许还有一段，然后在另外一个 Circ 的 collateral 的来源看起来应该是最 distal 的这个 OM branch。那但是整个 course 我实在没有办法看得非常清楚，所以如果 IVUS 看entry 是这个还清楚的，我想还是很值得，就是 anti-gray 先走一段。那 overall 的 CTO 可能差不多3公分 around， 那中间下面那一段或许不是真的 total occlusion 才对。那如果真的entry 很难 identify，
有可能，
我想才考虑是 retrograde， 毕竟这个 collateral 大概都相当的tortuous， 我的想法。
那陈学医师，
我想这病人的话，他 RC 跟Circ比较起来，他还是 circumference dominant 的，所以他的 LED 的 collateral 可能还是大部分以 circumference supply 为主。那如果说你要做 RCA 的 retrograde 的话，那个 RCA 因为它比较小，它好像看起来可能还是要把它照清楚，到底是 PDA 到 septal 到 distal 的 LED， 还是说它是从 epicardial， 因为看起来好像是 epicardial， 那这些血管其实并没有说真的没有，看起来我觉得没有非常丰富啦，所以可能要把它照清楚。那如果看起来RCA回来 collateral 不好走的话，那这病人是 BED 还是 anti-gray？ 因为不晓得他几年前出来的时候到底是用哪些 device， 因为你 anti-gray 事实上 IVUS Guide 你可能还是有机会呢，就是那再加上现在新的 wire 可能还是有机会可以走，可以用 anti-gray 的方式来玩这个 CTO。
陶主任。
这个是蛮困难的 case 哈。那这个proximal cap 好像有点 ambiguous 哈，那就不是非常清楚。那个可能因为它旁边就有一条 diagonal branch 嘛，所以可以把那个看清楚。可能用 IVUS
这个 live 一下
entry point 那个弄清楚。那另外那条 wire 在 septal 的地方，也许可以用一个 double lumen caster 进来 support 那个 wire 来先 wiring 看看能不能进到那个 true lumen 里面。那如果这样可以的话，当然 integrate 就可以解决了。那如果真的不行的话，可能再走 retrograde。retrograde 看起来像那个 distal circ 到distal circ 进来的那个 collateral， 看起来好像有机会，有机会来做至少 kissing wire， 或者后续的一些 reverse cut 也可以从那边再试看看。不过 primary 可能还是先把 entry point 先弄清楚，如果可以的话 integrate 还是有希望。
黄主任对这个 case
其实我觉得大家看法都差不多，就是还是尝试着可以 identify integrate 的 entry point， 还是 integrate first。然后 retrograde 因为 collator 不是也是都是很 complex 的一个anatomy， 所以我也是觉得我个人也是会 prefer 是 integrate first。
不知道 Dr. 对这个 case 的 strategy 大概会是什么方法？
你要recall啊？没有recall吗
？Dr.
在。
也是，你这个 case 你看过这个 image 之后，你的 strategy 大概会是什么？
这个 JCT score 很高啊，这个很难做啊。你这个没有开口，这个 bone stem 有腮帮，然后 calcify 这个长度还这么长，估计这个 AD 也有这个一点弯曲，而且 fail 过一次。如果在台湾 fail 过一次，应该是很难的病例。如果做，其实你第一件事还是你可能 integrate 是很难做了，但是一定是 integrate preparation 啦，也是好像他做法这么样了。我觉得你把一个 wire 摆 diagonal， 然后Sasuke 或 Kusei 可能比较好一点，然后就不想了 Gaia Phi 这样就破出去，然后 integrate preparation 做好了去了多一点，肯定90%会 subintimal。然后如果你想试这个 parallel 就试，如果不想试的话就直接 retrograde 了。我不知道卢主任这经验会好一点，这个不知道你会怎么处理。
是我要是我的话，因为这已经飞流过了。刚刚飞流报 history 好像是1-2个月前飞流过一次，好像没有很久，所以我想我可能还是因为它 retrograde 那个 circ 远端那个 collateral 好像是还蛮直的啦，我还蛮明显的，所以就像刚刚张主任讲，如果那个 course 看得清楚的话，我们可能就 primary retrograde 先把 retrograde wire 放好。那其实上一次 try 的时候 integrate 好像已经走蛮长一段了，跟 retrograde 的血管好像很接近了。当然subintimal不晓得是不是，那有可能就是 integrate 我可能会走一点，然后干脆把 IVUS 塞到 integrate 的洞里面去看。当然这个 IVUS 可能头要剪一下，你进去看说到底那个洞进的是对或不对。那甚至这个 retrograde 的话，可能用 pinhole guiding， 可能要2个 guiding。好，我想大家 panel 的意见大概还是觉得 proximal cap 可能要看清楚了，然后 integrate 还是要试看看。那我不知道新一你现在目前你的 strategy 今天是会怎么做？
谢谢大家的意见哈。那我主要考量就是说，因为乒乓guiding的话会让操作比较复杂，所以我想尽量简单化。那简单化就是用一个guiding的话，那顺序就变得还蛮重要的。就是说，如果我先当然前后都要走一点，那我的 primary strategy 就是 kissing 这样 kissing wire。那如果我先走 retrograde 的话，那我的 guiding 里面就会有个 retrograde micro caster 嘛，那 NT 又会有一个 Sasuke， 那这样子就会很紧。那我主要考量是说，我的 wire integrate wire 再进去 CTO body 一段以后，我可能需要 IVUS 去 check 一下我的这个进去的头对不对？因为毕竟他之前 failure 过，就是怕说走到之前的 force 这样。所以我的想法是，我先 antegrade 走一段，确认好 IVUS 没问题之后，我就开始走这个 retro 的这个 circle 的 collateral 这样，然后最后用 kissing 这样。
好，我想这 strategy 应该也是可进可退。那你现在 IVUS 有 check 的嘛？哈。
对，那我们请伟杰帮我们看一下，我们刚刚第一次从 septal pull back， 然后第二次从 diagonal pull back 这样。
好，那我跟德伟老师解释。那其实学长从 LAD CTO 的 lesion 哦，那因为这个病人其实蛮特别，有一个很大的一个 septal 这样，那跟 diagonal， 那这两个其实 septal 跟 LAD-OS 感觉看LAD CTO entry point 好像几乎成90度，那 diagonal 可能是30度。那我们来看一下，其实从 IVUS 的这个 view 是不是可以给我们这样的 information 哦？那我们先来看一下第一次 run 去 identify 从septal distal pull back， 我们来看一下，其实这个是我们可以从 septal auto pull back 回来的样子哈。那到这边的时候，其实我们来看一下这边比较细看一点，就是这边回来，那这个地方在12点到3点钟的方向似乎有一个可能是我们的 reentry point， 我们再往回拉一点点，我们可以看到好像其实是一个就是 diagonal 的 wire 其实回来哈，所以刚刚跟新医师讨论的话，有可能第一个从这边其实是一个 reentry point， 那这是第一个。那第二个就是接下来我们 try 的去从LAD 的diagonal 去pull back 这个 lesion 哦，那请大家先看一下。那这个其实因为我们刚刚其实在septal branch 拉回来的时候，有点大概是在3点钟到12点钟的这个方向，所以其实我们把它的就是 IVUS 的镜头放在比较接近 diagonal 的 proximal 给拉回来。那我们可以看到就是说，可能其实反而是在3点钟到6点钟这个方向，可能其实是我们 LAD CTO 的reentry point， 所以我觉得可以，可是看起来其实这个 OS 好像其实没有到很硬仗，然后也许就是可以在整合这个3D 的方向，请学长再接下去做procedure 这样。
其实好像在 Angel 上面看到是有一点点这个往前像一个 dimple 的状况。我刚刚有一个角度，那或许 wire 摆在那边pull back 可以确认到底是不是那个dimple 的地方。
所以从 IVUS 从 diagonal 看得比较清楚是 LAD 的 OS。CTO proximal cap 可以看得到，是不是？
其实可能会比较大，可能是在我们那觉得是在这边这个地方，这个是
这 septal 过来的嘛？
这个 diagonal 进来 ，septal 这里 septal 我们这个 view 其实是从 septal pull back 这样。
对 ，septal pull back 嘛，
对。那我们觉得可能是一开始这边可能是一个 CTO 的 body， 然后接下来再pull back回来。
可是这12点钟方向那个是 CTO body。
对对，12点到3点钟方向，然后接下来就diagonal 的 wire 进来这样。那我把它pull back给老师看。
你从 IVUS 看它其实 proximal 是比较靠近 septal。
嗯。
哦，是哦。
看起来不太是这样。
是这样吗？
有点远，有点小的距离。
那这样看起来有点怪。那从 diagonal 看呢？可以再当
diagonal 看给老师看一下。diagonal 看其实它塞的没有很里面，学长再看一下。这是从 diagonal pull back， 然后 septal 的 wire 进来这样。
那从这里有这个影像有看到吗？在
我们觉得可能是3点钟方向。
也是有 channel。
对，3点钟方向，其实它近端是有 flow 的，
感觉是一个 channel， 不是一个
对，有一个 channel 在
一个 plaque， 不是一个 complete 的一个 plaque， 这样。
所以呢 ，Angel 我们可以再看一下，看起来其实是有点奇怪，因为这个你刚刚讲的 LAD 的那个地方对，
这样子
是在这个 septal 的对侧， 可是从 septal 拉回来，它又在它的旁边，所以看起来应该是不一样哦。你看这个 angio 它有2条 septal，你刚刚看到那个怀疑12点钟方向，那应该是另外一个 septal branch， 那应该不是。从 diagonal 回来那个应该看到可能还比较像，因为它在 septal 对侧啊。
可是我觉得那边其实有点复杂哈，跟就是我看等我一下，我看 septal 这边，其实在这个可能不是，可是它连进来这个地
另外一条
方，
septal 啊，不是啊，那是另外一条 septal， 哎 ，septal 距离那个洞可能太远了 ，septal 理论上应该看不到。
有可能是没有看到啊。
所以我那时候也是觉得这样子啦，那个地方可能 IVUS 因为有点远了，所以我那时候在想，就是说干脆我外进去，然后 IVUS 就直接从那个进去那条外去看，可能还比较清楚。当然这个只能见一点点啦，不能见太多，那头可能要剪。
因为我看你那个 pericardium 好像在那个左下角的位置嘛 ，pericardium， 所以 septum 的话可能应该在对侧，所以刚你看到从12点下来那个有可能是 septum。
可以帮我推一下。
但是从 diagonal 拉回来的比较像。
所以它的确从 IVUS 看是有个 dimper 啊，哎，对，有个小洞，它不是完全断平的，所以那个4点钟方向那个搞不好是可能是 LED 的 CTO plasma cap 的位置，对。
所以看星星你那个 LED 2.0下已经刚有下去了嘛，哈。
对，但是我觉得我很顺的感觉进到了之前的路。
对啊，没关系啊，你进到那个路之后，你就用 IVUS 去看看，说到底 plasma 是对的还是错的啊？
对，
我觉得可以考虑用这个。
对，我们等一下会直接进 IVUS 再看一次它出来的地方，这样。但我希望我的 wire 可以再压低一点，因为它这个上次的 case 碰到的问题就是说，它的 wire bias 哦，它很容易 wire 在 puncture 的时候，它的那个洞会非常靠diagonal侧。就是目前防头的荧幕上可以看到它一直偏比较上方，它 puncture 的那个点在 CTO proximal cap 的地方是比较偏diagonal侧。那因为之前就是会一直这样，然后我觉得我可能希望可以从这个针的dimple那个地方进去。那这个地方碰到的困难就是，我的 wire 的 curve 如果不够大会压不下来，没办法去碰到正中间。那如果我wire curve 做大的话，那我进了 CTO body 以后又很难处理这样。所以我这次的想法就是说，我让 Sasuke 就不放 diagonal， 让它放 septal， 希望让我攻击的角度可以更贴近这个比较贴近中间，就比较靠 septal 侧这样。不过目前看起来
有阻力吗？进去那个洞的时候？
没有，进去没有阻力。
所以你可以看刚那个 IVUS 它那个血管旁边其实钙化非常的厉害。
对。
所以你如果没有找到适合的洞，真正的洞的话，其实你根本就进不去，一定是有一个比较松软的地方让你进去。那你很可能就走到我们刚刚 IVUS 看到那个软的地方。如果说它是 CTO cap 的话，那这样当然就是更 OK 啦。所以最保险的方式就是你进去，然后我们 IVUS 看一下，如果是对的，那你就换成这个 microcaster 直接伸到那个里面去。然后你这时候就可以调整你刚刚的问题啊，把 wire 修好，然后再慢慢走一点。
好，
就 more perforation
按出来，对，
比较好。
我记得你从
我这边
记得你 RCA 的照相好像那个 LDA 可以到比较高的位置嘛，是不是？刚刚 Angel 看起来，你两边照相 Dura injection 的话，RCA 照相好像可以做一个不错的 guide 那方向，你 wire 的方向
最高好像是 circ 那个过来的，
是啊。
我再稍微探一下，看看，好像都会走到那个地方那我就先放着好了，然后我看一下 IVUS。好，那 IVUS。
另外呢，在这种情况呢，有一个想法，就不知道大家怎么看，因为他刚试过的了，所以这里怎么都会有一个 subintimal trap 的了。那如果我们用一个 filter XTA 或 XTL 肯定可以进去，最100%可能是进去上次试过的地方，然后我把这个 XTA 或者 XTL 在这个假仓，在这个以前试过的地方，然后用这个 Sasuke 就 根据这个 Field XTA，然后再 parallel wire 去找这个入口，找这个洞，可能会给用 diagonal 或者 septal 会容易一点，因为感觉好像如果你这个 Sasuke 放在 septal 也好 diagonal 也好，你的 wire 都偏了一点方向。如果你是同一条 wire 同族这样的话，你调这个位置可能会更容易一点。
对，这是很好的一个想法哦，就是用 double lumen microcaster 走在这个刚进去那个 Y 上面，然后再试另外一条 para Y。不过我想关键还是确定要用 image 确定说那一段是不是 LED 是如果是确定的话，我们更有把握了，就可以用这种方法。
对。
所以欣怡，你现在要 check IVUS 是不是？
对，我要 check IVUS，但是因为被Sasuke卡住了，所以我可能Sasuke要先退出来。对，我其实当时其实有考量这个啦，所以其实一开始就想要用8的，但是
你还是用拼，
因为他的脚非常的弯。
卡来卡去。
对，他脚非常弯，两边脚都很弯，所以就算用了 long shoes，他的那个弯还是没办法打直，那稍微拉一下他就会痛了，所以只好放弃8分去这样。那不过也没关系，我们现在就是把Sasuke退出来确定一次这样。
所以你还是用那个 anchoring 的方式把它夹出来嘛，哈。
对对。
因为我们上次在退 Sasuke 的时候，即使用 anchoring 它还是会把外拉出来。Sasuke 蛮滑的，他说要很小心。果然又发生了。
刚讲完。
真的。
对，他好像比想象中，对啊，抓不太住。
抓不太住。
对，抓不太住，真的抓不太住。对啊，我在光在拉的时候就这样。
因为其实不太重要，因为你如果是可能很大机会都要用 retrograde 搞定，如果 retrograde 搞定，你 VGH cut 的位置一定要离开这个 bifurcation 的，所以你这个 XTA 再进入一点也无所谓了。我意思再进入一点其实也无所谓，因为你根本不可能在这里做 VGH cut， 因为这个腮帮很重要，这个打根。
好吧，看起来好像太困难了，我可能要出来。
你们大家对那个 Sasuke 都没有这种经验，
还是
会拉出来还是很小心。它不像 Crusade， 我们以前只要夹住之后拉，其实都还蛮安全的。但是不知道为什么 Sasuke 可能 profile 小，夹的比较紧。
好，要把那个拉出来一点。
确实，外左头也有没有机会可以做？
这个你知道吗？还有这个。
其实我刚刚有想到 ADR 的 option 啊，就是，当你如果要 ADR 的话，你可能就，有几种做法啦。你跟外耳先走，你先 try 一下那个平行导丝走看看。那其实平行导丝，如果你做的 OK 的话，其实这种 case 也蛮有机会的。那你的 A plane 跟 B plane 互相矫正一下。那把那个平行导尽量导入那个出的 lumen， 这个其实也是可以做。那如你把 wire 走到 distal 有那个 retrograde 回来的 lumen 以后，你再去做 ADR， 你可以用小把弄代替 crossbows， 然后再进去做 reentry。不过他们看到 distal 血管好像它是个 tandem lesion 然后对，但是如果你能先进到前面的那个 lumen 里面，其实这个也可以考虑啦，对，也可以考虑，对。不过当然以现在我们在台湾的做法，希望能够那个 subintimal 的那个 length 越短越好，越短越好，对。所以就先这样试看看，idea 是个 option。
好啦。
就交流一下这个经验嘛。这种情况呢，我个人的经验就是，如果我把 wire 放在diagonal，然后去 puncture 这种没有 stem 的 CTO 的话，骨髓会比较好一点。但是如果呢，这个我 wire 是放在这个 AAD 里，然后再放这个 double lumen catheter， 就 Suzuki 比较好，因为它 deliverability possibility 比较好，我就可以把这个 Suzuki 推到最近，然后如果进不进去或者什么，通常这个位置就是你开始进入 subintimal 的地方，然后如果是同一条 wire 在 AD 这样，然后 parallel wire 的话 ，Suzuki 就好像比较好一点。
哎，现在新一点 anti-grade wire 是？
没有，我现在就是进 IVUS 进 diagonal， 然后看看这个刚刚的 Gaia 它的位置是在。
哦，说那条是 Gaia。
对 ，Gaia second。OK，
好。
我想看它的位置到底好不好这样。
现在我们看到的 IVUS 是现在你在做的吗？还是？
对，我现在，没有 IVUS 不是 IVUS 是之前的，
是之前的。
对，我现在 IVUS 进，看一下进不去，快点，我先把它，对，看一下可以。
哦，你 IVUS 折起来哦，
对，看到了，我先把它拉回来一点，因为它的改顶其实如果用，我是选3.0的 XB， 那因为它3.5的 XB 会一直朝向色壳，让我没办法。
这个盖尔的位置好像走了进去啊，好像进去了一些东西哦，进去。
对。
其实看起来很容易进去啊，就是不一定留着盖亚嘛。workhorse 的XTA 啊 ，sorry， 那个 FC 啊，这些大概都很容易，就看起来蛮容易进去。是不是这个地方先换 workhorse wire 看完之后，因为现在也没有 support。OK，
那我们 IVUS 进去了，铺背看看这条 wire 的位置好了。来录。
好像现在盖尔的位置很好啊，推一推，然后转一转，这个 tube 不像 septal 那个位置上可能可以。
对，好的，好，我们 live 看一下。
那这个 long view 在这里。
来，给我一下 live。
哦，你要再看 live。
对，我看一下 live。
你好像进去是对的。
好了，黄医师，我们帮我们解释一下。
等一下，新一还在看 live 哦，等一下。
好，稍等一下下。
好像是进去那个洞嘛。
对，这是 live。基本等一下再跟老师讲一下哈。
好，我们从这边来，这边我们来录一下。
record 是。
对，
好 ，OK。
不要打水，不要打水。好，停。
好，那我们先，你可以让他要这一个吗？你要前面那一灯，前面那一个比较漂亮。没有，就是上一个 pre diagonal 下面这个看一下，为什么不太会动？那上一个嘞？上一个有录到吗？
哪边很痛？然后动一下哈，要不然我那个脚帮他松一下，好吧？他好像绑太紧了。
控制权可以给我们吗？
我没有动啊，那个重接。
而且看起来好像还是从我们刚刚看到那个洞进去的啦，所以其实 information 就跟刚刚一样，没有更多。
它那个机器有点奇怪，其实就是刚刚学长在拉第一 round 的时候，就像老师讲，它其实钙化非常严重了，所以你可能必须只有一个地方 reentry point 进去啊。刚铺背的时候，其实就是从那个没有钙化那个地方，所以可能那一个地方是对的这样。
就从那里进去。
这个是比较对，它当掉了这。
我觉得
那可能就剩这个它机器当掉了，所以就刚刚那个剩下这个就是铺背一点点，在那个diagonal 地方铺背这样。
OK， 那我想你可能要关掉重开啊。我想就是你就2个 option 吧，一个就是走远一点，然后 IVUS 进去那个地方看一看那你如果确定是对的位置，那你就 integrate try 一下刚 Lempo 讲的这个 power wiring。那另外一个方式你就可以 try retrograde 啊。
好，
我觉得这个不用太期待，你可以 integrate 做完，因为这个其实很难的，因为你计算这个 CTO score 是4分的 CTO score 来的，然后试一试就行了，然后第2个方法才可以。觉得现在的正检很好听医师的 wire 是从出的，方才你现在换了，之前进去的入口是真的 AAD 的入口进去，可能进去以后才 subintimal 的。还有这一个你进去以后，然后放 Sasuke 在这里，然后 parallel wire，这个病例呢，它有一个很大的 island size 这个好像 retrograde 之前看的时候有一个很大的 island size，如果该了的话，你对着这个 island 加下去，可能会进入出入门都不一定用 parallel wire。以后试一下，不行就考虑 retrograde 了。但是这个 retrograde 就要很小心，因为 RC 不是很大。如果你用血做 retrograde，其实风险很大。
其实这条什么 wire 这条？
这个是 long cervical， 我是先把它放到刚刚嘎尔的位置。
它好像可以一直前进。如果它好像可以一直前进。
好，
你会拉回来？
没有，因为它那个洞其实很好进去，但是它会往下降，我不太确定。我等一下先放好以后，可能就会考虑就是滤缩柜也走一段这样。它大概到这边有点阻力这样。我是没有，我就稍微touch一下，我就感觉一下目前的外的阻力的状况。
那你可以要不 test 看距离前面到底多远啊？从可能
要不然我们从
照相吧
test 先好。掉出来。
这跟刚刚应该是不同的。
对，因为因为走到这个是我一开始有看到的一个collateral， 就是从 diagonal 旁边的小 septor 也连到这个地方，所以我再稍微调整一下，然后再照个相。
这里好像很好啊。
这里对，这里开始有一点阻力，我从这边照相好。那因为它会一直朝向色可，所以
对，
比较 cohesive。好，我们先准备照相。
朝向色格很好啊，从色格照回来更清楚啊。
啊，对，哈哈，好。照相。
喂，对，你好像其实这一段都是出入门啊。
方向好像不差哈。
对，如果是这样的话，你会不会放一个 male capita，然后再近一点啊？那你看到这个 island，这个对，那你如果放个 male capita，然后盖啊，然后
APT
这个 island 很大啊，这个你现在是在出入门，我觉得你是前一段都是在出入门，你
有可能啊，有可能。那你用 microcaster 下去，可能在 integrate 可以再试一阵子。
好。
对，因为这一段直，因为 AD 其实就是这个弯最麻烦，你过了这个弯之后，AD 一般都是比较直的了。这个，
对，希望看看有没有机会。但是就那个 LED 的 Rotational Cap， 在我的外耳下方好像就是有看到，感觉那边就一直有一些 enhance， 所以就吹屏，还是我直接进去应该可以。对。跟我说。回来。
你现在要换 microcaster 是不是？
对，我现在 APT 已经到 Legion。
我觉得呢，这个呢，我觉得找到这个因为我看到特尼斯用这个
APT 的时候，外耳就往前了。
跟这个 lateral view 啦，这个是我很喜欢用这两个 view 做这个 AD 的，在其他地方我看不见的，所以感觉到很开心。这个有人这个找到知音，
我剪一张可以吗？
用这两个做，
好像外又更前面了。
照相对，因为我在推 APT 的时候，外耳好像就自己往前了，感觉这样的话应该是有机会是至少是在这个 intraplate 这些关里面的当照相的。就是刚刚照相 tip 在 island 的地方，然后我看一下 distal target， 看起来应该是蛮直的。这个好像，
这个可能远的歪啊，会更容易让你走出错的方向，可能用比较硬的歪啊，因为这个是一条直路嘛，直接往下冲就可以，对准这个冲。
可能是之前走出来的地方，
对，
这边可能不太对。
更要用稍微硬一点的，对，你要
对，之前有路的话，用远的话呀，更容易做弯路。
你刚才是可能会不错，比较好控制。
照相，填一张，刚照相。
distal 的 island 看清楚一点，其实也是不容易，好像因为我最初看的时候以为它是很大的一个 island， 但是看清楚它 proximal 这个 island 的 proximal path 其实也是渐渐走上去的，好像曾经碰过有一些 dissection， 可能要穿过去都是要一些比较硬的 wire， 而且要很重才可以。手感。
目前这边有点阻力，我方向可能要调整一下。
感觉这个方向对。我们这边也是用这个方法去做的，ROVUS 然后这个 lateral，我发觉了，如果你再加一个网板挡这个 radiation 呢，在这个 lateral tube 里再加一块呢，就更理想，保护自己。
好，
这样都有前进哦。
不过好像是刚刚的路我看看哦。
你刚刚 test 一下，然后看看方向。
好。等一下，我再调一下，这好像是刚刚的路。
对，好像太 free 了哈。
这里很，
对啊，
这里很
刚刚的路
硬，
这个不太对，我可能会退后一点，从那个 island 刚起跑这样。
我觉得在这种情况，如果你的 wire 放，然后这个 micro capital，拉厚一点，给多一些 working space 给这个 wire， 可能会更容易找到这个，它更容易走得急一点。
我这边有点阻力，我可能会在这边尝试poke 看看。
像你们左下角那个是 raw map 吗？你们有在用吗？那个粉红色那个。
那个其实我很少用，
很
少用。对，
那感觉可以让你看到那个 distal 那个 vessel 的方向。那不要偏差太远。
我们偷偷看见这个东西，觉得很神奇还好，但是用完这试了一两次之后，就觉得这个其实好像没有什么用。
还是真的。
我好像有前进一点，然后跟刚刚路不太一样，我可能会再
我去照个相，
看看。
对。那以后不行，如果你好像离这个 island 很近，那就 Sasuke 进去 parallel wire 可能是最好的。对。
看起来还不错，
还不错啊，继续加油。
还可以，
继续往前。
侧面看一点偏下面，然后看碰到钙化了，我可能会稍微调一下。
可能直接进这个真枪，直接进这个出入门的机会不高。我们觉得如果可以就很开心，如果不可以也是预料之内吧。然后 Sasuke 走过去 parallel wire 扎，因为他好像这样多一点就是 contrasting 嘛，就是说可能之前这里有很多 dissection。
我建议，如果你再来 test， 可能还是从既然 right side 都有，可能 right side 照。我其实最近也做过类似的 case 呢，后来走了几个，后来发现哇，那个越照这个前面的 force lumen 越来越大。
还有最近呢，好像又这个 3D wiring 啊，这些其实不知道台湾用不用呢？这个 你们的经验是怎么
另外一个声音是 microcast 到 circumflex 的，从 microcast 照也可以，但是要打标准。
3D wiring 在我们台湾其实大家都是，我觉得不是很容易采用了，因为 3D wiring 的要件可能第一个还是要远端要看得非常清楚，相对的关系要搞得很清楚。当然角度就是我们两边 I 有成90度哦，那这样去调整。但是我觉得我们台湾的专家 retrograde 做得太厉害了，直接 retrograde 上去很快就做完了。
我觉得 Polaroid 的一个要件就是第一个就是说 AP， 我通常做法就是 AP 2条 wire 对准，那 overlap， 但一定有一条2条都不在 true lumen 嘛，2条 overlap， 然后再利用 lateral， 因为 lateral 就是那样上下的关系而已。你这 in AP view 是都对准了，那 lateral view 是那个上下的关系，所以在往上或往下 puncture 那个机会就会很高。
对，完全同意。
我目前 support 有点不够，所以我把 APT 再往前推一点。
我不知道今天 Boston 有没有准备 Judo 的 Y 或者是 Honye Y， 因为他之前他们有用他们的 CTO Y， 就是 Judo， 跟 Honye， 他们那个是有到6 gram 的，6 gram 的类似，就是 taper end 的，但是6 gram 的，因为我不知道大家的经验怎么样，因为我们这边常常那个 UV3 是往上。就是看亏 Pro 了12，那中间其实没有什么不愧是我们大概也是用到200T 啊，其他的比较少用。那他们有拿给我们试用一些 Judo， 觉得感觉还不错的。也许如果有觉得Gaia second 过不去，然后要再往上又不要太硬的话，也许 Judo 是6 gram 是一个可以的选择。那我有试过它的 Honye 的确还真的蛮滑的，而且蛮 train power 很强。它那个好像听说是4 gram 的。
其实你现在感觉是怎么样？
我现在有一点点阻力。
要换在
有阻力是好事啊，往有阻力的。
我可能有点到 distal cap， 我可能这边要决定要不要就是puncture。
我觉得你的方向还不错，你可以换那个 Gaia Third 的，也许可以考虑。
我也同意，应该可以换外的。
好，我稍微再照一次，确定一下。
哦，还有一点距离。
我再调一下。你帮我做个 reference。这边有点阻力。我看侧面它 contrast 好像会在distal cap 的地方有点 enhance 的那个。
侧面好像稍微低一点哦。
对，
就是你侧面稍微可能往上走一点，
对，
你这太高了。这阻力还是很大的。
我觉得这边
看起来很靠近了，
很像，但是之前其实也曾经这么靠近过。我觉得可能这个嘎雅的 curve 可能还是比较小。
我们刚刚诊断的 angel 好像 retrograde 的 flow 可以再看得更高一点。我不晓得是从 right side 照相，你要不要试试看，从另外一边照相，看看有没有办法更清楚这一段的 course。
右边照看看。你再 test 一下，看在不在？不在。34，侧面45。侧面40。黄头。
这个 Y 的 tip 跟那个 distal 那个 island 的距离哦，从 AP cranial view 看起来比较近，然后从 turator 的那个角度看起来好像比较远。这个其实我常觉得，如果是这种状况的话，常都是在 submitting 嘛。
对，
两个有一个调到了，另外一个就不会到，另外一个就会过头。所以我觉得可以试一下，干脆你就 try。或者是你要 upgrade 你的 Y 了，用这个稍微硬一点的试看看。
我的感觉跟Sean一样，就是我觉得这个应该是在之前的路。
我觉得以前纵使之前的，我觉得也不会差太远，所以你可以往前走。那一定是在 submitting 嘛，那你在最，那也是个 guide 嘛，你这样少数可以进去做 parallel 也可以。
好的，我先好，那我这边先照个相看看。不用出类头。
好像还可以啊，你就
对呀，好像很好。
勇敢的往前吧，行，
好吧。
那
我就把我的那个 APT 往前。
OK， 好，那欣怡你慢慢继续进行，那我们就先到胰岛管去。
好，谢谢大家。
好，等一下再回来。好，谢谢。那阿彩，蔡医师，我们现在进到你这个导管室哦。那今天那你们先介绍一下你的这个团队。
就是我是蔡全才，就是那个我旁边是王一总医师，然后那个 第二个助手是那个卢继廷总医师这样，然后就是那个王一总医师会报告那个今天的那个 case 是。好，王一
好，
听哦，
是。哦，好，那就各位老师、各位同事，大家好。那今天我们这 case 是一个60岁的一个男性，然后那他的那个主要的一个 underline 是有这个 hypertension 跟 dyslipidemia 这样子哦。那个这边，那他主要是当初就是因为胸闷，然后那有去蜀北，就是有做那个导管这样。好，那我们看一下下一张，下一张，好，那首先可以看到说右边其实它的血管就是钙化就是蛮严重了，那主要就是在那个 PDA 的部分，其实我们可以看到就是有一个很明显的一个 competing flow 这样子那这是主要，然后同时中段那边有一个很大的一个 calcium nodule 这样子 ，OK。好，那再下一张
APT 2.6。好，
那个右边的图有帮大家标示一下，就是主要从这个在 RCA 的 middle 部分一个钙化，然后很大的一个 calcium 的一个 nodule 这样子 ，OK。那就是 PDA 有一个 competing flow 这样子 ，OK。好，那再下一张。OK， 那左边的部分其实也是可以看到说 LAD 的 proximal 到 middle 啊，就是一个 diffuse 的一个 stenosis， 然后同时也是就是很明显的一个钙化这样子。那当时在外院的时候，其实就是 OCT 的那个catheter 推到这边的时候，其实也是就是整个就 prolapse， 就 device 就已经推不太下去这样子。OK， 好，那再下一张。OK， 那这个是从另外一个，就从这个 reverse spider 来看，也是可以看到说 RCA LAD 的 proximal to middle 一个很明显的一个diffuse 的一个钙化加上狭窄这样子。OK， 那OK 下一张OK， 那这个是circ的部分的话，其实也是可以看到说，其实在 proximal 部分也是有一个大概70%左右的一个狭窄这样子。然后，那我们今天主要处理的部分就是这 LAD 跟 RCA 的部分这样子。
好的，谢谢王总。那我们今天现在在台上的这个 panel 有吴承学医师那张其仁张主任那个。我左手边是曹殿敏曹主任跟这个黄启宏黄主任，还有我们来自香港的一个专家Dr.林那这个 case 看起来是就至少 RCA 跟这个 LAD 这两个 D 是有点钙化有点 RCA 是 calcium nodule。那这个要处理哪一段先那个蔡医师，你目前的 strategy 是打算要处理哪一边？
我先处理 LAD 这样，因为就是那个因为那个它 RC 有一段那个 PL 也是就是有一点functional total， 那我先处理 LAD， 那 LAD 如果我在处理 RC 的时候，我想要那个它的 PL 就是打开，那如果是 PL 打不开，就是那个走不过去的话，我可能从 LAD 要走日周会回去，就是那个把 PL 打开这样。
所以就是我在这里跟各位报告，上一次的在外院的做的 intervention 其实是从要做 RCA， 要做 RCA 的那条 PDA 看起来开口非常的厉害，那条 PDA。
对，它有一个 PL，
应该算 PDA PL 中间的一条还不算小的分支。那在那一次的他们的这个 manipulation 外好像一直都走不进那条那个 branch 里面。那后来在那个地方努力了一阵子之后，那个好像可能 cause 一些 dissection。那条 flow 就变得不太好，所以那一次的 procedure 其实停在那一边。但是因为这位病人大家可以看到 RCA middle 的地方 calcium nodule 是蛮明显的。那 LAD 好像也是 diffuse， 然后 tortuous， 然后 calcify 的一个利益群，所以看起来是两边可能都需要治疗。大家可以看把左边的那个 lesion， 左边的 image 放到 main screen 可以吗？
加2张。
来上一张，我看一下 RCA 的远端那个地方，
剪一张，
剪一张，对，就这个位置，那条血管，它是不是很大？可是好像也不小，所以如果能够把它救回来，当然是 OK。那刚刚蔡医师的意思是说，其实他远端的 collateral 是从 LAD 过来的，所以他想说，万一这么远的地方不往 manipulation 还是走到 force 的话， 那 retrograde 也是一个方法，所以他今天的 target 是想先做 LAD 的lesion啦，那是不是需要 rota 可能就要看之后的 image。我不知道，大家对这个 strategy 有没有什么想法？陈学，
我想大概就是说，当然如果我们讲到这个 PL， 可能很多人会觉得不用处理因为它就是有 contain flow 也不是很大。那 RCA 的这 middle 这个地方的话，看起来是 calcified nodule， 但是我们其实如果从 angio 很难去定量它的严重度，所以这可能还是要 image 去看说它到底这个它的狭窄程度到底多厉害因为它这个 calcified nodule 我想在处理上是非常困难的那当然首选刚刚 Dr.林讲过，可能就是以 rotablade 为主。那 LAD 的话，看起来大概势必看起来是要处理的因为它看起来是比较长的 lesion diffuse 的 calcification， 所以我想，目标可能今天还是以 LAD 为主。那这个 RCA 可能需要 image 以后才有办法决定它到底需不需要去处理它。
我想这个 RCA 这个当然看起来可能是一个 tight lesion 不过就 vessel size， 那以整个 vessel distribution， 我是会相对不会非常 aggressive 去处理它。如果前段还需要经过很多的这个花钱，然后这个处理前段的这个才能够完整 approach。那尤其是这个看起来可能连 stent 的基本上都有点size 太小了，所以现在是那个 branch， 我觉得应该是不大吧，是，所以我觉得可能 LAD 还是更关键的需要处理的 lesion。那至于当然刚刚讨论过，我们的这个处理钙化的 tool 是蛮有限的啦，除了 balloon cutting balloon 再来就是 rota， 那可能还是看看 image， 看看需要怎么处理。
对，这 RCA 我觉得可能摆最后了，因为那个它也有 collateral 嘛，但是这 RCA 如果你要放 stent 的 delivery 都会有问题，因为那个都是钙化，你会很痛苦，会很痛苦。那可能要用到钙 extension 啊，深插到很远的地方，那其实还不一定可以过得去。当然就是要慢慢 try， 但会花很多功夫，为了这条小血管，所以这条可能是摆在最后。如果病人还是有 symptom 或者是有比较大的 ischemic area 的话，那考虑。那 LAD 的话，我想就可以今天主要的 target， 那可能就是 image guide， 看看要不要做一些 atherectomy 的 procedure 这样子。
我也是觉得 LAD 是很 straightforward 的，这个 RCA 也麻烦。第一个置放不好置放，而且即使要置放也是要 metal jacket 的，几乎是冷冻的 standing。所以我也是觉得现在应该是先处理 LAD， 那 RCA 看 functional 评估还是怎么样的决定要不要处理。
是，谢谢王主任。我想各位 panel 的大家意见可能还是把重心放在 LAD 啊。我想请问Dr.林就是说像这 RCA 有点 torture 的时候，那种 calcium nodule 在你们香港的治疗方面，除了 rota 之外，你们会治疗其他的像 orbital 或者是这个 IVL？
都是 rota。这个非常同意各位专家的意见，应该先做 AD， 因为这个 RCA 的 Modification 很复杂。如果要处理这个 calcium nodule 的 Modification 的话，就用大的最小 1.75 2.0 吧。如果不是的话没有效果，所以如果用这个一定会血压低啊、白低啊这样。如果 AD 可以先搞定，然后再做会比较好一点。其实不是在不在香港或者什么，我个人经验还有跟其他各地不同的人交流，大家都一致认为，如果 calcium nodule 的话，最好还是 Modification。其他的你以为 CSI 可以做得到，但是我们 CSI 试完以后imaging OCT 看它其实没有用的，或者就也是有好幸运的话有一个血人的这个情况出现。short wave 的就基本上有改善，但是基本上都没有，除非你很幸运，这个 calcium nodule 只是一个 calcium， 但是不硬的 calcium nodule， 那才会成功。要不然的话，
这种 lesion 像凸出来的那种礁石 IVL 效果不好。
不好，一定不好，这个一定不好。而且你没有回头路，没有回头箭，你 short wave 研究，我给这个 OCT 你看过，会有机会有很多 dissection 的。
好的。
另外 CSI 完之后呢，可能会这个很粗糙啊，你就很难 deliver 东西的。
很粗糙就是了，表面会非常 rough 这样子。OK， 好。
因为它是在中间嘛，中间磨了你推了，它这样转过去的时候，不想这个全磨的，有一个螺丝营这样的，有时候很难过东西的，
还是没有办法非常 smooth 就是了。
对，不 smooth 的。
好的，好，那蔡医师，我想我们大家的那个意见好像都是还是先把 LED fix 好。那我不知道你今天的想法的做法还是目前的进度。
我同意大家的说法，但是那个 PL 的 plan 其实是 syringe， 它在外院的时候其实是那一条血管是跟上面的血管差不多一样大。那我现在就是同意大家的说法，就是那个我可能先弄 LED 这样。那我现在那个它 LED 就是比较麻烦，就是它有一点就是血管弯啊，然后钙化的分布 angio 下。其实我也不大会看，那就是所以就是我可能就是想要拉 IVUS 这样，但是就是刚刚 IVUS 推就是跟外院一样，就是我根本就推不进去。我推了一下，刚刚它其实那里有一个diagonal跟那个，我不知道大家有没有看到，就是它有一条diagonal 分叉那里 ，diagonal 跟 settle 的分叉那里，其实是那里还蛮tight的，我跟过外其实是那里很难过。对，所以就是我觉得他就是 IVUS 推不下去，可能就是卡在那里这样，所以就是我现在是要直接磨还是
小 balloon 还是直接做 rota？
对，它有，我刚刚过 wire， 就是他过这里的时候就卡住了，不是那么好过。然后刚刚推了 IVUS， 他应该有一张 IVUS。我是可以看说可以推到哪里，我就推到哪里，然后看 IVUS 有一点影像这样，可以请大家就是
好，可以吗？可以让我们看一下吗？
可以。
这是
这个
LED 吗？还是在 lemon？
对，这是 LED 从它刚刚比较 proximal LED 拉回来，进去可能只有5到8 mm 左右。那可能跟它 CAG 上面有点 compatible， 它其实是一个比较 diffuse 的一个 region， 然后是一个 eccentric， 那有钙化感觉很厚啊，很多有一些 calcium nodule， 那也可能是因为这样，它表面其实非常的粗糙，所以蔡医师其实推不太下去这样。那请大家
就是看大家要直接 rota 还是大家觉得要小火轮开一下？
张主任，这个状况你会直接就做 rota 了，还是保证开一下？
那如果病人经济上可行，我觉得是可以考虑 roll 了。那因为可能 final 的 expansion 还是会比较好一些吧。那如果小的不论这个地方dilate到底真的能有多少帮忙deliver， 如果光做这个地方，那不知道下面是完到这一段之下就都下不去，是吗？
对，我刚刚顶了一下。就是顶不下去，除非我在想说，另外一个方式是我用 guideliner 或是 Gazilla， 就是看可不可以推这样。但是我觉得它可能最终可能还是会卡在那个 septum 跟 diagonal 那个交接处，因为那里挖耳都很难过去。
这看起来就是好像 spiral 上下两侧都有钙化，我想当然转弯两侧钙化的地方，大概就真的很难推啊。
你现在这条 Y 是使用 blue 吗？
使用 black。
使用 black 啊？
对。
因为它你可以看到它外，其实它的那个血管的走向其实蛮 tortuous， 它是，所以它的 Y bias 在每一段它会贴向另外一边的。那这个，所以你刚开始看到的地方，你那个 Y 刚好贴在那个比较 rough 的那个飘形的一个 surface， 那个靠在那个位置，所以你东西会非常难进去。那这个其实我觉得比较好的方法还是做 rota 啦，因为它表面很粗糙你外都贴在那上面，你到时候什么 device 都会过不了。 你就算你把它打开，它其实狭窄可能也没有很厉害，但是你打开，打完之后它跑到中间，然后消下去，它又弹回来，它又贴在那个粗糙表面上，你还是很困难。
这种情况呢，就是为什么说 Volta 跟这个Shortwave 是好朋友了，因为这种情况，有时候我通常会放一个2.0的球囊过去，就用它的2个 marker 去做一个 stem boost， 然后看这个 wire 跟这个 calcium 的情况，如果是很 eccentric， 然后它再加2个 S1 的话，那可能我不会用1.5的 Volta， 因为有时候这种情况容易圈，可能会选1.25的，但是1.25的它就不能把所有的 calcium 取尽，可能我很高出1.25的过了，然后就 differential speed burn low speed burn 完之后，然后就 short wave， 这样就相对安全而且容易做了。这个1.5好像可以，但是看这2个弯的话，我不知道它这个 wire 跟这个 calcium 的关系是怎么样，这样看不清楚。但是如果你尝试一下放一个2.06和2.010的球囊，这里做一个 stem boost 的话，就可以看得很清楚这个 calcium 跟这个 wire 的关系是怎么样，然后就可以再决定你选这个 Volta patient 的 burr 的 size 了，因为一般这样的 AD 一定是3.5的，如果正常的情况一定是1.5或者1.75以上的 burr 头吧，但是这个有点担心哦。
请问 Dr.林像这种的 IVUS 过不去，是不是常常 IVL 也会过不了？
对，一定过不了，保证过不了。这个情况如果有拐弯的话，一定过不了。有 guide extension 会好很多，但是也是一定过不了。
所以蔡医师，你现在是用 ballooning 是不是？还是？
没有，我现在 APD 我要换 Rota wire。
OK，
你做一个 stem boost 可以看一下，你看看，这个是西门子，是不是？
这西门子的导管，它有 clear stem， 不过可能
可以试一下，然后看看这个 calcium 的程度，还跟这个 wire 的关系。如果 Volta 了，我个人的如果拐2个 S1 的话，它穿孔的机会很高的。
所以那大家如果真的要直接 Rota 的话，大家建议多大 burr？
所以刚刚Dr.林就在讲说这个，因为它是螺旋形的啦，所以还是有点危险啦，所以可能会考虑1.5吗？要是我可能会直接175，我不知道黄主任呢。
我倒觉得Dr.林那个建议很好，用把论去做stem boost 或 IC stem 这样子可以确定那个钙化的分布来选择那个对 Rota 的选择，burr 选择也许也是一个 choice。
我原则上也可能会1.75模了，但这个就是 low speed 小心的advanced burr， 当然会不会有 cut through 的那个状况，可能不一定都可以避免得掉。不过对我们来讲，如果是要得到一个比较够大的 lumen， 然后可以有效 delivery， 我觉得可能如果真的就像刚刚讲，经济上没有问题，我们当然可以更安全的。在我们在台湾做 Rota， 大概很多时候大概就是同时要 balance 这个效率跟cost 这2者，还有 safety 这件事情。这个我原则上大概会考虑1.75，那就是 low speed， 很慢的 advance。
陈雪，你会选多大？
我想，因为这 case 它就是主要目的，刚才看得到，连 APT 也很难推了，所以我想它最主要目的还是必须要做 debugging。那时候我们当然还是会选一个比较大的，那我基本上就是会选一个1.5的了，因为1.5的大部分的 lesion 就是1.5，就是都可以用一个，也许就可以用一个 burr 就可以解决了。那1.75就刚刚那个 他的后讲就是风险可能真的太高。那1.25你落塔完，你可能势必还要再选第二个 bird。所以如果是我的话，我选1.5的一个落塔 bird。
这个病例呢，我可能最大选到1.5，因为他拐了2个弯之后呢，他后面这段是闭准来的。如果1.75的 bird 有时候不小心再走过低一点，他这个闭准呢有一点担心，因为闭准的地方的血管会比较薄一点，然后他闭准的时候，有点担心。而且1.5的话，你可以 differential speed bird 啊，我们可以试啊，你先180这样过了，然后再慢慢的减出啊。但是这个其实我也想跟各位老师请教一下，真的你们一开始用低的粗度1.75这样过，是不是会据你的经验是不是更安全一点？因为这个我没有这样尝试过这样。
你是说用1.75？
对，用低粗过去，这样是不是会比较安全一点？
一般我个人的经验呢，就是如果说选稍微大一点的 bird 的话，可能转速一开始不能太低，因为转速又太低的话，那制造的那个 particle 可能会非常的粗哦，可能会比较容易 no reflow 啊。所以如果选大一点的 bird 的话，就是要像刚张主任讲，非常 gentle 的 advancement， 然后慢慢前进，希望一次不要磨出太多的 particle。那第二个就是要很小心控制你的 bird 的位置，因为有时候像今天早上那个蔡医师，另外一个蔡医师做用2.0的 bird 他那个 advance 如果太快的话，有时候就会很容易就超出这个实际上真的要磨的钙化的部分，如果走到远端，风险就真的更高了。那我个人是routine，就像刚您讲的，就是bird 过去之后，我们会用低速做 polish， 那我们可能用12万、13万这样子，就120、130，稍人的一个转速哦，那希望能够 create 更大的 debugging 的 area。我不知道张主任你们现在的 practice 在。
其实我有好长一段时间，一开始就可能低转速，可能是13、14。不过确实，如果像比较长、比较 diffuse， 那可能这个整个前后磨的时间还蛮长。那至于 safety， 我觉得是还蛮 safe 的。真的低转速，这个可能我印象中很久做 Rota 也没有放过 pacemaker， 因为这个我觉得跟这个日本医师的这个经验是很接近的，低转速不太很明显的会有厉害的 bradycardia， 会或者很快就
低转速比较不会 bradycardia。
是，那 slow flow 其实我也不太有这样的感觉，但是我觉得要磨完第一个 run 把整个都磨过一次，时间会比较长。那尤其是我们很慢的前进的状况，那这个到底影响如何，我不太能说。所以我现在会稍微在第一次的时候把速度快一点，可能15万、16万，那后续再降下来。不过就这个 case， 我还是会试试看，可能一开始就真的不要速度太快。
我明白你说的速度不快，就是前进速度不要太快。
对，前进的速度不是转速。
对啊，那我明白了。还有这个你会用 extra support wire 啊，还是floppy 的 water wire 的这种情况？
这个问题我们其实 wire bias 都是要有image之后，可能比较能够确定啊。因为像如果这个 case 用 extra support wire， 因为它血管其实是有点弯曲哦，有点 tortuous。那 extra support 的话，它那个 wire bias 可能会非常的 strong。会贴壁贴得很紧，那这时候 debugging 当然效果会更好，但是 perforation risk 就会高一些，所以我 personal 是会先用 floppy wire。当然，如果说有 image 来辅助的话，也有可能就会用 extra support wire。我不知道黄主任。
完全同意。
我也是用 floppy 这个 case。
我们一般都是用 floppy， 除非真的，尤其 tortuous 的话，基本都是 floppy。
哎，那蔡医师，你现在是？
我现在就剩开始磨了。那个，
那你要选多大份？
我想要选1.75。
1.75，好。好啊，那你就继续加油，赶快。
好，1.75。
我们现在要看你磨，嘿。
帮我点滴复让哦，点滴复让。
蔡医师你好，你的转出你会选多少呢？第一个弯。
我第一个让，我想说可不可以选18万转呢？
同意，完全同意。我们都是第一个弯一般都是18万转。
早上看那个Dr. 红叶，他都是20万转了，这个常规我看都是20。先 run 一个20万转的，先转过去再说，那后面再讲。
来吧。那大家会建议我应该要磨到哪里啊？我在想法是就是那个 Bifurcation 那里就好了。
对，我想也是在那个 diagonal 跟 septal 那个 Bifurcation 的地方，就不要再超过。
你再看一看这个形象，你最好磨之前做一个 angiogram， 不要去到闭颈的位置，因为这个病人他有一个闭颈的，有时候闭颈是 unpredictable 的，尤其比如说你打个 TNT 去的话，你再叫这个闭颈会更严重，然后磨起来这个不知道会有什么情况。这里这个影像看不清楚，但是之前的 angiogram 有一点闭颈的现象。对，看到了。
你是说 bridging 还是
bridging？ 对 ，bridging 可能是在 Bifurcation 的远端吧，
对，主要不要进这个 bridging 就可以了，前边都没问题。
我只要靠到那里就好。
蔡医师可能那个 guiding 我一直看了几次，好像都有 wedge 在那个
guiding 顶得很紧，
稍微
是。等一下我那个什么，就是 rotor bar 就是到位的时候，我再稍微松一下这样，因为我之前经验就是没有顶紧，就是我等一下 rotor bar 就是推了一下，它就会就是开始往后掉。好，现在。
这个是 water pole 吗？
再慢一点。
这个是真的 water pole 吗？
不是，这是旧的。
Link，
小胖，我想要看那个。
如果是 water pole 的话，做这种情况就非常之好了。你可以看到这个三角形，它如果点出的话，你就停往后拉一下，然后再试，这样就。
我想要看那个数字，你要不要再进来一点？
很容易。
还是你往后退？
刚才我们讨论的就是慢慢推进这个情况，就更受控。
下来一点。好，差不多，好。我用单眼镜。对，你用那个，对。
蔡医师，我们看你 rota 一个 run， 我们再转走。
好。其他新学长没进度吗？
有，他在等你啊，你赶快。
好。他在等我，他可以先了。好，
那他等着看你，
等着看完，好，
就起跑点。
那我就开始磨了。那好，高速。
感觉在那个地方有点阻力哦。
对。
有降速吗？
不是，没有降一点点。
所以你现在16万转？
现在18万。
18万哦，好。
对。
可能将来你们有 shortwave 之后就不用这么辛苦了，就1.5，过去然后就再加一个 shortwave， 然后就
现在 shortwave 在香港，它下去 price 大概多少？
它有2个公营的跟这私立的有一点价钱的距离，我想可不可以这样在这里说，比这个沃特贵，比这个沃特贵。
比如它贵嘛，
对，
贵到3倍。
公立是18800港币吧？
对，18800，那大概。
私立是比较贵，而且每个地方都不同，好像印度是3万美金，澳洲也是这样。
3万美金哦，3000美金。
3000。
对。你卡住了吗？
我卡住了，但是有出来。
刚前进的太快还是？我们在聊天。
我顶了一下，他就过了。
我也觉得这就是刚刚我觉得不要真的这么顶着，就是 touch 的它，那真的 apply 了一定程度，它就会往前 advance 一点。
好，
尤其是有转弯的，你这个顶得太紧，它一下子过去了就 stuck。
等一下，帮我wire往前送。好，wire往前送。好，可以，好，可以。那帮我压着，我要，不是，我要前进，我要再磨一次。好，那。
这个其实是一个很高难度、很高风险的病例，所以都说其实台湾 Modification 真的不用说什么，已经是世界 first class 了。
那阿才你要降速吗？蔡医师。所以这是 policy run 是？
对，14万了。
14万 ，OK， 好。
那我出来了。
你 test 一下看有没有破，有没有破我们就走了。
刚刚看是没有破了。
我看起来很好，对，好的，恭喜你，我们就好，阿才，那今天就非常谢谢你的一个 demo 了我想这 case 录完之后应该会非常漂亮。好，那我们就先转到3导管。
好。
欣怡我们回来了，我们等一下应该没有 closing 的，所以在 closing 之前
没关系，我们一般的退好了。
一般退。OK。
对。
那你们讲一下你的进度。
基本上没什么进度啊。
你的外刚不是已经？
我唯一的进度就是确定刚刚是在 force。
你怎么确定你有看 IVUS 是？
就是我稍微再勇敢的往前，对，但是看起来就是我刚刚其实有试着pump的不同，就是看pump不同的点啊，但是不是很顺利。这个就是我们刚刚目前外的地方是刚刚走的 force 点。
对。可是
那我刚刚有试过，往前一下。
你有没有说感觉是哪个地方出去，还是说
这个地方是我刚刚试图就是pump比较低一点
的位置？
对，但是这是 concrete pore，所以虽然说胖进去，但是它其实它会走直直的，它就是往3点钟一直走，它没办法转弯，所以我现在可能再试试看，大家谁可能看看可不可以降下来这样，但是
你这个洞是对的吗？你这个放进去这个
这不知道，但是因为它如果不这样胖，它就是会一直走到刚刚的那边。刚刚那边可能一开始是对的啦，
一开始是对的。
对，就目前看到的这个 Angel，
那一开始是对的，那你现在的就是错的啊。
是，
但是因为刚刚那个就是很容易，就是走到这后面大概都错了啦。
那你们可以看一下。
我的近端就是跟近端看起来，如果走刚刚的路跟近端差不多。
啊？
像你说这个 concrete 这个，
不是我的意思是说，
看是
你们刚才 second 已经走得很远了嘛，对不对？你走了进去，我看至少4公分以上了。
对。
那大概就要4公分，那4公分你可以 IVUS 进去看一下你近端到底对不对啊？你如果是对的，你就不用再试别的位置啦。
好，但是因为我就是它洞那个就是刚刚很靠diagonal的那个路哈，很容易就进去。
对。
所以应该就是跟一开始看那个 IVUS 应该是差不多的，除非我就是要把 IVUS 塞进去那个路那个
塞进去那个地方看一下，否则你现在目前这个下面的地方，你就是假设那个是错的，不是吗？那到底是哪个？一定是有一个才对，一个错吧？
好，
这2个都是对的。
好，我等下确认一下。
有点快。
但是我想说放不同的洞看看有没有机会，不过好像还是很困难。
卢主任，我有点事，我今天就先跟各位说声再见了。还有邓医师，继续加油，会继续为你加油的，就算不是，对，
好，谢谢，
再见，各位专家，很高兴，很荣幸可以在这里再跟大家交流。我今天也学了很多东西，谢谢各位。
谢谢，我们时间其实也差不多，准备要 closing 了。好，因为我觉得可以在这里 IVUS 看一下算了。
好 ，OK。先退出来，我走一点再看好了。
这个应该很重要，因为就算你 retrograde 回来，你还是得弄清楚那个方向。那尤其是那个 diagonal 很大，你不要 lost 掉。所以已经走很远了，应该无论如何善用它，而且从collateral 的这个看起来，应该方向不至于是错误太多的。无论如何留着，就算 retrograde 大概也是一个不错的指引了。
好的。那我就把它走远点，然后进个 IVUS 看一下。
这里应该可以
，IVUS 应该进得去啊。好，我看。
好，那就停在这里。
好，快点，欣，我们等你看完 IVUS，我们就要 closing。我们舍不得 closing。
比较困难的可能是一开始那个刚刚如果我们认定的 entry 是对的话，那里可能有钙化，到底进得了多少可能是问题啊。
就是那个给我 IVUS。IVUS。这个。等一下，我这个可能有3公分，这个大概只有是我剪下。剪刀。 好，现在这个
知道卢主任常常剪那个 IVUS 前端嘛，哈，那有没有什么值得跟大家 remind？因为有时候就是他这个那一段会很容易。
现在没有在做什么。
这个 case
应该还好。
我本来想说不要剪，看能不能进去看的，因为说是
现在
剪
有暂停，
这就剪掉了，那也不能
有吗？
因为剪掉之后，它的头就会变得比较粗糙，然后你那个 marker 就不见了，所以你其实不知道你的头，你只能看到那个镜头，那前面的 marker 不见，所以你在前进的时候，你就看到那个镜头往前走。那第一个就是如果就钙化哦，大概它就穿透力其实是不太好。那第二个就是说，刚刚张主任讲，他如果剪太多，他会 detach， 他就没有办法，他跟外相连的那个部分就太短了，很容易有时候你太用力的话，它会整个跑掉。所以我们一般现在目前是剪大概1公分了，1公分，也不能剪太多啊。
我不知道情况是。
哦，好像有顺利的进来，这剪掉1公分的嘛，哈。
来 left， 对。
好。
大家可以看看。
的确很偏的哈。
对。
好，那 IVUS 可以放在 main screen 吗 ？IVUS 的 image。OK， 好。哦。
好，我们铺背回来好了。对。对。
所以它非常的偏。
有没有从那个外耳铺背？
这样看起来在Tse-Min还是在 interpreg？
我等下，我刚好像看到真正的口嘞。好，来暂停 live 给我。
所以搞不好你刚刚看的放进去那个点也是对的，因为一个在北极，一个在北极。
对，因为这边我看这边倒有看到那个9点钟好像。
那好像还是对的啊，
我这里面是蛮偏的。
蛮偏的。
然后我现在铺背回来看一下。
哦，在这个地方就比较中间了，对。
对，这边比较中间，我看，但是它的出入门好像是在IVUS 9点钟的方向，我踩一下。9点钟的方向，那个好像是比较，这个其实才是这个地方。
这个
9点钟方向才是原本的 vessel 的出入门。那因为它在 ocean 地方有钙化，所以这个地方刚刚被挡到，看不太到。
你现在这个还是在 vessel structure 里面呢，你这整个都还是在里面呢。
这边蛮
偏的。
对。因为它的血管
旁边有一条血管进来，那是 septal 吗？
看一下啊，这 septal 应该是在
最外面。
这是
septal 啊？
这才是 septal。12点钟那个。
对啊，下面的
应该是diagonal。
那是 diagonal septal。
12点钟是diagonal，我有放外了。
那你再往下去走，再走下去
一点，
要下来一点。
这
里有小分支啊，这个分支是
小分支
septal 还是 diagonal？ 所以这条其实蛮重要的，
我看看
是连到你的 channel 里面呢。
对，代表这个地方都还是处的。
对，
它应该是有个小 collector。那时候我看到小 collector 过来，所以我想近端这边好像还可以，所以
对，近端是对的，
对。但是再往 distal 一点，它就是很像是血管的那个 structure， 就从9点钟它会绕到3点钟去，就像它会绕到3点钟去。
你就跑。
所以这个地方可能就是准备进什么一体码的地方了。所以可能 repuncture 可能要从这2个来找我看。 那
你可以用
对，
你刚刚有到 Sasuke 的
这
方
目前这个 IVUS 看到是2点钟方向有看到 lumen 啊，有一个 lumen 隔空有个 space 在那边，不知道大家有没有看到？
对，
那个地方
可以
可能
辨别它的方位吗？
辨别，因为它整个好像外来应该是有旋转的，
有旋转哦，
所以比较困难。对，比较困难。对，但是我觉得这个就是比较偏，就是在这个地方，可以在这一段重新再旁看看。
IVUS 摆着 microcaster 你这个不行，
不好用
啊，不然就只有用 Streamline。
还是转 retrograde， 至少进度是对的，有点对，还是有点进度。retrograde 过来其实会给你很好的一个 landmark。理论上，它这个 lumen 可能是在那个 branch 的对侧啦，所以在那个在你看到那个进道比较偏的位置那个地方，可以从那边 puncture， 然后在 diagonal 的对侧，可能可以用这个方式来攀看看。不过当然这个是尝试一个方法之一啦。那比较 permission 可能还是 retrograde 比较快。
retrograde 比较快，
对，会比较快，把 Y 留着，然后 retrograde 可能会比较快。
好，谢谢。
好，那今天就非常的谢谢新一还有蔡医师这个很好的一个 demonstration 哦。今天其实我想我们这 ROVUS 是在台北荣总应该算是第2次比较。尤其跟日本的Honye Dr.来一起连线我们做这个 ROVUS。那这个 ROVUS 其实从上一届到这一届，我们选的一些 case 尤其今天的 case 包括 complete 的 CTO case 跟这个 DOTA 的一个 case 我想都是一个蛮 typical， 但也不是说非常难，但是其实我觉得都非常有教育意义的一个 case 那我觉得2个 operator， 4位 operator 做的其实也是中规中矩。那今天其实也非常谢谢这个 Boston 公司的一个安排那谢谢我们在座的各位他们的好朋友黄主任、张主任陈雪那谢谢大家能够在这个 table 上这个平台上面那畅所欲言。那我觉得还有国外的专家那我包括我自己其实就学得非常的多那这些 case 我觉得能够为我们这个 daily 的这个 practice 带有一个很大的一个帮助那今天就谢谢大家的一个参加。我们今天的节目就到这边，好，谢谢。